Hello, my name is Jim McVeigh. On behalf of the Substance Use and Associated Behaviours Research Group at Manchester Metropolitan University and Anabolic Steroids UK, welcome to the conference, The Public Health Implications of Anabolic Androgenic Steroid Use. And thank you to the 300 plus delegates for joining us today. I think you'll enjoy and find today really interesting, and thank you for your support in registering and joining. I'd like to start by thanking Manchester Metropolitan University for their support in making today happen. I'd also like to thank our three major sponsors for the financial support which has made today possible. That's Exchange Supplies, Orion Medical Supplies and Vernicare Exchange. Thank you so much for your commitment and your support. I'd also like to thank a range of supporters, the drug treatment providers across the UK for their input and for promoting today's event. A number of individuals such as Michael Linnell, Martin Sissons and Margaret Fluke for their support in pulling the day together. And of course the technical team, Camille, Bartosz and Kasia, for all the preparation on making today happen, and for the delivery and what I'm sure will be a successful delivery on the day of this event, and in helping us to get this online for people to see after the event. I'd also like to thank members of the conference steering group for their input at the early stages of development in their help and advice in bringing this together. I should point out, don't worry if you can't watch continuously for the full next 8 hours. There'll be the occasional 10-minute breaks, but I do appreciate that many of you won't be able to spend the next 8 hours with us. The event will be is being recorded and will be available on www.anabolicsteroids.org.uk shortly after the event. And anyone who's missed it today, or if you want to catch up on any of the specific presentations, you can just log on there and see all the content of the day. And this is an exciting time for research in this area in the UK. We have an unprecedented amount of high quality research being conducted and being published at the moment. In the UK, Anabolic Steroids UK is bringing together this data and this evidence and helping to bring together UK academics in the field, together with leading international experts and researchers and the UK practitioners, to share evidence, to exchange experience and inform best practice. The UK is in a unique position of strength in having so many needle and syringe program practitioners with an interest in an active engagement with anabolic androgenic steroid users. We need to build on this and provide them with the best evidence that we can. Ultimately, we aim to benefit the users and those contemplating the use and those affected by other people's use of anabolic androgenic steroids and other associated image and performance enhancing drugs. And we aim to do that by informing best practice and providing robust evidence. One of the key areas of work in the coming year will be the development of prevalence estimates, and this is something that we've never had before in the United Kingdom. It's a collaborative piece of work involving many different individuals and organisations, the iPed Info Group, Anabolic Steroids UK, Public Health Wales, and their input at all levels of this process. Expertise from Liverpool John Moores University, the University of Birmingham, Greater Glasgow and Clyde NHS and Manchester Met are all working collaboratively with the common aim of being able to identify what the true levels of anabolic steroid use are in the UK, and as much as we can about that population to help inform how best to provide, in particular, harm reduction services. For the conference today, I'd really like to thank the speakers. The format that we've used today is the best that we can under these circumstances in the times of COVID. It also has the advantage of being really cost effective. It means that we don't have to charge delegate fees, and we're able to provide input from speakers from across the UK, across wider Europe, the Middle East, United States and Australia. And so in that respect, it's a real advantage being able to do that at a minimal cost and no cost to the delegates. There are obviously disadvantages. It's a real pain for the speakers. It's much more time consuming, more stressful, and I'm really grateful for them for the preparation and putting their presentation together, and then making themselves available for the question and answer sessions today. Another disadvantage is you can probably hear my sick bulldog grunting in the background. It's the whole idea of working from home and the new work environment. I apologise for any interruptions from my dog. Obviously, another disadvantage is you don't have the same level of interaction that you would do at a conference, where you get to mingle with other delegates and interact with the speakers. But on balance, I think it's a great way of disseminating research and evidence to a large number of interested people and free of charge to them. So we've decided to do this again next year. But for 2021, we'll be doing it with colleagues from the University of Queensland. And in addition to the live programme being delivered to Australian time, there'll be a specific theme developed to ensure that the conference has its own character and the format and content remains fresh. We'll disseminate further information from this, in particular from the anabolicsteroids.org.uk website, and you can sign up to newsletters from there, and we'll keep you informed of developments of the new conference. But just because you can't be here in the same room as the speakers doesn't mean to say you have to be a passive audience. There'll be an opportunity to ask questions to each of the speakers, and also the chance to vote for the questions that you would like to see asked. If you take a quick look at the conference platform display, if you look on the left hand side of your screen, if you're on a computer, or on the top of it on a mobile device, you'll see the chat feature, a chat button there. That's where you ask the questions. There's also a programme button there where you can see what's coming up next. And you can also get to vote up the questions that you want asked of the speakers by doing the thumbs up indicator on there. So please do participate in the day. You'll see that the day is split into 5 sessions. I won't go into details of all the speakers. There's information there on the programme and on the anabolicsteroids.org.uk website. But just to say that the sessions are divided into themes. The first one being around harms, secondly around societal backdrop and the epidemiology, including a case study from the Middle East. Then we'll be looking at different populations of users, or the typology, about women users, and about the different points on the spectrum of different anabolic steroid users, and the different issues that they may have. We'll then go on to look at treatment interventions that are in place and the evidence to support the development of those interventions. Then we'll have a conversation between William Llewellyn excuse me, and the author of Anabolics and a great advocate of harm reduction, and Joe Keane, UK practitioner and powerlifter. There'll be a question and answer session at the end of each of these sessions, and finally we'll have Ian Boardley summing up with a few closing remarks. I'll leave it there. Thank you for joining us and enjoy the day.
Good morning. My name is Dr. Harrison Pope from Harvard Medical School in Boston in the United States. And today I'm going to talk about what science knows at this point about the long-term adverse effects of anabolic androgenic steroid use. To begin with, let me give you a little bit of historical background. As many of you may know, testosterone, which is nature's own anabolic steroid, so to speak, was first isolated in Nazi Germany back in the late 30s, and over the next decade or so, hundreds of synthetic analogs of testosterone were created, thereby creating the family of hormones that we now know as the anabolic androgenic steroids, or AAS. By the 1950s, athletes had discovered that these drugs would allow them to gain levels of muscularity and performance superior to that of any natural man. And steroids subsequently swept through the elite athletic world, through the Olympics, competition, bodybuilding, etc., for the next several decades. But it was not until the 1980s that we see steroids beginning to percolate out of the elite athletic world and onto the streets, so to speak. This transition began in the 80s in the United States, but more like the 90s in the UK and other British Commonwealth countries. So the effect of that is that even the oldest of these general population AAS users, men who first tried steroids when they were in their 20s in the 1980s or 1990s, those men are still now only in their 40s and 50s. So it is only recently that there have been enough steroid users who were old enough that we've been able to actually study the long-term effects of these drugs. So what long-term adverse effects of anabolic steroids should we be the most concerned about? Well, in first place, I would rank the cardiovascular effects as the most serious cause of concern, followed probably in second place by the neuroendocrine effects, specifically the fact that many men develop prolonged hypogonadism, or inability to manufacture enough testosterone of their own when withdrawing from steroids. Then perhaps in third place would be the psychiatric effects, especially major depressive disorders, which may accompany hypogonadism. And then finally, a whole string of effects on other organ systems of the body, and in particular, the possibility that steroids may have neurotoxicity. And you'll be hearing about that at the end of this session from one of the world's experts in this field, Dr. Astrid Bjornebekk. But first, let me discuss in some detail the cardiac effects, because in recent years, we conducted the largest study that has ever been done looking systematically at cardiovascular toxicity of steroids in men recruited in the vicinity of Boston in the United States. I recruited 86 men between the ages of 34 and 54 who had used anabolic steroids for at least 2 years out of their lives, and a comparison group of 54 otherwise similar weightlifters, same age, same gyms, etc., but who reported no lifetime use of steroids at all. And we did a detailed cardiac workup on these men and demonstrated 2 significant long-term adverse effects. The first of these, as you can see here, is dilated cardiomyopathy. In cardiomyopathy, the heart becomes inefficient in its ability to do a good, clean, forceful contraction, and also impaired in its ability to fill back up with blood in preparation for the next beat. We assess cardiomyopathy using echocardiography, which is rather like an ultrasound, where an instrument can record the impulses from the heart through the chest wall. And here is what the output looks like. And you can see the right atrium, right ventricle, and left ventricle as they are detected by the machine. And here is an example of output from the machine. On the top, we see a tracing from a non-steroid user. As you can see, the lines of the graph are all closely superimposed on one another in a coherent bump with a height that goes up to the 58 mark. That means that all of the different aspects of the heart are contracting in a synchronous, coherent fashion, which is highlighted by the bright red ring on the left. So that this is a a good, clean, forceful beat that is expelling a lot of blood out into the aorta and into the peripheral vasculature. By contrast, on the bottom, we see the output from a steroid user. And there you can see that the various lines are not superimposed closely on each other, but are not nearly as well synchronized, so that this is a more flabby beat of the ventricle, as also shown in the ring on the left, which does not have the bright red highlighting, showing that the ventricle is not able to expel the blood as powerfully or as effectively in its beat as in the case of the non-steroid user. And this is the output showing the rate at which the heart fills back up as new blood is coming into it in preparation for the next beat. And on the upper tracing, which is a non-steroid user, you can see that there are high peaks and deep valleys, showing that the ventricle is rapidly filling up with blood, that it is rubbery and elastic and responsive, so that it fills up quickly with blood. That little blip midway with the A above it is where the atrium is contracting and sending its blood into the ventricle. On the bottom, you can see that the peaks and valleys are much less because the steroid user in the bottom has a more stiff ventricle that is not as responsive and doesn't fill up as efficiently, and has what is known as a slower diastolic tissue velocity. So translating that into actual numbers, this is a figure from the paper that we published a couple of years ago in the journal Circulation. On the top, we show the left ventricular ejection fraction, or the LVEF. And normally, when your ventricle contracts, it should expel at least 52% of its contents into the peripheral vasculature, and that is designated by the dotted red line. If you look at the non-users who had never used steroids in brown on the right side of the figure, you will see that their average LVEF was almost 60, and that virtually all of them, if you look at the little cloud of dots, virtually all of them were above 52, with only a couple of exceptions. By contrast, if you look at the 86 steroid users who are in the dark blue image on the left side of the graph, you can see that their average was actually below the 52, with a large number of them having abnormally low LVEF. But what is interesting is when you break this down into the users who are currently on steroids at the moment of evaluation, as compared to those who, for one reason or another, are off their cycle or who had stopped steroids at some point in the past, you see that the left ventricular ejection fraction is on average much worse in the people who are currently taking steroids, whereas the people who are off steroids seem to have partially recovered with their mean LVEF almost as great as the non-steroid using weightlifters on the right. But you can still see that there are several of them who are quite a ways below normal, even after having come off of steroids. So in short, it appears that when you're taking steroids, your ventricle is very likely to become impaired in its ability to pump an adequate amount of blood out with each beat. But that if you stop your steroids, you appear to recover to a considerable extent, but maybe not quite to the point where you are back to the level of the non-steroid using weightlifters. So now, turning to the lower image, we're looking here at the early diastolic left ventricular tissue velocity, or diastolic tissue velocity for short. Now here, that is measured in the rate in terms of centimeters per second at which the wall of the ventricle expands as it is filling up with blood. And the diastolic tissue velocity should be at least 8 or 9, and that is designated again by the dotted red line indicating the threshold of the normal range. Once again, if we look at the non-steroid using weightlifters on the far right in brown, you can see that virtually all of them have a diastolic tissue velocity above normal, with many of them being well above normal, up with 10, 12, even 14 centimeters per second of speed, so that their ventricles are very flexible and fill rapidly and efficiently with blood. By comparison, the steroid users in blue on the far left are barely above normal on average, with many of them going well below the normal value of 8.5 or 9. And once again, you see that the people currently taking steroids, the ones who are on drug, there are quite a number of them who are well below 8, with some going all the way down to 6 or 5 or even 4 centimeters per second, which is quite pathological. And again, in the ones who are no longer taking steroids at the time of evaluation, you can see that there's some recovery, that they have improved to some degree relative to the people currently taking steroids, but they still have not recovered to the level of the non-steroid using weightlifters. So cardiomyopathy is a significant effect of these drugs, and fortunately it appears to be at least partially reversible, although the diastolic tissue velocity, the filling up with blood, appears to be maybe only partially reversible. And with advancing age, this is a disorder that could lead to shortness of breath or difficulty with carrying out exercise. Also in our study, we performed coronary computed tomography angiography looking for atherosclerotic plaque in the coronary arteries, namely for hardening of the arteries in the heart, which, as you know, would increase the risk of getting a heart attack. We did this by injecting the subject with a contrast agent, which could be seen by the X-rays in the CAT scanner, and then watching it as it coursed through his coronary arteries. Here is an example of what the image looks like. The arrow is pointing out a little area of atherosclerotic plaque, which, as you can see, is probably blockading at least 50% of that artery that is otherwise relatively open. And with computed tomography, you can assess the degree of this plaque throughout all of the various arteries in the heart and quantify the level of pathology. Here we have a graph of or a scatter plot, if you will, of the levels of plaque that we found in the hearts of the 86 steroid users. As you can see, there were quite a number of them who had no atherosclerotic plaque at all, even some of the ones who had used steroids for as much as 10 years or more. However, there were quite a number of them who did have substantial amounts of plaque, and as you can see, that was particularly prominent among the men who had more than 10 years of total steroid exposure under their belts, meaning that they were almost certainly at increased risk for having a heart attack. Interestingly, of the 86 men that I recruited in this study, 3 of the 86 men had had a heart attack prior to the age of 45. And very likely, as these men get older and get into their 60s and 70s, the risk of a premature heart attack or a premature stroke will get even greater. So now, turning to the number 2 ranking problem in my estimation, it is the problem of persistent hypogonadism, or failure to manufacture adequate amounts of testosterone. So if you are male, and slightly more than 98% of all steroid users are male, if you're male and you are injecting testosterone or testosterone analogs, be it decadorabalin or equipoise or anadrol or whatever steroids you may be taking, the hypothalamus in your brain sees all of these steroids coming in from the outside, and it concludes that we've got plenty of steroids on board, there's no need for us to manufacture any more, and accordingly, it secretes a hormone which signals the pituitary gland to stop making its sex hormones. And these hormones are called luteinizing hormone, LH, and follicle stimulating hormone, FSH, as you can see halfway down in the figure on the right. And the pituitary, responding to the hypothalamus, shuts down its production of LH, which normally tells the testis to manufacture testosterone, and shuts down FSH, which tells the testis to manufacture sperm cells. And accordingly, the testis, without the stimulation of the LH and FSH, falls asleep, so to speak, and shuts off the factory. And gradually, it shrinks in size, and if you then stop taking your steroids, especially if you stop taking them abruptly after many, many months of exposure, the testis cannot instantaneously wake up and resume making testosterone and sperm cells. And it may take weeks, and in some cases months, and in some cases years, and perhaps in some cases never, in terms of getting back to normal. This is a significant problem because with hypogonadism, men lose their sex drive, frequently lose erectile function, and also, in about 10% of cases, become quite seriously depressed, sometimes even to the point of getting suicidally depressed. And also, men who experience this withdrawal hypogonadism may be very tempted to quickly resume taking steroids in order to make the bad feelings go away, so that this can potentiate a steroid dependence syndrome where guys end up taking these drugs continuously without interruption, simply because they cannot tolerate the withdrawal. Now, this can be potentially treated by a skilled endocrinologist by administering human chorionic gonadotropin, which is a hormone that mimics the effects of LH and FSH, and it will help to wake the testis up faster than normal. And also a drug called clomiphene, which mimics the effects of the hypothalamic hormone, which in turn stimulates the pituitary. So if you are familiar with this, and regrettably there are not very many endocrinologists out there who see steroid users, but if you happen to be one who is skilled in this area, by juggling these different hormones, you can mitigate the effects of the hypogonadism and try to get the man's neuroendocrine system to get back on track more quickly. But still, even in the best of hands, there can still be prolonged hypogonadism, which can be quite devastating in some of these men. So let me transition from this directly to psychiatric disorders, the third of my list of concerns. Hypomanic and manic episodes are times when people on steroids develop euphoria, irritability, aggressiveness, sometimes violence, associated with decreased need for sleep, hyperactivity, impaired judgment, sometimes even rarely paranoid or grandiose delusions. Fortunately, these hypomanic or manic episodes are quite uncommon. About probably 10% of people get these episodes, but the other 90% have only very modest psychiatric symptoms of this type. And we don't know why these 10% of people are predisposed, whereas the other 90% are not. It appears to be some sort of a biological idiosyncrasy that makes people more vulnerable to this. Similarly, major depression, periods of depression during steroid withdrawal, are also idiosyncratic in that about 90% of people who have withdrawal hypogonadism don't get depressed, but about 10% can get quite severely depressed, again, for some biological reason which is not yet understood by science. This is just a quick slide from an early study that I did in the 1990s, showing that the manic or hypomanic episodes were much more common in people taking high doses, doses equivalent of 1,000 milligrams of testosterone equivalent per week or greater. But again, as I said, the mechanism by which these occur is not known. I have already mentioned that depressive episodes during steroid withdrawal occur only in a small percentage of people for reasons that are unknown. But in the people who do get these depressive episodes, they can sometimes be quite severe and associated with suicidal ideation or even completed suicide. Finally, there are effects on various other organ systems that are less concerning than my top three summarized here. There's an increased prevalence of ruptured tendons, especially in the upper body. There are occasional cases of liver toxicity, although that is much less common than is often believed. There is occasional kidney toxicity. We just published a paper on this. And then there is the issue of neurotoxicity, which is now being investigated intensively both by my group and by Dr. Bjornebeck, who will be giving her presentation at the end of this session and giving you an update on what we know at this point about that. So in conclusion, what are the implications of all of this? Well, as I mentioned at the outset of this talk, widespread use of steroids by the general population did not occur until the 80s and the 90s. And as a result, even the oldest of these general population steroid users are only in their 40s and 50s today. So we are only now just beginning to be able to see the long-term side effects in men who've used steroids as they go into middle and older age. So let me conclude with an analogy. Suppose that widespread cigarette smoking did not arise in the population until the 1980s and the 1990s, and that the great majority of cigarette smokers were under the age of 50 today, in the same manner as is the case with steroids. In that scenario, there would be the occasional case report of lung cancer, perhaps the occasional case series of a small number of people with emphysema, but we would have no idea of what was about to hit us. And what worries me is that a similar situation may exist with anabolic steroids, and that over the next decade or two, as these men move into their 60s and 70s, that we may see a substantially greater amount of pathology as these adverse effects begin to declare themselves.
Good morning. Today I'm going to be talking about the harms associated with the injection of image and performance enhancing drugs. Firstly, I'd like to thank the organisers of today's conference for inviting me to speak. The focus of this presentation is on injection and harms, and the most commonly injected image and performance enhancing drugs are the anabolic androgenic steroids, and these will be the focus of the data that I'm going to be presenting today. There is evidence to suggest that the use, and in particular the injection of image and performance-enhancing drugs, has increased in many countries over recent decades. Most of this evidence comes from increased presentations by those using anabolic androgenic steroids and allied drugs at needle and syringe exchange programs. However, the evidence we have on the extent and any potential changes over time on the size of the population using image and performance-enhancing drugs is limited. However, there are a number of public health concerns related to the use and the injection of image and performance-enhancing drugs. For example, there's evidence to suggest that the use of anabolic androgenic steroids can cause harm to the heart, liver, and brain. When it comes to the injection of image and performance-enhancing drugs, there is, of course, the risk of infection. And these will include the infections commonly associated with injecting drug use. That is skin and soft tissue infections, primarily caused by bacteria, and bloodborne viral infections such as HIV, hepatitis B and C. Bloodborne viral infections can be acquired through injection practice, particularly the sharing and reuse of injecting equipment, and also sexual behaviours, with the latter being a particular risk for HIV. Skin and soft tissue infections result from poor hygiene around injection, particularly the contamination of injection equipment from bacteria in the environment and on the skin. The injection and sexual behaviours that increase the risk of transmission of infections and the prevalence of infections such as HIV, hepatitis C, hepatitis B and skin and soft tissue infections have been extensively studied amongst people who use and inject psychoactive drugs such as heroin and amphetamines. However, much less is known about the extent of these bacterial and viral infections and the associated risk and protective behaviours among those who inject image and performance-enhancing drugs such as anabolic androgenic steroids. And this in part reflects that historically those who inject image and performance-enhancing drugs were seen or at least perceived to be at lower risk of infection. And this is related to the fact that there are differences in the injection practices between those injecting image and performance-enhancing drugs and those who are injecting drugs primarily for the psychoactive effects. Image and performance-enhancing drugs are injected intramuscularly and subcutaneously. Psychoactive drugs are usually injected intravenously. This different approach to injection will affect the amount of blood that can be in the environment, and so it was generally perceived that there was probably lower risk of bloodborne viral infections through intramuscular and subcutaneous injection than there was through intravenous. Similarly, there are also differences in the way these drugs are prepared. Psychoactive drugs usually come in powder form that require complex preparation, and this preparation may occur in environments where hygiene is very difficult to maintain. Image performance-enhancing drugs often come prepared for injection, for example as a liquid in a vial, or are easy to prepare and are typically perceived as being used in environments where hygiene is much easier to maintain. And these differences probably underpin, partly at least, why there's been less investigation on the extent of infections amongst those who use and inject image and performance-enhancing drugs, such as anabolic androgenic steroids. In this presentation, I'm going to give an overview of what we know about the extent of injecting risks, sexual risks, skin and soft tissue infections, and bloodborne viral infections among people who inject image and performance-enhancing drugs. This data is drawn from samples of individuals who are predominantly injecting anabolic androgenic steroids and allied drugs. I will then go on to consider recent data that's currently in press that's looked at the uptake of testing for bloodborne viruses among people who inject image and performance-enhancing drugs, before going on to consider what these data mean in relation to responses to infections among those who use and inject image and performance-enhancing drugs. Using data from a recently published review, we're first going to explore the extent of injection and sexual risks amongst those who inject image and performance-enhancing drugs. Firstly, we'll look at the extent of those reporting injection risks, focusing on those who ever report a number of risks. Firstly, those ever reporting the reuse of their own needles and syringes. And 4 studies have looked at this have found rates of between 8 and 15%. Secondly, the sharing of needles and syringes. The 9 studies have looked at this and have reported rates of between 0 and 22%. And thirdly, the sharing of multi-dose vials with another person. 6 studies have looked at this, and between 2 and 43% reporting sharing a multi-dose vial. As can be seen, the numbers reporting sharing various items of injecting equipment vary greatly between studies. This will reflect the fact that studies have recruited different population groups at different times and have used different methodologies and measurement methods. However, these data do suggest that there is a significant level of equipment sharing amongst those who inject image and performance-enhancing drugs. However, this may be partly related to the fact there is an overlap between this population and the population that injects psychoactive drugs, with 4 studies suggesting that this is between 5 and 27%. So some caution is needed with interpreting this, as some of the psychoactive drug injection could be related to injecting those drugs, for example amphetamines, for enhancement purposes, for example in relation to weight control. However, together these data do suggest that there is likely to be some injection-related risks for bloodborne virus infections and bacterial infections among those who inject image and performance-enhancing drugs. As these data are all based on self-reports and so therefore subject to a variety of biases which will probably most likely lead to underreporting, the levels of risk may be higher than suggested by these data. If we look at the studies that have examined sexual risks amongst people who inject image and performance-enhancing drugs, we find indications that at least among part of this population there are substantial risks for the transmission of such infections. If we look at the studies that have examined sexual risks during the preceding 12 months, we find that in these studies around half of the participants report having multiple sexual partners, and that levels of condom use are generally poor, with the vast majority reporting either no condom use or inconsistent condom use. Together, these findings suggest that at least among part of the population injecting image and performance-enhancing drugs, the risk of sexual transmission of infections, including the bloodborne viruses HIV and hepatitis B, is potentially substantial. Having looked at the extent of injecting and sexual risk behaviours amongst people injecting image and performance-enhancing drugs, now let's go on to look at the extent of infections, and starting with skin and soft tissue infections. A small number of studies have looked at the extent of symptoms of these infections, and these have usually relied on self-reports. Now, some of these symptoms, such as having an abscess or open sore at an injection site, will in fact a bacterial infection. Others, such as having redness, swelling or tenderness in the injection site, may affect an injury as well as an infection. So I'm going to present the results from 2 studies, the first from the UK, and this found that around 2/5 had ever had redness, swelling or tenderness in an injection site, and 7% had ever had an abscess or open wound at an injection site. And another recent study from Australia found very similar findings, with similar proportions reporting both of these symptoms. Together, the results from these 2 studies suggest the experience of injection site infections and injuries amongst those injecting image and performance-enhancing drugs, while not an everyday occurrence, is common. However, the levels of these remain much lower than they are among those who inject psychoactive drugs. A larger number of studies have looked at the extent of bloodborne viral infections among people who inject image and performance-enhancing drugs. Some of these studies have used self-reports, but here we'll focus on those studies that have used serological or biological markers of infection. These studies show that the prevalence of HIV is usually between 1 and 2%, They found prevalences of hepatitis B infection, that's ever infection with hepatitis B, between 4 and 12%, and prevalence of ever infection with hepatitis C between 4 and 10%. These findings suggest that these infections are an issue amongst people who inject image and performance-enhancing drugs. Whilst the prevalence of these is lower than you find in many samples of people who inject psychoactive drugs, the prevalences of these is also higher than amongst the general population in the countries that have been studied. HIV and hepatitis C are both infections that can be long-lasting. HIV is a lifelong infection, and for the majority of people who are exposed to hepatitis C also will go on to develop a lifelong infection. HIV is treatable, and there are drugs which can cure hepatitis C infection. However, to access these and other forms of care, it is necessary for these infections to be first diagnosed. So key to this is uptake of testing for these bloodborne viruses. Studies indicate that around 2 in 5 people who inject image performance enhancing drugs have been tested for HIV and also for hepatitis C. These levels of testing are almost certainly insufficient to recognise most of the infections among this population group. If you look at hepatitis C, what we find is that among people who inject image and performance enhancing drugs, the majority remain undiagnosed for hepatitis C, with those who have injected a psychoactive drug much more likely to have their infection diagnosed than those who have not. I'm now going on to explore the factors associated with the uptake of HIV and then hepatitis C testing. Until recently, no studies had looked at this in detail amongst people who inject image and performance enhancing drugs. The data I'm going to present over the next few slides is taken from a paper which is currently in press. In this study, a sample of people were recruited from community settings and asked to take part in a study. Those who agreed answered a questionnaire, and from that questionnaire they were asked about their uptake of testing for hepatitis C and HIV. And using this data, we explored the factors associated with testing. I'm going to present the results from a multivariable analysis, an analysis in which a number of variables are taken into consideration to allow for the fact that there may be interactions between these. So you're going to see a couple of tables like this, which present the factors which are found to be associated with testing uptake in the multivariable model. The results are presented as odds ratios. An odds ratio basically is a ratio of two numbers. Basically, for the baseline category, it'll be 1, and in the category that's been compared to that, it'll be higher. So an odds ratio of 2 in a category will mean that the likelihood of the event occurring in that group is twice that in the comparator group. So what we find when looking at factors associated with HIV testing is that there are a number of factors which are to be expected. HIV testing is associated with sexual orientation, imprisonment, but also interesting, it is associated with recruitment setting. So individuals in this survey that were recruited through a service, primarily a needle syringe exchange program, had a much higher uptake of HIV testing than those who were recruited in the community, i.e. in a gym or other fitness setting. Similarly, another interesting finding was that those who reported having had a metabolic or physiological test were much more likely to also report having uptake of HIV testing. A couple of other factors are also associated with HIV testing, and these probably relate to differences in risk. Looking at hepatitis C, we find a similar pattern. Again, bisexual men are more likely to report uptake of hepatitis C testing. Those who had been imprisoned were more likely to report uptake of hepatitis C testing. But similarly to HIV, those recruited in services, such as needle syringe exchange programs, were much more likely to have been tested than those who were recruited in community settings. And yet again, those who had had a metabolic or physiological test were also more likely to report uptake of hepatitis C testing. This study also asked about the motivations for iPad use. It found the most commonly reported reason for iPad injection was to improve body image. Other commonly reported reasons were non-competitive bodybuilding, sporting athletic performance, competitive bodybuilding, and occupational performance. The motivations for iPad use were found to vary by recruitment setting. For example, those recruited through community settings were significantly more likely to report athletic or sporting performance as being an important reason for their use of iPads compared to those recruited through services such as needle and syringe exchange programs. The motivations for iPad use were also related to the uptake of bloodborne virus testing. Those who reported athletic or sporting performance was an important motivation for their iPad use were significantly less likely to report being tested for HIV. Whilst those who reported retaining or regaining youthful appearance, increasing sex drive, or use of iPads for hormone replacement therapy as important motivations for their use of iPads were significantly more likely to report being HIV tested. This study also looked at risk behaviours and found that these also varied by recruitment setting. Compared to those recruited through services, those community recruited were more often likely to report having shared a drugs vial and poor levels of condom use if they had 2 or more sexual partners, indicating that those in the community had higher levels of risk than those who were recruited through services. Those recruited in the community were also less likely to have been tested for bloodborne viruses than those recruited through services. These findings have particular implications in relation to consideration of the findings from previous studies. Many previous studies that looked at people who inject image performance-enhancing drugs have focused their recruitment on needle and syringe exchange programs. Therefore, caution needs to be taken with current estimates of the extent of harms and risk behaviours, as these may potentially lead to an overestimation in the uptake of bloodborne virus testing and the portion of those aware of their status. It may also impact on our understanding of the extent of risks and the levels and extent of infections. Thus, targeted testing interventions are needed for those who inject iPads that are appropriate to setting and context. Approaches to increase the uptake of testing for bloodborne viruses among people who inject image and performance-enhancing drugs will need to focus on and reach people who are least likely to be tested. They will therefore need to access those who are not using needle and syringe exchange programs and those without a history of psychoactive drug injection or imprisonment. The findings from the recent study of an association between the uptake of bloodborne virus testing and receipt of metabolic and physiological tests suggests a way forward. Those who use iPads often desire to access metabolic and physiological testing to monitor the effects of the drugs they're taking on their body and as part of their training regimes. Therefore, approaches that use the offer of a range of screening tests, including tests for infections and also metabolic and physiological tests, should be explored. Such approach may lead to an increase in uptake of testing for infections, but also lead to early identification of other problems and harms associated with the use of iPads.
So, hi guys. First, thanks to Jim and the other organizer for arranging this meeting. I have been looking forward to the event, and it's a little sad that we were not able to travel this time. But hopefully soon there will be new opportunities where we'll love to travel and meet again in person. Anyway, today I'll present some of our research where we investigate anabolic steroid use and long-term effects on the brain. So this is an overview of the studies that I have initiated. And our main study is the first one, the brain and behavior study. And that is also the one that I will focus on today. And in this study, we have collected data throughout many years with 2 major data collection time points. In total, we have had 140 unique steroid users and 110 weightlifting controls that have participated in this study. Some of these participants have also participated twice, with 3.5 years between the time points, giving us a longitudinal aspect to the data set. And while our main focus is brain imaging, cognition, and mental health, you know that anabolic steroids is associated with a diversity of side effects. So from the second time point, we also broaden our collaboration to include researchers from different disciplines. So at that time point, we also have had a cardiac examination, blood vessel examination, and we have sampled blood. So we have detailed levels of hormones and other biomarkers that we believe could be related to brain health. And yeah, this is a picture also for where we work, where we spend our days. And this is a recent picture of the core research group. So when steroids are used in order to increase muscle mass, typically high doses are taken over longer periods of time. And we aim in our research to see how such long-term high-dose use affect the brain, cognitive function, and mental health, and how it affects brain health in old age. So we know that anabolic steroids may cause psychological and behavioral side effects. So then we also know that it affects the brain. Here is a word cloud of the most experienced psychological side effects from our recent study of 100 AAS users. And some of these side effects likely reflects temporal hormonal fluctuations, while others could reflect more permanent changes. I would like you to have in mind that there are different ways that AAS might affect the brain, and this is very similar to the effect of other drugs of abuse. We have temporal activational effects. For instance, AAS-induced mood swings is likely a consequence of hormones being present or absent, binding to their receptors in brain regions implicated in emotional processing. It could also be indirectly by influencing the signaling of neurotransmitters in the same regions. But substances of abuse and AAS might also change the structure of the brain and induce long-term alterations in behavior. And I like to think of memory impairments as one such long-term brain alteration. In support of structural brain changes of AAS use, several cell culture studies have shown that high-dose AAS use may cause neurotoxicity, death to the nerve cells. And there's also animal models and a handful of human studies that have shown that AAS use is associated with impaired cognitive performance. We also know that there are medical side effects associated with AAS use that may impair brain health. For instance, hypogonadism and a variety of cardiovascular risk factors. So one of our main research questions is to see if long-term use of steroids impact brain structure. And to do that, we have recruited male steroid users with more than 1 year of cumulative steroid exposure, as we're looking at long-term effects, and we have compared them to a group that are similar in many ways, that they are matched on heavy resistance training. So we have a weightlifting control group. And all the participants, they scan their brain, and we compare the volumes of different brain regions, and we compare the regional thickness of the cerebral cortex, which is the outermost layer surrounding the whole cerebrum. So the MRI findings were that compared to the weightlifting control group, the steroid users, they had smaller neuroanatomical volumes. And smaller volumes were found for total gray matter volume, cerebral cortex volume, putamen, which is a large structure of the basal ganglia, corpus callosum, which is the fiber bundle tract connecting the two hemispheres, and the clearest findings that also survived correcting for when we kind of did analysis where we left out those with other substance use issues were the ones for the larger volumes, total gray matter volume and cerebral cortex volume. And you can see that I've written also note that there were no differences in intracranial volume. And that is kind of important also to notice, as the intracranial volume is the volume that surrounds the brain, and it's kind of a measure for how large the brain, it says something about how large the brain it was supposed to be at its maximum. And if there were differences in intracranial volume, then we could have suggested that there were differences in brain volumes prior to steroid exposure. But now we do not have any indices that suggest that there should be differences in brain volume prior to exposure. And here are the findings visualizing regional cortical thickness differences between AAS users and control. And the findings are illustrated on lateral and medial surfaces on the brain, right and left side. So that's why you have kind of 4 pictures for visualizing these effects. And blue color illustrates areas where the cortex is significantly thinner in steroid users compared to weightlifting controls. And you can see that it's kind of widespread effects. And in the lower picture, we have kind of looked at those with longer steroid exposure, those with more than 10 years, and compare them to weightlifting control. And you can see then that longer exposure is associated with even more widespread effects. Are these differences related to cognitive performance in our sample? And to do so, we have investigated cognitive performance using a broad range of cognitive tests. And then we have grouped these tests into meaningful cognitive domains. And the main domains that we have looked at is working memory, speed, learning and memory, fine motor speed, problem solving, and executive function. And in all analysis, we adjust for age and education, as we know that they are factors that always are related to cognitive performance. So we remove the variance caused by that. And so in this analysis, we can see that there are differences between the groups on almost all cognitive factors that we have investigated. But there could also be other things that could influence cognitive performance. For instance, premorbid abilities and other use of substances of abuse. So we also have conducted analysis where we try to remove the variance caused by that, to see that it's not alcohol and cocaine use that causes the differences. And when the findings were kind of stable also when we do that, and the most prominent findings are seen for working memory, speed of processing, and problem solving. And we've also seen for memory performance that there is dose response effect. So we did comparison within the steroid group, comparing steroid users with shorter exposure, less than 5 years, to those with a more prolonged exposure, more than 10 years. And it was particularly for memory performance that was more impaired in those with a longer exposure. And 36% of our sample also reported memory problems to be a side effect of use, and increasing to 50% of those that had used steroids for more than 10 years. So based upon our structural neuroimaging data, we have now estimated the biological brain age of our participants, which is kind of cool. Brain age have been calculating using artificial intelligence, machine learning models, where a large lifespan dataset of healthy males are trained to make a model of how a typical brain looks in a particular age. And then we apply this model to our sample, and then we get the brain age of each participant. And the difference between the predicted brain age and chronological age is termed the brain age gap. And it can tell us if the aging trajectories are deviant from the population norm. And we found that AAS users, they had higher brain age gap compared to non-using weightlifters, thus could suggest earlier brain aging. Steroid dependence is a particular focus of our research group. It's quite clear that users who develop an addiction to steroids are a particular vulnerable group in many ways. They are those who experience the most medical and psychological side effect, but that continues to use steroids despite of that. So one major aim of our research group is to find characteristic traits or markers putting people at risk for developing steroid dependence. Addiction is a brain disease. Drugs of abuse, they hijack the brain reward system, and long-term exposure to various drugs of abuse, including anabolic steroids, it seems, may cause structural brain changes. So we wanted to see if there were structural brain characteristics that were associated with AAS dependence. And to do this, we compared the brain scans of dependent AAS users to non-dependent AAS users. And the blue areas illustrate areas with thinner cortex in dependent steroid users. So all the findings were in that direction. And dependent steroid users, they had thinner cortex in several regions, including the prefrontal region, temporal regions, parietal, and also in occipital regions. But I would like you to pay a little extra attention of some of the most profound findings in the frontal regions here and the orbitofrontal regions, which is areas that are critical for impulse control and emotional processing. And the findings are actually kind of similar to what have been seen for other dependencies. And it could be that this thinning in frontal regions and reduced inhibitory control could be one explanation for the kind of maladaptive behavior of exaggerated drug use despite of adverse consequences. We also looked if steroid dependence was associated with earlier brain aging. So here is the brain age findings comparing non-users, non-dependent steroid users to steroid-dependent users. And what we found was that it was actually the steroid-dependent users where the brain age gap was increased, whereas non-dependent steroid users were no different from weightlifting control group. So we have also started to disentangle factors that might be associated with our brain age findings. And as I previously mentioned, we have a very rich data set now with a lot of interdisciplinary data on steroid users and weightlifting controls. And now we're working with this data to kind of see the broader picture. And one of these things that we try to look at is if neuroinflammation or inflammatory markers are increased by or are affected by steroid use, if steroid use influences the immune system functioning, and to see how this relates to brain aging. So in normal condition, inflammation is a kind of protective effect. But chronic inflammation and in aging and aging-related illnesses, the inflammatory system is kind of in the high gear, and we get too much of it, which might damage the nerve cells and increase brain aging. So we're trying to look at different inflammatory markers and how they relate to our brain findings. And here is one interesting factor, interleukin 8, which we first see that it is higher in the steroid user group, suggesting that steroid use could have some impact on the immune system and cause this heightened level of neuroinflammation. And what was also interesting was that this factor in particular is clearly linked to our brain age gap findings. And this was true for many brain regions. And here I show you a profound region from finding from the brain age gap in the temporal lobe. And here you can also see that it was the steroid user group, and that kind of that it was this relationship was much more profound in the steroid user group. One factor that I am extremely interested in is the growth factor, brain-derived neurotrophic factor, or BDNF for short. BDNF is a protein that helps our nerves grow and are important in neuronal survival and synaptic plasticity, and in promoting learning and memory processes. BDNF levels have also been highly linked to a variety of mental illnesses, depression in particular, where love levels are seen in depressed patients, and also in other disorders. And we find kind of huge differences between the groups in BDNF levels, with lower levels in steroid users. And note that this is also true for former AAS users, suggesting long-term reduced neuroplasticity after steroid use. And I think this finding is a little bit interesting also, as we know that former AAS users are a vulnerable group. They are vulnerable to long-term psychiatric illness, and it could be that reduced neuroplasticity could serve as an explanation to why that is. So to wrap it all out, we have now seen that long-term high-dose AAS use is associated with apparent aging of the brain compared to a weightlifting control group. We have seen that steroid users score lower on a variety of cognitive domains. And we have seen, when it comes to the brain findings, we have seen that steroid dependence is associated with prefrontal thinning, which resembles finding from other dependencies, and that it was dependent steroid users in particular that had this increased brain age gap. And I'll also show you some preliminary findings that I find very interesting, that steroid use might also impair have impacts on immune system function and neuroplasticity. And finally, thanks to all that have contributed, all muscles and brain, the participants that have used so much time to take part in our research, and a lot of these findings related to steroid dependence. You can find that in the thesis work of Lisa Hauger that defended her thesis in May. And now we have some new collaborators, new members of our research group, and we will continue to work heavily on these findings. And thanks a lot to Jim and the other organizers.
Hello, it's Jim McVeigh. I'm sure you'd like to join me in thanking the speakers for those fantastic presentations. They were really informative and have really sparked a lot of interest. Just to recap who we've been listening to, Harrison Pope, who's the most made the most significant contribution to the field of any of academics in relation to anabolic steroids. Professor Viv Hope, who led the team looking at bloodborne viruses and continues to lead that work. And Astrid Bjornebekk, whose fantastic work in leading a team in Oslo, and in particular that work around cognitive function and impact on the brain. I'll go straight into questions. We've got a pile of questions. I don't know if we'll get through them all, so I'll stop talking. I'll start off with you, Dr. Pope. A couple of questions for you. Apart from with anabolic steroid users, it's clear that there's cardiovascular damage for long-term use. Apart from using less and for less dosage and for shorter periods, is there anything they can do to mitigate that damage at all?
It's not obvious that there is very much that you can do. First, if you are going to use steroids, it seems pretty clear that it is safer to use injectable steroids rather than the 17-alpha alkylated steroids that are orally active, because those certainly appear to mess up your cholesterol fractions much worse than the injectables. The other thought that I have had, and that some of the subjects in my studies have had, is whether it would be of value to take drugs like statins, so drugs like Lipitor, or at least Lipitor is the brand name here in the United States. But a couple of guys that I had in my studies tried deliberately taking a statin, and surprisingly, the statin was not very effective at improving their lipid profile, so that the power of the steroids sort of overrode the power of the statins. But that admittedly is based only on anecdotal experience with a couple of cases.
Right, thank you. That's fascinating. We'll stay with you. And you mentioned about depression and depression-like symptoms during withdrawal. Can you tell us a bit more around those experiences and what you've encountered, how long it lasts, and the severity of those symptoms?
Well, this has been an area that has increasingly worried me over the last 10 or 15 years. If you had come to me back in the year 2000 and asked me if prolonged hypogonadism was a serious problem, I would have told you that virtually everybody has complete recovery of their endocrine function, and I would have been completely wrong. It has now become clear from our recent studies that many of these guys have prolonged hypogonadism that may persist for literally years, and that in some cases appears to be entirely irreversible. And it is accompanied by depression in only a portion of cases, and for reasons that are not well known to science. We know this from studies where men have been artificially made hypogonadal by giving them drugs that would counteract the ability of the hypothalamus to in turn stimulate the pituitary, which in turn stimulates the testis. And if you cause artificial hypogonadism, for example, in treating prostate cancer, when you don't want a lot of testosterone on board for fear that it will exacerbate metastatic activity, what you find is that about 90% of men do not get depressed. They lose their sex drive, they may lose erectile function, they may become sluggish, fatigued, but they don't get clinically depressed. Whereas about 10% of them, and these are just very rough figures, obviously, about 10% of them can get seriously depressed, suicidally depressed in some cases. And why some people are susceptible to this and others are not is simply not clear. In cases where it occurs, obviously, the first thing to do is to aggressively treat them in the hands of a good endocrinologist who is familiar with steroids, but also it is very often necessary to treat them psychiatrically. And these steroid withdrawal depressions do respond to ordinary antidepressant drugs like fluoxetine, which is Prozac in the United States. I'm not sure if that's the same brand name throughout Europe, and other drugs in its family. There's even a report in the literature of a guy whose depression responded to shock therapy, to electroconvulsive therapy, so that when it happens, this is for the small percentage of people who get bad depressions, this is no laughing matter. It's quite a serious problem, and should be aggressively treated both by an endocrinologist and by a psychiatrist.
Thank you for that, Dr. Pope. We will have an endocrinologist this afternoon. We'd be interested to explore that issue again. If I could move on to you, Astrid. We've got a question from Tony Knox about, have you noticed specific anabolic steroid combinations or anything that specific that contributes to cognitive functioning? Have you been able to tease that out at all?
I always get this question, and these are one of the things that we are trying to look into, but the picture is very complex because most users they use several compounds and combine them in different doses, and some only uses testosterone, but we haven't been able to see if there are particular compounds related to brain and cognitive findings. We have seen that the longer you have used is important, and also it seems to be an association with those who uses many compounds. So a weak correlation with those who applies several compounds instead of a few, but that could also say something about the more exaggerated use in general. Those who uses several compounds, they typically also use higher doses and have used for a longer period of time. So it's very complicated, but at least the users they do mention when we ask them that there are several steroids that are associated with more severe psychological effects, like trenbolone, for instance, and it's very, very popular, but we hear it all over again that I get crazy with trenbolone, and it's So, but it's really efficient, so they choose to still choose to use that one, but I don't know for the brain effects.
Yeah. It's a pity this research wasn't done in the 1990s when the regimes were so much simpler. We might have been able to tease out some of those features. Another question leading on from that was around the role of growth hormone, and theoretically, would that potentially mitigate some of the damage?
I think it's a little bit, it's hardly speculative to suggest that, but there are some animal studies that have looked into growth hormone, and I think that they do not probably have the same damaging effect, maybe as steroids, but we know too little about the exact mechanisms and how these things interact together. So I think at least we have seen 140 unique steroid users, and maybe 40% of them also uses growth hormones. So I think it's not correct to believe that growth hormones will kind of have some recovery effects or something. But I don't know. Yeah, it doesn't look so into our findings, but it's difficult, complex again.
Yeah, of course. Julio raises an interesting question. What you're seeing on the brain effects, would you compare them to any other clinical conditions? Is there a comparison?
It's a little. As I mentioned in the presentation, also it's a little bit similar to what you see for other drug dependencies as well. So it's kind of many of the same areas that and the cortical effects, and they are kind of going in one direction, it seems. So it's a little bit difficult to know if it's comparable to other conditions, because we do not. I think it's both the cardiovascular effects leading to brain effects and inflammatory markers, and there's neurotoxicity probably. So that there's a lot of things going on, and it's but it could be the same as when you get diabetes or other cardiovascular thing. It also affects the brain, but it's different aspects into it as well.
Okay, thank you. I'll come back to you as I will to Dr. Pope with some more questions, but I'd like to move over to Viv, and an interesting question raised around the impact. We see great differences between blood-borne virus prevalence levels. What do you put that down to? Is it down to services? Is it down to the population, the characteristics, or is it too early to say?
That's an interesting question, Jim, and one I don't think we really know the answer to. I think all of those factors are likely to play a part. I think we need to be cautious about viewing this as a single discrete population. The motivations and the reasons why people use anabolic androgenic steroids and other IPEDs are quite varied. And those reasons and motivations will impact on the nature of their use, their perceptions of risks, and the wider behaviours. So certainly some of it will be explained by the fact that there perhaps are some groups who have a perhaps less risk averse view, are perhaps more likely to have a wider profile of risk that increase their risk of blood-borne viruses. I think when it comes to HIV, we need to consider the fact that in this population that sexual risks probably predominate over injecting risks, whereas hepatitis C is probably the other way round. So I think there are lots of factors into play here. It's also difficult to disentangle. Most of the places where we've studied the extent of blood-borne viruses are in situations where there are long-established needle and syringe exchange programs which have been accessed by this population. And this population has grown up alongside the existence of those interventions. And we don't know what the counterfactual would be if those weren't there when the injection of antibiotic anti-steroids sort of spread into the wider population in the 80s and the 90s. So I think we need to be a bit cautious about trying to arrive at a single conclusion. But I think we also need to be cautious of the fact that there will be populations groups within this population which will have higher levels of infection and other groups where HIV and hepatitis C probably don't exist. The exact reasons for that are unclear, but we know that blood-borne virus presence vary by population and geography anyway, so we would expect that.
Right, thank you. You raised an interesting point around the sexual transmission of bloodborne viruses amongst anabolic androgenic steroid users. Online, we have like many practitioners from needle and syringe programs. I don't know how many we have here from sexual health clinics. Should we be investing in those sexual health clinics? Would it be a different population? I'd like to hear your views on that.
I think that's, again, difficult to answer because it probably depends on who you're trying to reach. I think the offer of services often needs to be situated within what people's needs are, and not to see. I think sometimes we're in danger of doing this. We do it with other populations, of reducing people to an infection and focusing on a single outcome that may be of public health importance, but actually to the individual is a small part of their lived experience. And perhaps seeing these issues, these health harms, whether it's to do with bloodborne viruses, the cardiovascular effects, or the effects on the brain, as a sort of a group of things that go together, and thinking about what can we do to address them collectively. So I think it's about offering a range of things to help people monitor the health, to monitor things so they can reduce the risk. The setting for that, I think, is what's appropriate for the individual. For some people, that will be a sexual health clinic. For some people, that might be a needle syringe exchange. For some people, that might be a sports clinic. I think it needs a lot more thought and a lot more work around development of appropriate intervention approaches and settings for those interventions. And I think we do need to think about bloodborne viruses alongside other health risks and other harms, and a part of a process of monitoring the effects these drugs are having on people and the process of using that those drugs are having on people.
And just a final one for now, Viv. Are there any good examples of evidence of how effective interventions can be around injection techniques with this population, or has that not been researched yet?
There is no, I think, formal research evidence that's looked at interventions around improving injection technique. And I think that's one area that perhaps does need some thought and exploration. But I mean, that's also an issue that's been raised among those who inject psychoactive drugs as well. There's a lot of problems there also arrive from poor injection technique. So I think there is an area of intervention there. I think also that perhaps needs to be grounded in a more holistic approach to people's health and well-being. So it's not just about how people use the drugs, but actually making a situation in the context of providing things that can minimise harm across the whole spectrum of possible risks.
Right, thanks. If I can return to you, Dr. Pope, this is a question from William. One of the issues we have in the UK and across the world are accounts of anabolic steroid users not getting the support and services from their general practitioners. As an ideal, what are the sort of services you'd like to see in general practice for the anabolic steroid user presenting there?
Very, very important question. In the United States, there are very few general practitioners who are sufficiently familiar with steroids to really be able to treat these guys. And steroid users in the United States are, I think, justifiably skeptical about physicians. As you well know, the medical community for decades claimed that steroids didn't work, that it was all a placebo effect. And it wasn't really until the 1990s that we see the medical profession finally coming around and admitting that these drugs actually were effective. And in a study that we did, published about 20 years ago, we found that about half of the steroid users that we interviewed had never disclosed their steroid use to any physician that they had ever seen over the course of their lives. So first of all, this is a very secret form of drug use. It is something that even I witness. And in my research on substance use, I have marijuana users who come and tell me all of the cannabis they've smoked. I have ecstasy users who tell me all of the times that they've rolled on ecstasy, cocaine users who talk about the cocaine they've snorted. And then I will have someone walk in my door who obviously has used anabolic steroids and who will deny to my face that he's ever used steroids. So the problem of secrecy is a big problem, and you need physicians who are capable of conducting an interview where they approach the subject of steroids in a sympathetic manner, make it clear to the person that they actually know something about this topic in order to secure the trust of the patient, and then who are sufficiently knowledgeable about the effects of these drugs, and particularly the problem of hypogonadism that we discussed earlier, to be able to actually treat some of these difficulties. So this I think is a major problem. The only real solution is just to continue to educate clinicians, both in the United States and in Europe, to be more familiar with this topic.
And just to follow on from that is, should we be encouraging anabolic steroid users to train differently, to do more aerobic exercise? Would that be of benefit to their overall long-term health?
There really are not any methodologically sound data on that, because obviously it's very difficult to, nobody has done a prospective study where they assigned half of the steroid users to aerobic exercise and the others to not get aerobic exercise. So that much of our knowledge in this area is largely anecdotal. And I mean, on paper, it sounds like having aerobic exercise would probably be beneficial, but not much is known.
Thank you. Viv, you mentioned about the heterogenic population, and for some people, bloodborne viruses don't appear to be an issue. How do we keep that on the agenda?
I think that's an interesting question, and I think it is something we need to keep on the agenda. But I think looking at the findings in our recent paper, which has just been published, suggested that those that had a range of metabolic tests were more likely to have also had a bloodborne virus test. Does raise the issue, considering the wider health implications of the use of anabolic androgens, about whether we should be moving to a mode of offering a batch of screening tests routinely, which include tests to monitor metabolic activity and also bloodborne viruses and other risks. So I think that there are ways of doing that. I think also we need to be clear that, bloodborne viruses are a risk to all of us if we engage in sexual activities and other factors in which we come into bloodborne viruses, and we need to be conscious of that. So I think we do need to keep it on the agenda, but we also need to get it in a balanced way where we're not just seeing this as being a big agenda. It is for some subgroups of people who inject anabolic androgen steroids, particularly when it comes to Hep C, and for those with sexual risk for HIV, but also for other sexually transmitted infections. But we need to try and keep it in a balanced kind of perspective. It's part of a bigger picture, a collective part of a group of harms that we will see over time. The worry with Hep C, like a lot of the cardiovascular problems, is that Hep C are long term. People with this infection will not see to many decades after they become infected. So again, it's a bit like one of those things. We've got an aging population. People who may have acquired Hep C through anabolic steroids in the 80s, 90s, will not develop liver disease until another 10, 15 years possibly. So it's something that could be in the future. So we need to keep it there, but we also need to keep it in perspective.
Thanks, Viv. And I suppose carrying on from that idea of the balanced approach, Joe Keane mentioned about the missing millions. I'm not sure what you would. I'm going to take that as the fact that we have a shortfall in our NHS account. So how do we go about making sure that this stays on the general agenda as a whole, but in a balanced way? And I suppose in balanced way as in it doesn't stigmatize, it doesn't drive people away, and equally it doesn't feed into perhaps a knee-jerk legislative response. How do we go about that, and who should we be speaking to? Should we start with you, Astrid?
Yeah, I think this is maybe a better question for Pope.
Okay, well, we'll come back to you, Dr. Pope.
I passed this one.
Well, in terms of a legislative agenda, there's no clear way that at least in the United States, it seems to me that the first step by far is to actually educate people about the potential dangers of these drugs. It was, at least in the United States, and I'm sure elsewhere in the world, steroids are not treated the same as other drugs. Steroids have a positive spin on them very often when people talk. You talk about a powerful car as being an engine on steroids, or something that is particularly powerful as being, quote, on steroids, unquote. But you would never use the term on heroin or on cocaine in the same situation. So that people still are only now beginning to realize that steroids are just another form of drug use. That these are people who are drug users and who are subject to the same problems as people who use other drugs. And very often, steroid users do use substantial amounts of other drugs as well. So once and also, it is only in recent years that we've been able to appreciate some of the long-term dangers of these drugs, because it wasn't until the 80s and 90s that they were widely used outside of the elite athletic community. So hopefully, as more literature begins and more studies begin to pour in, looking at these cardiovascular effects, the brain effects that Astrid has described, the risks of bloodborne viruses, and so on, that gradually it will become clear, I think, that this does represent a major public health problem. And only with that knowledge, I think, will we be able to galvanize the medical and clinical community.
Thank you. Viv, do you want to add to that?
I think I broadly would agree with that. I think the key thing is we know there are lots of potential health problems associated with the use of anabolic androgenic steroids across both physiological, psychological, and infections. We don't fully know the extent of those yet because we are dealing with an emerging problem. What we need to do is make sure we characterize those, but also get an understanding of the population at risk. So that's not just those who are currently using, but those who have done so in the past, because some of these effects may well be long-term, may not be seen until we get into older age. So I think there are lots of things that we need to better understand. I think key to that is the size of the population currently using, and better understanding the size of the population that has used in the past, and trying to get the message across that we're dealing with multiple risks and multiple harms, and that can be challenging in systems where there is often an myopic focus on a single health issue. You see that in the UK currently with hepatitis C elimination agenda quite dominating other aspects for service provision, for example, to people who inject psychoactive drugs. And I think that so we need to be a bit cautious about how we go about this. And I think it's trying to come up with a whole system approach that draws together information from both academia, practice, and also I think we need to think about developing appropriate advocacy support for changing the agenda. And I think that's often key. And I think that's where we need to develop something is around improving the advocacy. And that's around seeing this as a community problem, not something that's coming just from academics and public health people.
Right, thank you. We've just got a couple of minutes left. I just wanted to ask one question for all of you, and it's around women. And we know it's much smaller proportions, but we also know the effects can be quite profound. I've contributed to this by making sure all the imagery is about male users, and I've missed out women. Are we doing women a disservice? Are we doing enough research around that? Actually, it's an area that you've worked with colleagues in around female use. Do we need more research around that?
Yes, of course we do. It's literally nothing or almost nothing done on women, and it kind of has enormous implication for women using steroids, and they don't get that information because they are getting information now from males taking steroids, and when it's not, even if there is some information to get from the former German there is some there is some information to see what happened to those elite athletes who were clearly documented in East Germany. So, but it's not available. It's hard to reach information, and yeah, I think it's important. It has been kind of difficult to get participants because it's also stigmatizing to use steroids among women. So it's even more than they kind of there is an environment for that, but they are very secret about it, even if everybody knows who are using it. So I think it's definitely we need more studies on that.
With our iPad surveys, they're always, while we know that there's much more males, they still seem to be underrepresented in those studies. Should we be doing more?
I think the simple answer to that is yes. And we do in our studies in the UK, we have recruited women into those studies, but the numbers have always been small. I think we're dealing with a hidden population within a hidden population, and I think we do need to think more carefully, creatively, and maybe use more community or bottom-up approaches to reach into that population. But I do think we definitely need to do more in that area.
Great. And we've got 20 seconds left, which I'll hand over to you, Dr. Pope. If you can sum up that whole issue in 20 seconds, that'd be great.
Well, the issue of women, in a study that I published in 2013, looking at the pooled results of studies worldwide that had recruited steroid users without regard to gender, the number of men was about 98 point something percent, and the percentage of women was about 1 point something percent. So that you have to remember that steroid use in women is quite rare. It can be a serious problem in the small number of women who use it, but statistically, the magnitude of the public health problem falls squarely on the males.
That's brilliant. Thanks very much. And thank you to all three of our speakers for that really informative session. We're going to have a short break and then we'll be returning with April Henning. I'll be chairing the next session. Thank you again to the speakers.
Thanks.
Thank you.
Thank you.
Hello, my name's Sue Backhouse and I'm the Director of Research in the Carnegie School of Sport at Leeds Beckett University. It's my pleasure to be taking part in this virtual conference today to share with you the idea of the dopogenic environment and consider how its existence therefore encourages the use of Imogen performance-enhancing drugs. And in taking those ideas forward, consider what that means in the way that we act to prevent the potential harms associated with iPad use. And it's in considering the potential harms that the importance of recognizing the dopogenic environment is highlighted. In that sense, there is a growing evidence base of the harms associated with iPad use, giving rise to a growing recognition of the population health effects of such use. iPad use is a behavior, and we know that human behavior is incredibly complex. And drug use behavior are socially situated behaviors. And recognizing the complexity and the interactive nature of human behavior, we can start to consider what a simple behavioral map might look like in the sense of iPad use. And in particular, the use of anabolic androgenic steroids. So steroids are the most commonly reported iPads in terms of general society, and also in terms of some of the sporting research we've seen, has impacts on our physiology and our musculature and the gains in strength that it can generate. So if we take an approach of looking at anabolic steroid use as target behavior, we can start with a simple behavioral map to think about who are the influential agents around that target user, in this case Phil, who's the user of steroids, and then what are the influencing behaviors potentially around Phil in terms of his decision to use anabolic steroids. So we can start by giving an example of an influencing behavior of Phil actually going to the gym. So entering the gym environment where he then meets Jeff, who's his friend, and Jeff, who's in that gym environment, has been using steroids for quite a number of years. And as a consequence of his steroid use and his training combined, he has shown some incredibly impressive results as Phil sees them in terms of his gym performance. So he's lifting heavier weights, his recovery is much quicker, and Phil is able to observe those changes in Jeff. If we then look to Instagram, and Phil follows a guy called Harry. Harry's very regularly posting on Instagram, sharing lots of imagery of himself in the gym, lifting weights, and also he advocates very strongly for certain types of steroid and how that has helped him achieve his goals and the various pursuits of goals that he's put forward. Also alongside Phil, we've then got Carl, who's Phil's strength coach. Carl is very well networked and connected, and actually he is the source of supply for Phil's anabolic steroid use. So he supplies that through the gym environment and actually supplies a number of friends who are kind of situated around Phil. So this diagram, just a very simple behavioral map, starts to impress upon us the importance of recognizing the human behavior of using steroids is very much a networked behavior, and it's not a behavior that exists within a vacuum. So if we take that into account and have that as the basis for the conversation today, it's therefore important to draw on some theoretical frameworks to help us understand human behavior. And the framework that we've been applying in a lot of our research in recent times is the capability, opportunity, and motivation model of behavior, which is led from the work of Susan Mickey and teams at UCL. And what we see from the COM-B model, which is the image on your slide, is you can see that essentially behavior is a function of three interacting conditions. So Phil needs to have the capability to enact that behavior, and the capability in this sense is both physical and psychological. So physical capability could very well be injecting technique, and psychological capability would then be around knowledge and understanding of various cycles and strategies for use. On the flip side, it could also be knowledge and understanding of the risks and harms associated with various iPad use. Motivation is a next phase of those interacting conditions, and here what we're talking about is both reflexive and automatic motivation. So reflective motivation is very much thinking about the beliefs about the consequences of using steroids, and if individuals have a very firm belief that that will lead to the pursuit of their goals and they'll be successful and able to achieve their goals through that use, and there's a motivating element to it there. But there's also an automatic element to motivation, and that can come from the research that we are increasingly seeing around the effective responses to steroid use, and that can create habitual behaviours, and certainly the evidence base is mounting on the potential habituation and addiction to various iPad drugs. Then also the other interacting condition for behaviour is the sense of opportunity, and opportunity can be broken down into physical opportunity, and that can be the resources and the settings that are available to us. If we talk about resources within this context, it could well be the needle and syringe programs that are available. And also then the social opportunity, that's the social norms and conditions that reinforce the behaviour. So the social influence is an important part of that aspect of interacting factors leading to behaviour. So taking those all together, it's actually the physical and social environment and opportunity that we're interested in focusing on today. So if we take the aspect of the theory of human behaviour, the COM-B, it's important to recognise that COM-B, there are multiple COM-Bs within the systems. And here in front of you is the social ecological model, which colleagues have started to apply to iPad use and steroid use in particular through the work of Jeff Bates and colleagues. But here I'm interested again in not necessarily the individual level, and that doesn't discount the fact that we've got a growing evidence base around individual capability, opportunity and motivation. But what we're interested in today is the element of the physical and social opportunity and how that sits at the level of social networks, the social environment, at the level of physical environments or settings. So that includes schools, workplaces, gyms, prison settings. And then at the next level above, that's the level of the sector. So for example, the conditions around the iPad industry, looking at the governance and government rules and regulations, but also societal and cultural norms and values. So we can see, therefore, there are multiple layers of influence that can lead to behaviour. And it's at the level, essentially, of the physical and social opportunity that the concept of the dopogenic environment is drawing from. And with the dopogenic environment, what that term means is the recognition that the environment itself is capable of producing and generating behaviour. And that comes down to the fact that we sometimes ignore the aspect of the environment that is influential in our behaviour, and a lot of our focus and attention goes around individuals and their choices, and essentially individual agency and responsibility, and not seeing the bigger picture of the influences around those individuals when they come to make the choices that they do. So we did call for action to be taken on the dopogenic environment to try and shift the blame and stigma and focus away from individuals and recognise the role that the environment plays, as I say, in decision making. So I'd like to take you through some ideas then of bringing that dopogenic environment to life. You know, what does it look like? And I'll draw upon some evidence around sectors and settings in particular to illustrate how the environment is capable of generating and producing iPad using behaviours. So let's take a look at the gym as a setting for being an enabler of iPad use. And in the gym, here's an example of a quote from an adolescent boy that we spoke to in some research we did for the Rugby Football Union. And what you can see here in this quote is the articulation that the first time I got the opportunity to use anabolic steroids was when I first started going to the gym. this participant had been 4 or 5 times where that opportunity to buy some had manifested. Therefore, consequently, they just discussed that decision with people that they knew in the gym and that knew an awful lot about it, and that they said it can be really bad for you. So that social network at that point, to some extent, put off this participant. They were taking Dianabol, and shortly after he said he'd started taking that, he noticed the effects. So for this participant, that put him off. But it was the gym environment where that opportunity, so coming back to the model of behaviour, where the actual opportunity for the use of steroids was brought forward. If we look at the school setting, and we've done some research with, as I say, with adolescent males in particular, and within that school setting of over 700 participants that we interviewed, that we undertook a survey with and then follow-up interviews, what came through within that was a concern around the use of banned substances. And we did give the example of anabolic steroid being a banned substance in terms of competitive sport, that the teachers and the schoolboys themselves, over 40% indicated that they thought it was a serious issue in schools that needed to be addressed. So that was 58% of schoolboys, and 46% of teachers agreed that it was a serious issue. And we started to unpick a little bit more about that school setting in the research that we did. And what is probably worth noting today is, again, thinking then about the networks and how they interact with the settings. We had reports from the schoolboys of the teachers and coaches within those settings actually supplying children, essentially, because some of these were 16-year-olds, with the use of supplements. Now, supplements are not, by their nature, prohibited in sport or in society, but we are aware that supplements are not without risk. I will come on to that a little bit, but there is a risk of contamination and adulteration. But also, we're seeing research point to a potential gateway between supplement use and prohibited substance use over time. What we therefore found, the supply, in particular protein supplements within the schools, here is a normalization of such use within a school setting. And really within that school setting, we want to try and prevent and delay potentially the onset of supplement use, so that a food first approach is much more emphasized and supported and endorsed by those influential agents as teachers, because we also noted that the vast majority of those we surveyed were keen to do what teachers and coaches kind of suggested to them. So that influence is key. But the school setting is therefore important. And it's also important when recognizing that from those participants we surveyed, 3 out of 5 had never received any formal education on supplement use or banned substance use. So if we come back to the theory of behaviour and recognise that capability and knowledge in particular is an important determinant of behaviour, then we've got potentially some very vulnerable people within that school setting who are not aware of the risks of, say, supplement use in particular, not aware of the risk minimization process that's important for supplement choice decision making, and the potential that they can contain prohibited substances within those supplements. So important findings to know and to consider how we then act on those findings, in this case within the English school system. Beyond the school setting, there is research that has been identifying the setting of the prison as a space and a place where iPad use can be encouraged, and so therefore outside the competitive athletics arena there are other settings of importance, and the work of Dominic has highlighted the prison setting as a particularly important one. And if we then move beyond the prison setting to acknowledging the role of neighbourhoods and communities in iPad using behaviour, we've got research from Van Houten Keem that's highlighted within British South Asian communities the role of community in influencing iPad use behaviour. If we then come back to the settings around where we are exposed to those substances, and taking into account the risks I've highlighted around supplements, the retail and service industries and establishments that we frequent also become a point of choice. So reiterating the kind of statement around choice happens both home and away, in those retail environments, we are bombarded with choice. And this is a photograph that I took from our local petrol station. This is a couple of miles away from where I'm sat talking to you today. And in that petrol station, you are very clearly nudged to consume and purchase supplements. They're all supplements in the kind of foreground and the background of that petrol station, essentially responding to our cognitive biases. In particular here would be like a heuristic availability bias, in that, well, they're all here, they're all exposed, and kind of the idea there being, well, clearly I need them because they're all here on display for me to purchase. And the challenge there sometimes is with those easy access point of sales, sometimes a kind of an automatic decision to purchase can occur without really a true understanding of the need for those supplements. So we are within that choice architecture now that we find ourselves exposed to. There are constant nudges in the environment that we don't even think about, but we are exposed to on a daily basis. So here's a petrol station, and perhaps you also have got petrol stations where these supplements are now on every shelf that you also observe. If we then move from the settings and take a look then to sectors as part of that social ecological model. So the sector being the iPad industry, and it's a growing industry where there's huge amounts of money involved in that industry as well, and a growing industry contribution. Just a simple Google search brings up so many different companies and organizations that are selling various products. And just a few examples are on the slide in front of you. Now, on the face of it, those industries, those organizations, they look pretty legit. And actually, to a consumer who may not understand some of the risks and I guess the lack of quality within the industry, they may take that really nice clinical looking pharmaceutical grade organization and think that those products are going to be fine. But what we see on this screen is the reality of some of the underground steroid labs that are being exposed. And there's lots of interactions between sectors, whether that's law enforcement agencies, border control, national anti-doping organizations working together to address a growing concern around the illicit drugs market. And here is an example on the left-hand side there of some underground labs where steroids were being produced, and a screenshot from one of the National Crime Agency investigations that led to identification in the UK of a supply and trafficking team that essentially had brought 42 tons of illicit anabolic steroids into the UK. And the connection there is important in that supply chain was also then coming through into the gym and fitness network. And that was evident in the case. And actually the research is identifying the connection between the supply chain and issues of trafficking with the being embedded within the gym and bodybuilding scene. So again, that interaction between settings and sectors is a very important one when it comes to iPad use behaviour. If we then go back to some of the points I've raised around the supplement risks, there is growing concern as well around there's a growing market for supplements and has been for quite some time, and increasingly the identification of adulteration and contamination within that industry as well. This is a publication from Peter Cohen on one of the stimulant sources within supplements, where they tested 24 supplements and none of those supplements had actually been accurately labeled. So the consumer will rely on the supplement labels to try and understand what is within those supplements, but is being misled in some cases by some manufacturers and suppliers. So product consumer behavior is a challenging one, and it's a field where there is clearly a concern around the regulatory framework of that industry. But we've also got within the industry of nutritional supplement use this concept around the power of persuasion and the power of social proof within the decisions to use or not supplements. And we've certainly found that the internet is a go-to place for information around supplement use. Unfortunately, the vast majority are not seeking advice from qualified dietitians and nutritionists. Instead, it's what you see here on the internet. And just some examples there of this wisdom of the crowds. There's lots of almost like star ratings around the efficacy of products. And we've certainly found in our research people saying that that's where they go to. They look what's said online, what the reviews are, and if it fits all 5 stars, then they'll go ahead and purchase it. If you'd have looked at just that site, you wouldn't have also seen some of the reviews that said that this product can lead to diarrhea and abdominal discomfort, etc. So we've got to be mindful of that wisdom of the crowds and the social proof that drives some of our decisions and behaviours. So within the FAIR project that I was involved in, that issue of labelling and the issue of essentially uneducated consumers really came through from the experts that we interviewed. And it's something that is going to need tackling as we move forward in terms of raising awareness of the concerns being shared by the industry. But what do we do about that? And clearly a collective action is necessary across sectors and organisations. So just to conclude, to address harmful image and performance enhancing drug use, I hope some of the ideas presented today and by others is starting to make people aware that we do need to take action on the dopagenic environment, those sectors, settings and networks to enable individual behaviour change. It's not just a case of individual agency and individual responsibility. That changes at sector and setting level can affect social and cultural norms and values over time. And a comprehensive whole system strategy therefore enables collective responsibility for this population health threat. It's not just about public health officials that have a responsibility to take action here. There are multiple sectors that are capable and able to make some positive changes. And therefore this whole system approach requires effective behavioural, environmental, social and system interventions. So sadly, there is no quick fix, there is no simple solution and one size fits all, but there is the potential if more people work together to address the potential harms that arise from isoPED use. So thank you very much for listening and for your time today. Always happy to chat this further, and if anyone's got any questions, please don't hesitate to contact me. Thank you.
My name is Dominic Sego. I'm an associate professor at the Department of Psychosocial Science at the University of Bergen. I participated in this conference 4 years ago in Liverpool. So I'm very excited again to be participating in this conference in Manchester. Now, before I start off with my presentation, permit me to travel through time and commend Jim McVeigh for his wonderful inaugural professorial lecture yesterday. For many of us, especially the young ones like me, he personifies dedication, he personifies hard work, and he personifies innovation. So thanks for all your work, the inspiration you provide for all of us young ones in the field, Professor Jim McVeigh. Now, I'm an associate professor at the Department of Psychosocial Science at the University of Bergen. I'm affiliated to a newly formed lab, the Human Enhancement and Body Image Lab, with the Addiction Research Group at the University of Bergen's Faculty of Psychology. My presentation is titled The Global Prevalence of Anabolic Androgenic Steroid Use. And I start off, first of all, with an outline of the presentation. I'll first of all describe the studies that form the basis for this presentation, look into some results in terms of the prevalences and some issues in there, and round it up all with some 10 prevalence hot issues on prevalence that I think are relevant and emerge from the studies that are used in this presentation. We start off with a look at the presentation, the global prevalence of anabolic androgenic steroid use. And when we talk about prevalence, and since this is a public event, I'll try to be as less technical as possible. When we talk about prevalence, we're talking about the proportion of a population that share a given characteristic. What proportion of a population share a given characteristic over a period of time. So if we talk about the prevalence of anabolic steroid use, and I'm not going to go into anabolic steroids because I understand that this has been covered in the presentations by Skip Pope and Astrid and co. So when we talk about prevalence, a proportion of a population that shares a given characteristic at a given time period. So the prevalence of anabolic steroid users, the persons who have used anabolic steroid within a certain period. So if you talk about, for example, the past month prevalence of anabolic steroid use, we're talking about how many people have used anabolic steroids in a population over the past month. We can talk about the past 6 months. We can also talk about lifetime prevalence, where we here refer to how many persons have used anabolic steroids over the period of their lives, their lifetimes. Now, the prevalence is important because it shows us the burden of the particular variable or characteristic that we are analyzing. In order to come up with interventions to address the use of anabolic steroids and the associated harms, which have been explained by Astrid, which have been explained by Harrison Pope, we have to understand the burden of the issue. Okay, so the goal of these studies were to analyze and understand the prevalence of anabolic steroid use over the world. Before this study and before the 1990s, most studies on anabolic steroid use prevalence were conducted in Western countries. But since the 1990s, there have been various other studies on the prevalence of anabolic steroid use around the world. And it's important to statistically quantify and come up with the burden in terms of the prevalence of anabolic steroid use. 2 papers form the basis for this presentation. The first is a meta-analysis. Now, as I've said, I'm going to be less technical. In a meta-analysis is a statistical software or a statistical method for combining results from multiple studies. Okay, so if several studies address the same question, in this case, the prevalence of anabolic steroid use, we can statistically combine all of these studies to come up with a final effect size, a final prevalence figure across all these studies. So in ordinary studies, people conduct their studies individually, and in a meta-analysis, we combine all these published or unpublished studies to come up with a final result. Similar to meta-analysis, on the right, we have a systematic review. But this is actually a narrative review. So we systematically collected data or literature, but we did not statistically analyze or combine them as we did in the meta-analysis. So that's a narrative review. So these 2 papers form the basis for this presentation on the global prevalence of anabolic steroid use. Briefly describing the methods used in these studies. For the meta-analysis, we try to combine all the studies, all the published studies on the prevalence of anabolic steroid use from 1970 to 2013. 1970 because prevalence studies on anabolic steroid use started around this period. The goal was to examine lifetime prevalence. Okay, persons who indicate that they have used anabolic steroids at least once in their life. So, as I explained with the definition of prevalence, ever use of anabolic steroids is what we sought to cover. We sought to understand globally how many people have used anabolic steroids at least once. So we systematically searched the literature on the topic. There were about 16,600 hits. We narrowed them down to 187 studies reporting original prevalences of anabolic steroid use. Some of the studies had multiple prevalences. If you look into the European surveys on the European school surveys on alcohol and other drugs, the one report actually presents estimates for about 30 different countries or 40 different countries, looking at the earlier ones, so the more recent ones. So because of the multiple prevalences, we came up from the individual studies, we came up with a total of 271 original prevalence estimates published between 1974 and 2013. And presenting from the University of Bergen in Norway, it's exciting for me that the first study that we actually found, the earliest in 1974, was published by a medical student at the University of Tromsø, S. Solberg, on anabolic steroids in Norwegian athletes. So overall, we came up with a total sample size from all the 271 original studies of 2,815,144 persons who participated in these studies. And so we see here one advantage of meta-analysis. In a meta-analysis, we are able to have an increased sample size. It's difficult to conduct an basic empirical study or survey with a sample of 2 million. But in a meta-analysis, we have this advantage of having an increased size. It provides us the ability to increase the sample size and to have a higher sample size, which is beneficial and which is an aspiration for prevalence studies. So over 2 million, almost 3 million persons were actually included in this meta-analysis. We statistically conducted this using the comprehensive meta-analysis software by Biostat Incorporated. And in the map here, we see a description of the sources of the studies. We had 126 studies from North America, the USA, Canada, Puerto Rico, 5 studies from South America, Brazil. We also had studies from, most of the studies came from Brazil, 81 studies from Europe, almost all European countries with the exception of Russia, with the exception of the Holy See, Vatican, 7 studies from the Middle East, Iran, Iraq, Kuwait, 11 studies from Africa, Ghana, where I'm originally from, Cameroon, Nigeria, South Africa, 38 studies from Oceania, Australia mainly, New Zealand, Palau, Northern Mariana Islands, 1 study from Asia, a study by Pope and Kanayama, Yang and colleagues in China. So here we have an overview of where the studies came from. For the narrative review, we included studies between 2016 and 2017. This was a criteria which was presented by the journal editor. So in the current opinion in endocrinology, diabetes, and obesity, who requested that we do this work for them, they only wanted more recent studies, and they indicated specifically that we look into only the last 2 years. And since the study they actually specified that we look into 2016 and 2017. Now here, we only wanted to look into the prevalence, that is, all prevalences were accepted. We're not going to statistically combine them. So we wanted to simply have an overview of what contemporary literature on the prevalence of anabolic steroid use indicates. So there was no meta-analysis here, just a narrative review. We included 32 studies published between 2016 and 2017. In total, the studies included about 2,271,810. About 68,717 of them indicated that they were males. 43,260 indicated that they were females. Many of these studies did not actually break down the samples by sex, so we have some missing figures there in terms of adding the male and female figure. We simply combine these studies by a narrative synthesis approach. Here are some results from the meta-analysis. First of all, globally, with the 271 original prevalence estimates, we came up with an effect size, a total prevalence of 3.3%. So here we find that 3.3% of all the studies from around the world indicates of of participants in all the studies from around the world indicate that they had used anabolic steroids at least once. We have the confidence intervals also there between 2.8 and 3.8. For males, the prevalence from 112 studies was 6.4%. So 6.4% of males in the studies that we included in this meta-analysis indicated that they had used anabolic steroids at least once. The female estimate was 1.6%. And if we look at the global figure, it should actually be of concern to us. If you look and go back to the presentations by Harrison Pope and Vivian Hope and Astrid Bjornberg in terms of the harms associated with anabolic steroid use, this should be of concern to us. The use of anabolic steroids should be a public health concern, serious public health concern for all of us in the field, for medical practitioners, for policy makers. We find that the prevalence for males is significantly higher than for females. And of course, we can easily understand this, that we understand that anabolic steroid use is mainly a male phenomenon. Of course, we know that there's increasing use among women, which should be of concern, but the difference in prevalences can be mainly explained by the fact that females are more vulnerable to the androgenic or the masculinizing side effects of anabolic steroid use. This gap in the field, or in terms of the prevalence, will be wholly covered by the presentations by my friend Charlie McLean and also by my friend Ingrid Havner. So I'm going to leave that for them to exhaustively cover that. And here we have the geographic prevalences. We see a prevalence of 3.0 for North America, 4.8% for South America, 2.4% in Africa, 3.8% in Europe, 0.2% in China, in Asia, particularly China, which was not significant, 2.6% in Oceania, Australia, New Zealand, Palau and Co., but the highest prevalence in the Middle East. And I'll shed more light on this later. But here on this table, we have the global prevalence, the geographic prevalences listed here. The Middle East, with a prevalence of 21.7%. A simple explanation is that in most Middle Eastern countries, anabolic steroids are easily accessible over the counter. We know that Mayada from Jordan would be presenting entirely on the case in the Middle East. So I'm going to skip that because we'll have a whole presentation on that. A prevalence of 4.8 in South America, 3.8 in Europe, 3.0 in North America, 2.6 Oceania, 2.4 in Africa, 0.2 in Asia, which is not significant. Now, the take-home message here is that previously, the position, according to many of the experts, was that anabolic steroid use is only a public health concern in Western countries. But we see from this presentation, from these prevalence estimates, that it is no longer a Western phenomenon. It transcends geographical boundaries. There is also an increasing problem in many non-Western countries. And so we should not only be focused on the case in Western countries, we should also be concerned about the case in non-Western countries. The harms that have been previously presented by previous presenters are also emerging and spreading across non-Western countries. It's important that the effort to prevent and reduce harm among anabolic steroid users is extended to non-Western countries. Now, again, we look into the prevalences for some user groups which were specified in the studies we included in the meta-analysis. And here, the highest prevalence was associated with recreational sports people, persons who are not professional athletes, who just go to the gym, who just run around. Followed by athletes, professional athletes, with a prevalence of 13.4%, offenders, prisoners, arrestees, with a prevalence of 12.4%, drug users, in treatment and all that, who represent or present a prevalence of 8.0%. High school students, adolescents, with a prevalence of 2.3%. Persons in the general population, non-athletes, with a prevalence of 1.0%. So we see that the position previously in the field is that anabolic steroid use is restricted to elite athletes and bodybuilders. This was actually the case in the 1970s and even the 1980s. But we see that the spread has now emerged and is actually more prevalent among recreational sports people. So it is no longer a problem among elite athletes, professional athletes, but among recreational sports persons who seek for the aesthetic and the physical benefits. The athletes there, and it should be of concern in the sports arena, the World Anti-Doping Agency and the efforts to stop the doping in sports. Offenders among persons who have been arrested, among criminals. And we know that many persons use anabolic steroids in order to boost a criminal lifestyle, okay, in order to enhance their muscles because they feel that a hypermasculine physique is an advantage in terms of their criminal conduct, in terms of the exhibition of aggression, and so on and so forth. Drug users, and we know the link between the use of anabolic steroids and the use of other drugs. Persons are now using pre-stacked steroids, a combination of different steroids to enhance the effects. They combine the use of anabolic steroids with other drugs, growth hormone, clenbuterol, and so on. High school students, this should be of concern to all of us. Okay, they are at a young developmental stage, adolescents, and if they keep on or start using or initiate anabolic steroids use, the harms, in terms of the cognitive harms, in terms of the brain that Astrid presented, in terms of the neurological disorders, may actually be irreversible. They may be permanent. And this should be of concern to all of us. Even non-athletes who have no athletic motivation are using steroids for the prevalence. So the message here from these prevalence estimates is that steroid use is not restricted to elite athletes and bodybuilders, but it has spread into the general population, and that even ordinary persons who just go to the gym to exercise are using anabolic steroids. Next, we look at publication year, and we try to analyze in terms of the years in which the studies were published to come up with estimates. So we see that the highest prevalence is associated with the 1970s, with a prevalence of 9.2 from 3 studies. This is understandable because in this period, the persons sampled in the studies were elite athletes who were mainly the users of anabolic steroids in this period. So that's understandable. We see that in the 1980s, it drops to 7.8%. Now, in the 1980s, general population surveys emerged, which saturates the prevalence. Another characteristic of the 1980s is the emergence of underground steroid guides to help in terms of the use of steroids. We see that this drops again markedly to 3.2 in the 1990s. And this is understandable because in the 1990s, we see the emergence of or a clampdown on anabolic steroid use. We see the Anabolic Steroid Control Act of 1990 in the United States to clamp down on the use of anabolic steroids. We see the law prohibiting, or the act, the passing of the act prohibiting the use of certain doping substances in Sweden in 1991. So here, this clampdown can, whether realistically or not, be explained by these. Of course, if it's an illegal activity, then persons will engage in social desirable responding. Even though they use steroids, because it's illegal, they are likely to say no. So the drop can be explained this year. But from the 2000s, we actually see an increase, 3.2%. And this should be of concern to us. So as at the last period of data collection, we see a slight increase in the prevalence estimates. And this should be of concern to all of us scientists and policymakers. But the take home from my presentation is that anabolic steroid use is not just a Western phenomenon, it is now a global phenomenon, and it should be an issue of global public health concern. It's no longer restricted to males. There is also evidence of an increase in use among females, which should be of concern. And the fact that we have two presentations on this topic by Charlie McLean and Ingrid Harkness is very, very, very commendable. Anabolic steroids is also not only restricted to professional athletes. We actually see in this presentation of higher prevalence among recreational sports people, persons who simply go to the gym to exercise. So it's no longer a phenomenon that can be associated with professional athletes. We see it spreading across various groups, and this should be of concern. So that summarizes my presentation. Thanks for your attention, and I'll be handing over the baton now to Mayada to do the case in the Middle East.
Hello everyone, this is Mayada Ozaifi from the University of Jordan, and I'm happy to be among you today in this conference to talk about anabolic steroid use in the Middle East. Hopefully, after the end of the pandemic, we are going to meet in person sometime. So let's start our lecture. The topics that I'm going to cover in the coming 20 minutes, we are going to talk about the Middle East and the authorities in the Middle East, research about the anabolic steroids use, and what the research has revealed regarding the gymnasium's practice, profile, regimens, the reasons, the knowledge and understanding of the anabolic steroids, and the is Middle East. The Middle East is a transcontinental region in Afro-Eurasia, which generally extends from Turkey at the north to Yemen in the south, and from Egypt in the west to Iran in the east. It is made up of a vast number of ethnic groups, and as of 2016, the region has an estimated population of over 411 million. The majority of people in the Middle East are Muslim, and that's why it's important to talk about androgenic anabolic steroid in the Middle East, since the Islamic faith prohibits intoxication from alcohol and the use of substances or behaviors that induce addiction, such as illicit drugs or gambling. However, users of anabolic steroids, or Muslim users of anabolic steroids in the Middle East, perceive these substances differently. Since research by Van Hout and Keen in 2015 found that those users felt that these substances led them to be in control of and promoted their perceptions of their physical and spiritual health, and were not harmful at the same time, thus circumventing religious parameters. This is what is unique or different from the use of anabolic steroids in other regions in the world. Under the umbrella of the World Anti-Doping Agency, in the Middle East, we have 9 national anti-doping agencies and several regional anti-doping agencies that contain some countries of the Middle East. As you know, that the program of the regional anti-doping organizations has been created by the WADA in 2004 in order to strengthen the protection of clean sport by developing an innovative anti-doping strategies for those countries that most needed it. The program supports underfunded and understaffed national anti-doping organizations and national Olympic committees. All countries in the Middle East, they contain either national anti-doping agencies, as I said, in total there are 9, but the rest of countries that don't contain anti-doping agencies contain Olympic committees. Coming from Jordan, I have to say that the Jordanian Anti-Doping Organization was founded in 2007 And in response to the increasing concern about steroid abuse among Jordanian youth, the JADO, the Jordan Anti-Doping Organization, accepted the World Anti-Doping Code late in 2009, committing Jordan to fighting all types of sports doping, including androgenic anabolic steroid abuse. In Jordan, after the death of a 22-year-old bodybuilder in 2011, the Jordan Food and Drug Administration, the JFDA, issued new directives prohibiting the circulation or importation of any foods classified as dietary or sport performance enhancing without JFDA license. Moreover, these directives prohibit the use of such supplements under the age of 14 years and require the package label to be in clear, easy-to-read Arabic language. Speaking about research in the Middle East about androgenic anabolic steroids, in general, the published literature about this topic is limited and goes back to 2006, so it is relatively new. There aren't plenty of studies, actually. What I could find was around 40 studies between years 2006 and 2020. Most of the studies come from Iran, around 14 studies, Kingdom of Saudi Arabia 8, Kuwait 4, and then you can find 1 or 2 or 3 studies from different countries like Iraq, Qatar, Bahrain, Turkey. So in this presentation, I am going to talk broadly about the similarities or the findings in countries in general. And I'm going to use data mainly from the scoping review by Hearn et al. 2000. The work that we have conducted in Jordan regarding this issue. In Jordan, we have around 4 or 5 studies. Doping in gymnasiums in Amman, the other side of prescription and non-prescription drug abuse. In this study, we have conducted a survey covering 352 gym clients in the years 2012-2013 to find the prevalence of anabolic steroid use was 8.8%. In comparison to other study that was conducted in Jordan, the prevalence was 26%, but the difference between the two studies is that the first study, this one with the 8%, included all gym clients, whereas the second focused on 154 or included 154 athletes, bodybuilding athletes. And this explains the high. Talking about first about gymnasium practice in the Middle East. If you look at the literature, actually you could find all types of practice: gymnastics, bodybuilding clubs, sports centers, rec centers, athletic clubs, martial art. And the range of gym use ranged between less than 6 months and more than 10 years, with the majority between 2 and 4 years. This table is from the Jordanian study, and you can see that the majority of those who use gyms in this study, 70% actually were amateur. Okay, and the last continuous training period was either less than 3 months and more than 3 years. The sports included were mainly bodybuilding and more than one type of sports. The purpose of training was mainly, again, more than one and build up muscles. Of the profile of anabolic steroid users in the Middle East, if you look at the literature, you could find that plenty of similarity with the literature in the West. Most users are male, single, and in full-time employment, similar to that reported in the UK, Australia, and the USA. In one study in Iran, 25% of the female users or the female athletes used anabolic steroids. So this study actually was conducted in a female-only gyms and reported that quarter of the females reported using anabolic steroids. The age range of anabolic steroid users in the Middle East was between 14 and 60, with the majority between 18 and 34. The marital status differed by country. In Iran, Kuwait, Lebanon, it was mainly single. In Saudi Arabia and the Emirates, there was no difference, half-half, okay, single and married. Most users were in the higher education status, which is similar to other studies reported in Australia and the regarding the regimens, actually, the predominant route of administration reported in the Middle East was injecting, or both routes, injecting and oral. And the person who injects was mainly the coach or another athlete or teammate or self. The duration of anabolic steroid use ranged between less than 1 month and more than 5 years. The most commonly reported injectable anabolic steroids were testosterone and nandrolone decanoate, and the most common oral anabolic steroid used were methane androstenolone and stanozolol. The use of growth hormone was limited to only 4 studies. As I said, stanozolol and testosterone injectable and methane androstenolone for the oral. Okay, the average products per participant was reported to be 4.8. So 31 participants or clients used 46 products, not only anabolic steroids, different doping products. And that gives us an average of 4.8 per participant. This is actually a study that was conducted in Saudi Arabia and that I like to share with you. The study actually analyzed databases of the Saudi Arabian Anti-Doping Committee from 2008 to May 2016. The samples originated from various sporting events and were collected in and outside of sport competitions. The substances investigated were those included in the annual lists of prohibited substances produced by the WADA. All urine samples were tested in labs accredited by the WADA in Saudi Arabia. And the findings actually revealed that 141 samples out of 4,482 were positive. So the total were 4,482, okay, out of which 141 urine samples tested positive. That gives us a prevalence of 3.1% of prohibited substances detected. The prevalence of positive samples was highest in 2012. The prevalence was 6.6, and the lowest was in 2015. That's 1%. The most prevalent prohibited substances detected were anabolic steroids with a percentage of, as you can see here, 32.8, followed by stimulants. This table shows us the sports with the highest number of positive samples detected among all sports subjected to anti-doping testing in the study by Al-Ghubain in 2017, Saudi Arabia, between 2008 and 2016. As you can see, that the highest positive results were reported among bodybuilders, that is 22 positive samples out of 32. In which the most common substance was boldenone, which is an animal anabolic steroid, and it's a non-prescription drug for humans in Saudi Arabia, followed by methane among weightlifting athletes. The main reported reasons to use anabolic steroids in the Middle East among all studies can be summarized by improving image, increasing muscle mass or improving strength, to achieve attractiveness, improve athletic performance, increase self-confidence and social recognition, and lastly, Another reason was due to advice from friends. Regarding the knowledge and understanding of the anabolic steroids concept and adverse effects among users, most participants were aware of the anabolic effects of anabolic steroids in all studies. However, in some countries like United Arab Emirates, Kingdom of Saudi Arabia, and Iran, there was an inadequate knowledge of adverse effects. In one study in Iran, some users reported to continue to use the anabolic steroids despite knowledge of adverse effects. In another study in Kuwait, it was believed that the benefits of anabolic steroids on muscle growth outweighed its adverse harmful effects, and this explained why some people continued to use despite knowledge or awareness of adverse effects. In one study in Saudi Arabia, 77% of participants who self-declared knowledge of the adverse effects of anabolic steroids said that they would still recommend them to friends. And Hiti et al. In Lebanon noted that users of anabolic steroids were more likely to consume alcohol daily than non-users. A result actually that I found in Jordan that more than a quarter of participants, 28%, stated that they never heard of anabolic steroids or the Arabic equivalent, that is الهرمونات البنائية أو الاستيرودية. Who knew most about the anabolic steroids? Out of the 68.6% remaining who knew about the anabolic steroids, 100% were the mixed martial arts athletes, and 87% of the Muay Thai athletes, and 81% of the bodybuilding athletes or bodybuilders. The least percentage was among basketball players. Those who reported that they knew about anabolic steroids reported different sources of knowledge. In 30% of them, there was more than one source of knowledge, most of which was friends, which counted for 10.8%, internet 10.2%, and well, it is evident at the end that the use of androgenic anabolic steroids in the Middle East is an emerging phenomenon at early stages of diffusion when compared to the UK, US, and Australia. The current controlling methods are ineffective, so it is recommended that the classification of androgenic anabolic steroids become more strict. As you could see from talking about the research in certain countries, that many of these drugs can be bought without prescription in several countries. So we recommend that the classification gets more strict instead of prescription medications or over-the-counter, to become more controlled. Number two, to increase the awareness of the public regarding the dangers and adverse effects of inappropriate use of androgenic anabolic steroids, since research, as you could see, revealed lack of knowledge among many of the participants of anabolic steroids. Number three, it is recommended that the harm reduction or the prevention of inappropriate use of androgenic anabolic steroids becomes multidisciplinary, with the promotion of the role of the pharmacist, since they are the first line of defense in pharmacies and they are accessible to most of the general public. Further qualitative research, number four, further qualitative research is needed in order to identify and prevent the abuse of androgenic anabolic steroids. And I would like to thank you for listening, and if you have any question, I will be happy to answer.
Okay, hi everyone. Welcome to the Q&A for the second panel. I'm April Hunting, I'll be moderating. And we would like to just say again, thank you and welcome to the 290 participants we have participating across this platform and the YouTube channel where this is streaming as well. So hello to everyone. So we'll get right in. We have several questions here, and I'll start with a question for Sue. So you talk a lot about the dopagenic environment and the effect of these on behaviors. How do you see the internet and social media having affected youth behavior? And is social media in itself a bit of a dopagenic environment?
I think that's a really important question. And I think in recent, well, certainly over the last decade, we've really seen that paradigm shift in how people connect and interact. And I think the aspect of the online environment and social media is very much a contributing factor to what we're saying is the existence of this dopagenic environment. We now are far more exposed to sources of information at regular intervals, and we can access it quickly, we can engage in it quickly. And one of the challenges, though, with social media is it is unfiltered. We haven't got the ability to moderate the content and ensure its accuracy. And that then creates that risky environment that is what we were talking about with that dopagenic environment, because within social media, there are some really powerful advocates of anabolic steroid use. And actually the positive effects in terms of the changes in the way that people look and the way people feel, I think critically as well, they are promoted and celebrated, and therefore, particularly for young people who are now exposed to body ideals and certain expectations of norms, that can be very impressionable. So I do think the social media, the internet is a very key aspect of the dopagenic environment, and one that we should look at to consider how do we put the kind of content on there that is not only accessible but engaging to the audience and that helps them make informed decisions. And I think that's our next step really, is to have a bit more balance in the internet and social media.
Okay. And sort of a related follow-on question to that was one around sort of the language that's used on the supplement products that you talked about. So, using things that are like testosterone boosting, bulking, that sort of language. And, does that have an effect on sort of normalizing behavior?
Yeah, so I think if you look at the products now and you consider the significant advertising revenues put behind the sale of those products, that those products often advocate and promote quick fixes. If you think of some of the products that are on the market, they often say that results will be achieved in a matter of weeks, and actually to achieve some of those results through a food first and a proper strength and conditioning training program, they're not going to take a matter of weeks. That's a longer term program. Yet the supplement industry does promote that quick fix mentality, and that can be very enticing to young people.
Yeah. Okay, great. Let's move on to a question for Dominic. This comes from Ask. And this is around your 2014 meta-analysis, and this is one of an incredibly well-cited analysis. But there has been a bit of critique on sort of the methods and how that synthesis was done, in terms of some studies were very small populations with very, very high prevalence, while others were much larger populations with quite a bit lower prevalence. And so how in your research and in your analysis did that disparity and sort of that difference in sampling and result affect the outcome of that global prevalence rate of 6.4% for males and the 3.3% overall?
The homogeneity in terms of the method is key. Now, besides that, we estimate an overall effect size. Besides the overall effect size, we also break down and do subgroup analysis, where we, of course, do analysis for sample types, where we do analysis for regions, where we even do analysis for the types of sampling, whether random or non-random. And we find that the prevalence for random sampling is significantly lower, that's 2.4, than the prevalence for the the non-random sampling, which is 11.4. So if we look clearly into the paper, we address all these concerns. And yeah, that's the answer.
Okay. And a bit of a related question there on from Jim. You know, there was a bit of a lack of studies from Russia and Eastern Europe. And what can we assume about the prevalence there? Is the assumption that it's high, that it's low, that it's something else?
Well, an assumption that the prevalence is high or low there is quite speculative. It has to be. We have to rely on empirical evidence. So all we can say here, in terms of empiricism, is that there's a paucity of evidence in terms of the prevalence in Russia and the Middle East. But of course, we can count on circumstantial evidence from doping scandals with the World Anti-Doping Agency in recent times. We can talk about arrests in these regions. We can talk about an entire industry of Russian steroids to speculate generally that there must be something going on there. But of course, with the lack of empirical evidence, we cannot say much about what's happening there empirically. We can only speculate, and we can speculate based on circumstantial evidence.
And you know, in your presentation, you showed that in the first decade of the 2000s, there was a bit of a spike in terms of prevalence that you know could be partially explained by some of those contextual factors that you talked about. You know, how do you see what is your, I guess, I don't want to say speculation, but possibly knowledgeable prediction about what the current decade might look like when that prevalence study is run?
Well, we live in a very unique age. We live in a social media age. And of course, if you go to social media, we have entire hashtags dedicated to steroid use. And of course, with the blurring of the interface in this COVID-19 era where people are using social media more and more, it is likely that we would have these contexts in terms of the androgenic environment that Sue discussed in terms of its influencing prevalence. But there's something unique that as researchers and scientists, we need to also consider the COVID-19 era and the issue of steroids. We have steroids that are prescribed for persons who test positive for COVID-19. These are not anabolic steroids. They do not have any anabolic or androgenic effects. They are simply corticosteroids that reduce inflammation. But we have this in social media and in the newspapers where persons are talking about steroids. If you conduct research on steroids and you ask someone who has tested positive for COVID-19 has received medication, that person is likely to say, I have used anabolic steroids. But that's going to be a false positive. And actually, this morning I checked on Google Trends in terms of the hits on steroids and COVID-19, and there's been a spike, a real interesting spike in terms of searches for COVID-19 and steroids. So as prevalent, as epidemiologists, as anabolic steroids researchers, as human enhancement drugs policymakers, and so on, we've got to take into consideration the prevalence that are reported. There's a possibility that there are some false positives there. And so we have to go on with verification, ask persons who admit to using steroids to talk about or indicate the particular steroids that they have used, as Pope has indicated in one of the papers. Where possible, we should also do triangulation, use various other sources. For example, testing. I know that work in Oslo by Astrid and colleagues relies on testing by the World Anti-Doping Agency standards, where they compare the testosterone to epitestosterone ratio. So it's important that we also emphasize work in terms of verifying self-reported steroid use.
Okay, thank you for that. Now a question for Mayada. So this one also comes from Ask. So both you and Dominic, talked about this increased prevalence of use in the Middle Eastern countries. And this is seems an interesting pattern as one of the dominant theories for why there's been a rise in steroid use in the West. Really emphasizes women's liberation from the 1960s on. And, there is the theory that this resulted in this notion of masculinity in crisis. And so, the muscle building then is, meant to compensate for compensatory behavior among men seeking to sort of regain some of that lost masculine status as a consequence of women's liberation. So in this increased prevalence in Middle Eastern countries is sort of a challenge to this hypothesis, as gender equality and women's liberation looks a bit different there. So, you know, what is your response to that?
I'm not 100% sure that I get the question. Can you please just repeat it again? Thank you.
Sure. Basically, that one of the theories around why men tend to use steroids is that they're sort of compensating to regain some of the lost masculinity that has resulted from women's liberation in the West. But because the situation in Middle Eastern countries is different, how, you know, your findings sort of challenge that pattern a bit. So do you have any insight into what could be underlying that or behind that?
Yeah, I don't think that there is a contradiction between the hypothesis of this masculinity issue or factor in using image and performance enhancing drugs, the IPETs in general, and the increase in prevalence in the Middle East, because all of the studies, except one study in Iran, they all go with the majority of users are males. So females, they don't really, well, worldwide, they don't like to use AAS because of this their masculinity side effects, as you know. Talking of the women liberation and the movement worldwide, even in the Middle East, and I don't think that this is contradictory with the use of AAS, especially that there isn't much using of AAS among females in the Middle East.
Okay, just to chip in, I mean, of course, one thing we have to consider is that steroids are increasingly powerful in terms of their effects. They are really self-marketing, not only their aesthetic benefits, but especially when combined with a good exercise regimen, we know that it's very powerful. So steroids don't need any advertisement. The benefits are really, really, really clear. And so if they are available over the counter, as in the many Middle Eastern countries where people can just go to the shop and just buy it, people would readily go for it. So that the fact that there's lack of regulation in terms of the regulation of steroid use in many Middle Eastern countries is something really, really powerful that I'm sure accounts for the variance in terms of the prevalence of use in the Middle East.
Yeah. Thank you for that. That makes a lot of sense. Mayad, a second follow-up question on that from Julio here. Is there any data available that you're aware of on problems faced by the partners of AAS users in Middle Eastern countries, things around domestic violence or things of that nature?
No, we did not actually come across anything to do with the domestic violence and AAS. Probably the reason is our keywords, because we did not intentionally, or we were not intentionally looking at anything to do with violence. But I think in order to answer this question, I have to search using the keyword violence, but this was not part of our keywords used in search.
Okay, thank you. Now another one over to Sue regarding NSPs and sort of the overlap between sort of sport and others. So recent research out of the UK is showing that a significant proportion of AAS users are attending gyms, and those that are going to NSPs are also engaged in sport outside of course, bodybuilding. So how might NATO's and harm reduction services work together to sort of protect and promote health of these individuals?
I think what's really critical for us in the future is that element of a comprehensive approach to addressing the harms and risks of anabolic androgenic steroid use. The challenge for the national anti-doping organisations is they have got a responsibility around compliance of a world anti-doping code. And I think because that is the driver of their actions, a harm reduction approach coming from a national anti-doping organisation is going to be at odds to some degree to that compliance narrative and that compliance expectation. But what I think we can do within countries very much is around that comprehensive system where that harm reduction process happens alongside other organisations who have got more compliance regulatory responsibility, so that it's not just one or the other, that they are all available and accessible to those who need it most. And I think we're seeing in the UK an important critical shift in the narrative to athlete welfare. And I think we have seen very clearly some of the risks associated with sporting participation. You know, sport can be an incredible activity and enabler, but it can also bring about vulnerabilities. And I think because we're seeing that happen in the UK and in other countries, a welfare angle will necessitate a greater approach to more comprehensive interventions. So lots of organisations need to work together, and I think we need to get those organisations around the table, and that is happening, but probably not at pace. And with COVID, the risk then is that that kind of falls back again. But that's why today's event, and hopefully others that follow, will be the advocacy that I think Viv talked about earlier, is the need for more advocates to impress upon the need to take that whole system approach and bring those organisations together.
Yeah. And in your view, I mean, sort of related to what you just said, you know, what are those first, you know, critical urgent steps that need to be made by, you know, one of these stakeholders, multiple stakeholders, but sort of what do you think is the most crucial first step in sort of doing the work to promote athlete well-being in this context?
Probably one of the steps that we could get greatest advocacy around is probably education. Harrison talked about the importance of it this morning, and actually all of the brilliant work that and the research that Harrison and Viv and Astrid shared this morning, how do we ensure that that is reaching those who need to receive it, so that it is in a sense helping to inform decisions? At the moment, there is a lack of awareness around those risks. So I think we've got a strong opportunity to really push education. We've seen the need for it in schools. It's not there at the moment. And I think we'd probably be able to help, the lobbyists could help us around that. Clearly, there's a legislation kind of emphasis, and the UK doesn't have any issue in legislation. I know Ask raised this around personal use of steroids. That is one intervention again, but often that needs to come when the public understand the issue. And because we've got such a low awareness of the issue amongst the general public, we've got a lot more work to do around that awareness raising.
All right, thank you. And now this is a question that I think all three of you, given what you discussed in terms of prevalence and your sample populations that spanned sport, gym users, as well as others. But, you know, is there any association in either your findings or in what you can extrapolate from them between the prevalence of AAS use in sport and that within the general population? Or is that a bit of an oversimplification to sort of make that leap? I don't know who wants to go first. But...
Dominic, do you want to go, given I've just heard?
Yeah, I mean, it's that's something that we have to, of course, also I argue in terms of the empiricism test the relationship in terms of the prevalences between prevalences from gyms or from sports and also in the general population. But we can say, of course, we can hypothesize or assume that when there's a higher prevalence in professional sports, you could say that there's something also going on in the general population.
I think it's that element, isn't it, that sport and society are not disconnected. We're talking about human beings who are very, by their nature, networked across lots of different settings and organisations. I think if we come back, though, we've still got an issue of identifying prevalence. You know, we've got workforces, task forces trying to get underneath that so that we have got better data to draw upon to inform decisions and kind of develop that evidence-based policy making. And that comes as well down to what was mentioned earlier around the stigmatizing language that accompanies anabolic androgenic steroid use, and then the silenced and hidden behavioral nature of those actions. So until we start to address that as well, prevalence studies are going to continue to be very difficult to manage and ensure we get the most accurate data possible.
Yeah.
I agree actually with what Sue and Dominique just said. I think we should look at the community and the athletic community as well as being side to side, and they are not disconnected. especially now with even the normal gym users, they started to pay even more attention than previously to their image and to their performance, especially with the social media and all the communication, the technology. I think that they go in parallel and we cannot just separate them, with bearing in mind that maybe the prevalence will stay higher a bit, not maybe significant, statistically significant among the athletes.
Okay, that's interesting. Thank you. And again, related to the same question, the question was originally directed at Sue, but this was before the other two presentations, so I think each of you probably have something to say about this. But if considering something like the dopogenic environment and all of these environmental factors that help to sort of guide or structure use behaviors, would legislation in this case be effective? So I know, Mayada, you mentioned the wide availability. Dominic also mentioned it. Would legislation against use as well as sale be effective for doing this? So other countries have laws against personal use of steroids. Would that work in other contexts? Sue, why don't you go ahead if you...
Yeah, so I guess reiterate, I kind of picked up on that in one of my previous responses. I think without question, legislation is likely to be effective, but it'll be more effective when the public understand why it's necessary, and therefore get on side, support it, kind of emphasize the implementation and adherence to that legislation. I think the need for us to address that physical opportunity and the easy access to the substances is really critical. When you've got 16-year-olds already able to access that in their gym environments, that's quite a significant factor. So we do need to look at then how those agencies are working together to seize the illicit drugs that are entering countries through borders, etc. We're seeing more and more instances where those interagency actions are starting to raise awareness of that. So yeah, without question, legislation has a role, but it has a role alongside other interventions, including education, including persuasion, including modeling and training. To address the issue of the dopogenic environment, we've also got to think about how do we support, if we take young people, their ambitions to change their bodies and modify their bodies through really good sound strength and conditioning principles, but they're not getting access to that information. So we had examples where the boys were saying, well, I just follow so-and-so in the gym. It's and they said it's a blind leading the blind. So there's another mechanism of intervention that I think we as a community can really start to promote as well.
Thank you. Dominic or Mayada?
Well, sorry, I got distracted, but I'll just pick up from the legalization that Sue landed on. I think, empirically, if you look into the 1990s, you see kind of a relationship between the enactment of legislation and the decline in terms of the prevalence of steroid use. In the 1990s, we find the 1990 Anabolic Steroids Control Act in the United States. We have the 1991 passing of the bill on the prohibition of certain doping substances in Sweden, and we see a sharp decline in the prevalence there. So we can see that. But of course, it's possible that this, in terms of the legalization, leads to underreporting in terms of steroid use, because it has consequences in terms of admission of steroid use. So there's something that we can see there. Legalization helps, but it may only lead to perhaps social desirable responding or underreporting, which can have harmful effects in terms of what people go through when they use steroids. So we don't only have to look into legalization, we also have to look into the dopogenic environment in general, as Sue has so articulately expressed.
Yeah. Thank you. Mayada, did you want to respond to that?
Yeah, well, speaking of legislation, as I said in my lecture, that regulations, they do exist in many countries in the Middle East or in all the countries, but the enforcement is the problem. is that they are not strictly enforced in many of the countries, and you can buy them over the counter, and this is the problem. Something doesn't need to happen, like the death of this 22-year-old youth that I talked about in 2011, in order for these medications to be strictly enforced and sold only by prescription. So yes, I agree that something, I think, globally has to be done in order to schedule such medications to be used only under medical supervision. Yes.
Great. Well, thank you. Thank you for those responses, and thank the three of you for three very interesting and engaging presentations. So I see that we are now just coming right up to the end of our time, so we'll have a short break before we come back with panel 3. So thank you all, and thank you all for your wonderful questions.
Thank you.
Hello, everyone. Greetings from Denmark, Aarhus University. My name is Ask Vest Christiansen, and I am an associate professor here at the university. I'm very pleased to be invited by Jim McGuay to this conference on the public health implications of anabolic androgenic steroid use. It is an odd way to give a presentation in this way, but let's see how we can move about it. I'll now share my screen and see if we can get things going. So I've titled my presentation Tracing a Typology of Anabolic Androgenic Steroid Users. And ever since we learned that anabolic steroids were used outside elite sport, especially in the gym environments, we have tried to understand what it is that motivates either a sport, especially in the gym environments. We have tried to understand what it is that motivates, what types of people it is and that has generated a lot of research. And today in my presentation, I'll try to give a few examples of different ways of categorizing or trying to understand users. And this is all in order for us as researchers, but also for politicians and health personnel to be better equipped to both learn about and potentially help and regulate this area. But just to get us started, we know that the odd thing about the gyms and fitness environment, at least, is that we know that it started as a rather small subculture in Southern California. And if we just take Europe today, and if we accept the hypothesis that the fitness and gym scene evolved out of the bodybuilding communities in Southern California, then in Europe alone, we have 57 million Europeans that are member of a gym and fitness center. So to the extent that we believe that there's a spillover from the professional bodybuilding scene into fitness, then there is potentially a really large population of potential anabolic steroid users. Of course, not all of them, only a fraction will use steroids, but still many people have, but even if it's a fraction, it may be many people in absolute numbers. A little bit more background. If we look into Google Books registration of the word bodybuilding from 1950 to 2019, we see that in the first many years there weren't a lot of interest in that, but it started in the mid-70s, actually right about the time where Arnold Schwarzenegger came out with the movie Pumping Iron in 1977. There seems to have been an increase in the interest for bodybuilding right about that time. If we now add the word anabolic steroids to the Google Books registration, we can see that the increase was somewhat earlier than for bodybuilding, namely around 1960. We saw the first increase in the interest for that word, and that happened to be the time where we had the Olympic Games in Rome, where we had the first reports of really heavy use of anabolic steroids in especially some of the heavy events in track and field and athletics. Now, there are different ways of portraying and understanding who users of anabolic steroids are. One way is to take the media approach, which often wants to have either a story based on clickbaits or just sensationalism. So that often comes out with, for instance, teenage boys that may have been hit by the so-called roid rage and have perhaps even committed suicide. That's one type of story that is often seen. Another type of story is grotesque bodybuilders, which are just by their nature fascinating to look at and scary perhaps also in a way. But nevertheless, they don't take up the majority of this population. So the media coverage in that way does not really represent what is going on out there in the gyms. And in that way, it doesn't help us a lot to come to a better understanding. One academic paper that came out 15 years ago gave a completely different view of what this population looked like. They concluded that the typical user of anabolic steroids, and they had been surveyed almost 2,000 users, and they found that the typical user was a Caucasian man who was highly educated and gainfully employed and around 30 years of age. So that was indeed a completely different picture we saw there than what we have seen in the media. However, it may also be so different that it really does not correspond, at least not to what we know from Scandinavia and Denmark, where we also have data on the people who in the Danish gyms have tested positive for anabolic steroids. And if we look at those people and compare them to the background population of non-anabolic steroid using gym members, then we can see that there's a lifetime risk of imprisonment for the steroid users of around 30%, where that risk is only around 5% for the non-steroid using gym members. Also, if we look at hospitalization and mortality, steroid users have a 3 times higher mortality rate than non-users, and they visit the healthcare system around 2.5 times as much as non-users. So that's a slightly different picture than the one given by Cohen and his colleagues in their paper. And these 2 papers just came out a few years ago. Now, there are something that is worth paying attention to when we look at the gym culture compared to other sports. First, it seems to be right to conclude that those who take anabolic steroids are to some degree motivated by bodily dissatisfaction. That at least has come out in a number of publications. So in that way, what they do is different from what people do and are motivated by who start up taking swimming lessons or starting at badminton, who more often focus on socializing or getting skills in their discipline. But so in that way it may be different. But there's also a number of things that is very recognizable. So first, these things are then centered in the individual, but there are also a number of recognizable items not centered in the individual. So most of those who train, and also those who take steroids in the fitness scene and gym scene, they focus on the body itself, but they also focus on strength, health, dedication, discipline, safety, sexual attractiveness, youthfulness, and individuality. And these are all general, really widely recognized Western values. So even if we on the one hand side see some elements that are centered in the individual, we see on the other hand side some more broad, generally recognizable values. So here we have already the first contours of a classification that we perhaps can use to get to understand this population. And those contours could be depicted in a way that Jeff Bates and colleagues did in 2019, where they sort of used this onion shape model to say that if we look at the causes for steroid use, we can use it at different layers. Namely, we can use it look at the individual level, some of the with demographic factors and biological and genetic factors and body ideals centered in the individual. We could also look at the social network level, where we have the feedback from others and the social capital and socialization that goes on there. Or we could look at the institutional level, where there might be some rules and policies in place, and also some perceived social and occupational performance impacts of steroids. But we could also look more at the more broader level, the community level, where there might be some economic factors involved and local policies. And then finally, of course, we could look at the societal level, where there are cultural norms relating to steroids and body ideals, as we just saw in the previous slide. And there might also be these media and popular culture coverage and portrayals of anabolic steroids and body ideals. So this would be one way where we already see some kind of, if not a typology, then a way of ordering different types of factors that influence or cause anabolic steroid use. Now, another way to go about this would be to compare the kind of drug use with other kinds of drug use. So there you could look at the type of drug use that goes on in the fitness scene or the gym scene with, for instance, recreational drug use or recreational sport doping. That would be like cycling or marathon or those types of events. Or you could compare with elite sport doping. And then you could choose any number of factors that you want to look at. Here I've taken the primary motivation for the drug use, the context it goes in, the kind of supervision that's in place, the possible interventions, and then you can't see hiding behind my images is also the legal framework and the healthcare system. And then you could start filling in such a table, and you may agree or disagree with what I put in here, but this is just an example, a way of moving forward, trying to get an understanding of how this population of gym fitness doping compares to other contexts where drugs are also used. So that is also a way forward. Now, you could also, again, look at the types of users where you could situate them and compare them to other types of users. And you could start by having sport-type users on the one hand side, and then perhaps vocational users on the other. And here you would find bodybuilders, as we already spoke about, professional athletes, recreational athletes, strongman contesters, and in the vocational scene, you would have doormen, bouncers, you would have police officers, firefighters, male strippers, models, soldiers, and you could also add a category of, for instance, anti-aging users. That's probably not a vocation, but it's a scene that has grown in the last, a phenomenon that has grown in the last 20 years. So this would also be an approach. What we did with our study was that we sat back and wondered what would actually happen if we began to look for the approach to the steroid use, the anabolic steroid use, rather than more individual parameters such as what population it exactly is, or what sport or vocation the users have. So in order to do that, we got help from one of the old sociologists, namely Max Weber, who used to say that the ideal typology is the social scientist's main tool, and it's a more important tool than the individual concept. And for Max Weber, the typology is then concerned with general or ideal typical traits found in this case in persons with similar approaches and motives. So if we translate this into steroid use in gyms, it would mean that the purpose of such a typology would be to facilitate an understanding of otherwise confusing and multifaceted motives, while constructing types that emphasize the most consistent patterns of steroid users' motives, approaches, and behaviors. And then in that way, you could develop a tool or a heuristic device that doesn't describe real-world people in itself, but is a way to learning about those people. And that was our aim with the typology we developed. And it indeed is a problem. Everyone who has worked with, for instance, interviews or field notes know that you easily get 1,000 pages of notes, and you see everything going in different directions. So you have someone who can, for instance, talk about how they combine steroids with amphetamine and cocaine and booze. You would have someone who could talk about how they started out listening to others, but then began studying drugs more intensely themselves and ended up knowing a lot. Others would talk about this as more about a feeling of well-being, which would be important. And again, a fourth person would talk about how important it would be to compete and to be compared to the best in his category. Now, what we saw throughout our own material and the international literature was that two concepts came up again and again. And one was effectiveness. How effective is it either regarded by the user or regarded by outside specialists what the person is doing? The other thing is the risk people are taking. What are the health risks that is implicated in the use, and to what extent are these health risks managed? And by that, we now have four squares that we can start looking at with a person with high effectiveness and low risk, and that could, for instance, be our person from before, the quote from before, with someone who would really want to know as much as possible. But we would also have a category of users who would go for low effectiveness and low risk. That would be the person who most looked for well-being. And we would have someone with high risk and low effectiveness. That would be the one combining these anabolic steroids with amphetamines, cocaine, and alcohol. And then again, lastly, we would have someone with high risk and high effectiveness. That would be our competing bodybuilder, or someone who was motivated by competitive factors. Now, with that in place, we just need to give catchy names to these 4 types of users, and then this would be the expert type, this would be the well-being type, and up here we have the YOLO type. YOLO is an acronym for you only live once, hashtag you only live once. And then up here in the upper right corner, we have the athlete type. Now, I won't spend much time going through them type by type, but the main idea is that the expert type is someone who is into studying as much as possible about this area, and also take pride in giving advices and knowledge about not only how to gain muscle, but also about side effects and how to protect oneself. The well-being type would then be someone who is more concerned about looking good at the beach, socializing, and not taking big risks, and looking into the side effects, but not as deeply as, for instance, the expert type. The YOLO type would be the one that we often hear about in the media. They combine their drugs, their anabolic steroids, with other types of drugs. They go out on the weekend and the clubs, and perhaps also end up in trouble more often than the other types. And they are likely also younger than the 3 other types. Finally, we have the athlete type, who is concerned with competitive, have an athletic lifestyle, looks after diet, and everything he or she does is concerned with competing and to perform his best. So all these things are sketched out in our article on the typology, and I've also described it in a book that came out earlier this year that I published with Routledge. Now, luckily, we have seen also in other academic papers that part of the typology can be confirmed when you look at more empirical data to see if they match that. And it's also been, the typology has also been referenced in several bodybuilding magazines, which is quite nice. So we've seen that you could go take an approach where you would define users by and the causes for their use by proximal cultural proximity. You could define their use from the group of drug users that they belong to. You could go with their activity or sport, or you could, as we have done, define the users by their approach to risk and effectiveness, respectively. And we found that rather informative. Now, of course, there may be a number of limitations, and this will be my few last slides. One objection could be that drug use in itself is always dynamic and processual, and this would be like pigeonholing users or stereotyping. And my reply to that would be that, of course, that's the case. But in order to understand those processes, we also need to categorize and understand what's the user's general approach at a certain point in time. Now, here's my time running out, but I'll just quickly conclude. Another objection would be that, of course, the typology cannot describe all possible approaches to steroid use, and that is correct. But it does offer some reference points, and it's a way of it can be used to investigate and clarify and systematize one's empirical observations. Finally, the coordinates of risk and effectiveness could be considered rather shallow, a shallow way of interpreting steroid users, but again, they seem to come up in all the reports that we see that this is occurring all the time, these two factors, risk and effectiveness. So in that way, the typology can be used both for researchers, for politicians, and for health personnel to direct and tailor their studies or their interventions. Now, with those words, thank you if you stayed awake throughout this presentation, and I now look very much forward to take some live questions. Thanks.
Have you ever wondered, how does a woman end up becoming a competitive bodybuilder? And at what point does she decide to engage with performance-enhancing drugs, and why? What influences her? What are her motivations? And how does being integrated into the bodybuilding community affect this? My name's Charlotte McLean, and I had all these questions before I completed my PhD within Liverpool John Moores University, looking at steroid and growth hormone use in female bodybuilders. And what I'm hoping to do today is provide you with an insight into my findings. In order to do this, I will start by providing a brief background on female bodybuilding, a consideration of some of the health implications of the use of steroids and growth hormone, thus situating this research within the public health domain, an overview of some of the aims and objectives of the study and the methodology I employed, and finally, an insight into the findings of my research. And in doing this, I hope to provide an illustration as to how one goes from recreational gym goer or indeed layperson to steroid using bodybuilder. And I'm going to illustrate this using three notions. Firstly, salvation, which describes in part the journey into bodybuilding. Faith, which is born from the integration into the community and the relationships formed there. And exoneration, so normalization and justification of performance-enhancing drug use within the sport and the wider bodybuilding community. Now, when you think of female bodybuilding, it might typically be an image like this that springs to mind. Indeed, this is the female bodybuilding division in perhaps one of the most prestigious competitions in the sport, the Olympia. Pictured here is Iris Kyle, who was very successful in this class. Now, over the years, there has been an increase in the number of categories in female bodybuilding, and all these display varying levels of muscularity. However, women can find themselves more heavily sanctioned than their male counterparts when it comes to the degree of muscularity that is rewarded by the federations. And this is evidenced by the fact that the female bodybuilding class has been dropped from the Olympia since 2015. So what divisions might you expect to see at a show today? Well, different federations can sometimes have slightly different names, but broadly speaking, the categories are physique, body fitness, bikini, and more recently, wellness. I'm going to show you some examples of these now. Most of these are winners at the 2019 Olympia, so they are all professional athletes. Okay, so here we have Shanique Grant of the physique division. So as you can see, this requires a significant degree of muscularity and a low body fat percentage. It's judged on 4 mandatory poses, shown here, as well as a round of quarter turns, which I'll come on to later. And the top 6 competitors selected will also get to do a 30-second routine of their choosing. You're judged on overall presentation. This does include hair, skin, makeup, tan, and your stage presence, what the IFBB like to term the total package. You'll notice in this division there's no footwear though. Moving on now, this is Sydney Gillian of the figure category, which is the pro division's version of body fitness. So there's less muscularity than physique and a slightly softer look, slightly more body fat percentage. This is judged on quarter turns, shown here, which will be the same as the physique class. However, instead of mandatory poses, competitors perform an eye walk, which involves walking to the end of the stage and back again. Again, you're judged on overall presentation, the total package. You'll notice there's footwear in this round, And in fact, federations are quite specific about heel height, type of footwear, and the bikinis worn. So moving on then to bikini, and this is Elisa Piscini. So this is a softer, smoother look than body fitness, much more of a commercial model look with slightly more muscularity. In this class, you would also perform the eye walk and the quarter turns. However, the posing is a little more feminine, hands on hips, etc. Again, judged on overall presentation, this is obviously quite a glamorous class. Now, more recently, the IFBB introduced the wellness category, and this sits somewhere between bikini and figure. It's for women who carry a little bit more body mass in their hips, glutes, and thighs. So, although their upper body is developed, it's sort of not in proportion with their lower body. Quarter turns and eye walk the same, and the conditioning and posing is largely based on bikini. Okay, so there are a number of different federations that you can compete in as a bodybuilder. These are just a few of the key ones. So the International Federation of Bodybuilding and Fitness, the IFBB, is a pro division, and you would accrue points here in order to qualify for the Olympia. If you're in the UK, you would become an IFBB pro by competing in the UK BFF, which is the UK Bodybuilding and Fitness Federation. NABO, which is the National Amateur Bodybuilders Association, would be your route to Mr. Universe. And then there are also federations that cater for natural bodybuilding, for example, the NBF, the British Natural Bodybuilding Federation, and the Natural Physique Association. These are some of the key ones. There are federations popping up all the time offering their own pro status. So what about performance-enhancing drug use within the sport? Well, there may be a whole range of compounds used, and this will depend on the competitive phase of the athlete. For example, are they dieting or in the off-season? The division that they compete in, so how much muscularity is required, so body fitness, physique, more likely, but it's not unheard of in bikini. And of course, there are other influencing factors which I'll come on to later on. So my research focused on compounds used to increase muscularity, so steroids and growth hormone. And of course, such compounds aren't without risk or potential health implications. For example, steroids and growth hormone have been linked to cardiovascular, hepatic, and psychological health concerns. Of course, for females, the androgenic effects can be particularly significant, especially those that are irreversible, such as enlargement, deepening of the voice, facial changes. And of course, we mustn't forget indirect harms such as risky injection practices, contamination of illicit market drugs, and dosage and labelling issues. At the outset of the PhD, I developed a number of key objectives in order to guide my research, and these are shown here. To illustrate these more succinctly then, they included the nature and effects of use. So what compounds do women favour and why? How do they make these choices? Do they use oral or injectable compounds or a combination of the two? What side effects or health outcomes do they experience, be these positive or negative? What are the contributing factors? So this includes how one reaches the decision to become an assisted athlete, how competitive status and the influence of others impacts this, and finally, what role do significant life events have to play? Perceptions and attitudes. So this might include perceptions of risk, how people justify use, what is deemed acceptable use, and how performance-enhancing drugs are perceived compared to more traditional psychoactives. And finally, engagement with medical professionals. Is use disclosed to the GP? Was this a positive or negative experience? And what other services have been accessed? And of course, all this should be understood within a cultural context. I chose to use ethnography as the methodology for my research, as it's popular among researchers seeking to understand deviant subcultures and drug use. It allows the opportunity not only for participant observation, but through immersion, a route to understanding the lived experience of one's subjects. The methods I employed include participant observation within 2 gyms, One was local, which I attended on a weekly basis, and the other in southern England, which I visited on a number of occasions and had previous history with. I also conducted 11 one-to-one interviews with female bodybuilders, both previously and currently active. I also planned a photo elicitation element to the research, but due to time restrictions, this became more of a case study and provided me with supporting data. There was also a strong autoethnographic element to this research, so I was involved in the training and dietary strategies that bodybuilders employ. I attended bodybuilding events both on my own as well as within gym groups. I was subject to a number of aesthetic evaluations for competition preparation, and of course many informal conversations, all of which were recorded in a number of journals and field diaries along the way. So obviously with ethnography, one ends up with a good deal of data. So it's probably not possible for me to distill the complexity of bodybuilding culture and steroid use in women completely. However, in the next few slides, I will attempt to provide you with a flavour of my findings. Becoming a bodybuilder requires one to embark upon a significant body project to achieve the physique that the sport demands. In order to do this, you must engage in the rituals and practices of bodybuilding culture, and these can be quite consuming in terms of time and effort, going to the gym, preparing food, you may well alter your social occasions. It seeps into many areas of your life. In doing so, it has potential to distract a person away from other life events, and therefore it may provide a way of coping with negative situations, as well as being a means to transform your identity and finally achieve your physique goals. Although everyone I spoke with had a different story to tell concerning their own personal journey into bodybuilding, all of them fit broadly into one or more of these narratives, whereby bodybuilding offered salvation from an unruly body and life. These included the desire to change one's physical form, significant life events or experiences such as bereavements or illnesses, a career change, for example, moving into the fitness industry, a loss of identity when children are grown up, desiring a new focus or challenge. For some, bodybuilding was a redemption from the trappings of an eating disorder, whereby disordered eating practices in the pursuit of the thin ideal were alleviated through the quest for muscularity. So, why bodybuilding? Well, all of my participants had been exposed to the sport in some way. Some had partners or family members involved in the sport and had attended bodybuilding competitions as a result. Others were approached in the gym and asked if they'd thought of competing in bodybuilding. Some were inspired by the pages of bodybuilding magazines or other fitness profiles online. For me and others, it might be the gym that you happen to end up in. For example, I randomly started training at a bodybuilding gym because it was the most convenient one at the time. I was exposed to a good deal of hypermuscular bodies, including women. I started buying Muscle and Fitness magazine, and before I knew it, my ideal physique was in line with the bodybuilding cultural ideal. Bodybuilding offers salvation, and it also rewards those who successfully achieve the physique valued by the community and federations. I use boudoir to describe this. So, for instance, the achievement of the appropriate physique, i.e. physical capital, also results in social capital. So you gain a load of new friends, a whole community, maybe even a romantic partner. If you are successful in the sport, you'll be validated by the community and gain cultural capital. If you are a coach working in the fitness industry, you will attract more clients, so more economic capital. I also noted a more contemporary form, virtual capital, in the form of likes, engagement, validation from a much wider community for your virtual avatar. So the notion of salvation also has clear religious connotations, and indeed bodybuilding bestows the individual with a moral worthiness. This is echoed repeatedly in the mantras of bodybuilding and the cultural discourse that upholds the hard-working and dedicated individual who has adequately policed the organic desires of the body, overcoming hunger and pain, etc. So where do steroids and growth hormone come into this? Well, bodybuilding perpetuates the idea that one can have absolute control over one's physical appearance, The body is an object, to be refined and perfected, a possession that in a certain form becomes a valuable commodity. All that is required is to simply do the work to achieve the expected outcome by utilising the tools of the trade correctly, such that the reasons cited for using steroids and associated performance enhancers among women I spoke with was the desire to achieve a certain physique, to expedite their results, and to be competitive on stage. Some, like myself, had trained naturally prior to this, but chose to transition to being an assisted athlete due to their inability to achieve their desired physique by any other means. Steroid use in this context is essentially a means to an end, a tool in the toolbox that assists in achieving the desired result. Now, of course, whatever strategy you have employed to reach and maintain your ideal physique, it's likely to be the one that you sustain. You therefore may feel somewhat dependent on steroids, as you fear the physique created with the assistance of these drugs will also be lost without them, although interestingly this was something that stopped me from using. Bodybuilding, like mainstream culture, rewards the body aesthetic it deems most valuable. This can be in constant flux for women. Indeed, the muscular body that attracts the most capital is one that readily performs femininity, and it is often hypersexualized, devoid of adipose tissue, and not marked by AAS use. This does beg the question as to the degree to which bodybuilding offers any salvation from the expectations placed on women in modern consumer society. To be a successful bodybuilder, one must have faith. Trust the process is a common source of advice one might hear from peers as one struggles to adhere to the myriad of rules regarding diet, training and supplementation in the pursuit of physical perfection. And the coach can be an important figure and influence in this process. Indeed, the coach can represent the key to success for many. They are a godlike figure whose expertise and knowledge are upheld because of their position of authority within the wider bodybuilding field or gym. And this has been granted to them through the accrual of various capitals: cultural, social, physical, and increasingly virtual capital. And all of these hold far more credence than academic or industry qualifications. The coach's capability is therefore evidenced by their own and their clients' successful physiques, and as such their methods and ethnopharmacological knowledge is accepted, regardless of whether it fits with proven sports science or nutritional guidelines. Often the advice provided by coaches is dogmatic, such as the notion of clean eating, and this is really common in bodybuilding, and consists of the prescription of a restrictive diet consisting of a few allowable clean foods, often things like chicken, rice, sweet potato, oats. And because, of course, the term clean eating has no clear definition, these allowable foods may differ between coaches. However, what is clear is that one must adhere without question. Certainly, I've experienced situations online when to query any protocols can leave one open to the wrath of those who vehemently believe in its absolute efficacy. Indeed, it can feel a bit like querying someone's religious faith. As well as the delivery of dietary and training protocols, the coach can be influential in the use of steroids. Many of the women I spoke with had taken advice and guidance on both the type and administration of steroids by coaches or those acting in a coach-like capacity, such as training partners or gym peers. Like the protocols of diet and training, this advice is trusted and accepted as simply another adjunct to the process of transforming one's physique. Having faith in the process requires one signs up for all of the necessary elements of the protocol, such that when an extra pill must be swallowed, it is reasonable to see why many accept and trust that they are simply making another valid choice in order to ensure their success on stage. Furthermore, in many cases in my research, the coach also acted as a supplier, and hence any barriers related to obtaining the relevant compounds were removed, and faith in their authenticity automatically assumed. Many of the women I spoke to had not considered that the advice they were being given might be suspect. With often no background knowledge, they had few benchmarks by which to make such judgments. Only with hindsight did some recognise that they had been recommended incorrect dosages or compounds for their training level or goals. However, this did not seem to erode their trust in the next coaching figure they employed or the nature of the source of the advice they listened to. As such a good deal of faith lies with the cultural authority figures, it is not surprising that many bodybuilders are reluctant to seek or heed advice from outsiders, especially the medical community. Of the women I spoke with, few had sought advice from the GP regarding steroid use, unless directly concerned over a significant side effect. While some felt it was important to disclose under certain circumstances, many were reluctant to, or had experienced a negative reaction. In summary, faith and trust are required to become a bodybuilder. Faith in the process and trust in those members of the culture who are ordained with the authority to prescribe the necessary protocols for bodybuilding success. As we have seen thus far, the journey into bodybuilding involves integration into the community, and with that, the development of relationships that involve trust and faith in the process of becoming a bodybuilder, where steroid use is viewed as a means to an end in order to be successful on stage. Alongside this may also come a gradual realization that others in the field are also engaging in this behavior, and that within the context of competition, it's par for the course. Within bodybuilding culture, there exists an acceptable level of steroid use, and as long as you remain within these parameters, use is authorized and legitimized by the community as a normal and acceptable part of the protocols required for competition preparation. Use is therefore exonerated, and this legitimization by the community allows one to retain the authenticity of one's physique achievements despite steroid use. However, at this point, I should note that this line between acceptable and unacceptable use can be narrower for women, when muscularity begins to push the boundaries of gender norms. I also noted in my research that many of the women I spoke with used similar vocabularies of motive to Monahan's work when justifying their steroid use. These included self-fulfillment and constructive rationales. Here, use is a legitimate means to an end, so steroid use is constructive and controlled, and particularly for women when it's for competition. Denial of injury. Many of the women I spoke to had experienced side effects, including androgenic effects, loss of menstruation, as well as some health-related issues. However, they did not view their steroid use as significantly injurious to their health, and these side effects were not considered enough to discontinue use. Appeals to normality. One example of this was someone likening their use to tanning or the use of Botox. Someone else compared it to taking a vitamin pill. Condemnation of condemners. This is directing attention to others' deviant behaviour in order to neutralise one's own. Examples of this are often, "Oh, I don't smoke or drink." And finally, one I noted, the relativising of use. So this involved women justifying their own use by comparing it to someone else's who had crossed their personally defined line into the extreme, usually defined through more significant virilization, often described like, "Oh, I don't like women who look like men. It's taking it too far. Oh, I don't want to look like a man." So I'm going to finish there in the hope that I've provided you with at least some insight into the process of becoming a competitive female bodybuilder and how integration into bodybuilding culture can influence steroid uptake. Thank you very much for listening, and does anybody have any questions?
Dr. Mike Salinas. I'm a senior lecturer here in the Department of Sociology at Manchester Metropolitan. My talk today is about behaviours of steroid users and the ways in which their behaviours elevate the risks of use. And we know that there exists significant diversity in terms of behaviours and practices amongst the wider steroid using population. There isn't a typical user or a singular pattern of use. So today I want to look at the risk profiles of a particular group of individuals in a particular setting in an independent hardcore gym in the north of England. Now, this was an environment where the use of steroids and other iPads was not only normalised, but actively facilitated by gym members, by staff, and by the owner of the gym itself. So, I'm interested in the notion that certain subpopulations of steroid users are engaging in practices that heighten the risks of use, whether through almost reckless behaviour or through a sort of hedonistic subculture on shared norms and values that they have. Bit of context first. We know that many steroid users are engaged in risky behaviours. So I just want to draw your attention to two studies. The first being that of Begley and colleagues, and the national survey published in 2017. And the second being Christensen and colleagues' study of 37 steroid users from 9 different countries. So firstly, looking at the national survey results published in 2017, this was really interesting because it showed that about 3/4 of this sample had consumed alcohol once a month or more, and of those who reported drinking, I think it was about 43% were classified or could be classified as binge drinking when they drink. That's consuming 10 or more units of alcohol in a single session, so about equivalent to a bottle of wine. Further to that, around 47% of respondents had used an illicit psychoactive drug in the previous year. And this is significantly higher than the general UK population, which during that year was 8.3%. So recreational drug use of psychoactive drugs was 6 times higher amongst the individuals here. Another thing worth noting is that a significant proportion of people who first used steroids were teenagers at the time, which again poses risks in terms of the body's natural development and production of hormones during this critical developmental stage. And the other study that I wanted to point to was Christensen's study, and they looked at 37 people who'd used steroids and came up with what they called the 4 ideal types of users. Now, 2 of these users are worthy of note, particularly for this presentation. The first was the you only live once type. These were generally a bit more reckless in terms of their behaviour, quite hedonistic in their sort of subcultural groupings. They used psychoactive drugs and they experimented with different iPad combinations, different lengths of use. The other group that was engaged in kind of risky behaviours were the athlete types. So many of these individuals would not stop using, but would simply switch between substances rather than taking a break. They also engage in other potentially high-risk behaviours such as using insulin, but for the most part this group viewed these risks as calculated and believed that for the most part they were in control of them, undertaking the right mitigation techniques. So this study is, and the data I'm going to present is based on an ethnography which myself and a number of colleagues undertook a few years ago in an underground-ish independent bodybuilding gym. Now, for further details on it, you can read up on the methodology in the paper Polydrug Use and Polydrug Markets. But just very briefly, this was a male-dominated gym where the vast majority, between 70 and 99%, were users of steroids and other iPads. Although this paper is about heightened risk behaviours and practices that might be a concern, the first thing that I want to do is qualify the findings being presented. It has to be stressed that the majority of those we interviewed or spoke to during the field work were actively trying to educate themselves on steroids and the associated harms of these drugs and other iPads, safe practices, and also trying to educate themselves in terms of mitigating unwanted side effects. So these weren't passive consumers, nor were they ignorant to the dangers of these drugs. But as we'll see, some did show some willful ignorance towards it, but for the most part, just like Christensen's athlete's time, many saw the sort of risks of use as being pretty inevitable, but for the most part calculated. So very briefly, when it came to the risks from injection, everyone we spoke to was really knowledgeable in terms of what the risks were and how best to mitigate it. In terms of the awareness of risk that stemmed from the use of these drugs, such as damage to the key organs or the cessation of the body's own production of testosterone, again, these guys were really clued up. And again, for the most part, many tried to mitigate these risks either by coming off, having during their cycles, using post-cycle therapies, or avoiding, say, oral tablets. I'll let you read these, or you can pause on the slide, but just these are sort of typical responses in terms of the dangers that arise from either injection practices or through the drugs themselves. So what are the elevated risks then? Well, with that in mind, and the idea that these people were not passive and were trying to educate themselves, let's look at the behaviours which we identified where risks were likely to be elevated. So in order to do this, I've split the findings. Polydrug use, poor and inconsistent regimens, medical conditions, and poor injection practices. So let's look at polydrug use first. This was the finding that the vast majority of those we spoke to were using, a plethora of different image and performance enhancing drugs. Human growth hormone, the stacking of multiple steroids, oral and injectable for the most part, and other things like insulin, amongst, I think it was 3 of the 20 that we'd spoken to. So there was a real mix of enhancement drugs, image enhancement and performance enhancement drugs. But in order to mitigate the anticipated side effects, many were also using therapeutic drugs, whether it was Viagra to deal with erectile issues, or whether it was, say, mid-cycle or post-cycle treatments, tamoxifen, all these kinds of drugs to help alleviate, again, some of the unwanted side effects. But in addition to this, half of those we spoke to were also using psychoactive drugs, principally cannabis, cocaine, and ecstasy. If I go to a rave, I'll take MDMA, but it's probably about 3 or 4 times a year, so it's not very often. But when I do have a session on it, I hit it hard. I used to be on the cocaine every week, maybe 3 or 4 years, maybe more. I think the last time I used coke was about 2 months ago. Another individual we spoke to. I do take cocaine. I don't take it very regularly. I'll only take it if I'm out. But I do drink alcohol exactly the same as before I wasn't using steroids. And I do smoke cannabis. And finally, the more extreme end of the spectrum in terms of their sort of psychoactive drug use. I had a fucking blowout the other day. I ended up eating 20 ecstasy tablets, drinking champagne, vodka, and all that. I had about 1/8 of cocaine as well. It's not good, is it? Is that a regular thing that you use these drugs? Is it recreational most weekends? Cocaine, definitely. Every weekend for the last 7 months. The second category then is to do with poor injection practices. And this was the idea that, that we had concerns about the sterility of the environment, the injection sites, and certain practices that individuals were engaged in. So here's a nice anecdote that many people seem to reference the same case. A member took steroids, but he didn't wipe his arm with alcohol wipes. He just banged it in like that. Half there, straight out, banged it in the other arm. He only gone and got an abscess, and he had to have a big chunk of his arm removed. His shoulder, he's got a big cut on his arm and his shoulder now. And this exchange that one of the researchers had with 2 of the older gym members is particularly illuminating. I never do it here. Well, why not? It's filthy. I've only been here a few days, and the amount of guys who are doing it here, yeah, but that's them, isn't it? Yeah, I wouldn't. Even though they wipe them with a sterile wipe, they're picking up something and this and that, and then they're blowing on it when they're injecting them. And I just think, germs, it's dirty. I know why they do that. It's because one lad did it, and then another lad copied it. And I thought, why are you blowing on this side? Actually, the research team was able to document this, not that exact case, but this practice with individuals, one individual who was injecting his friend, blowing on the injection site whilst injecting him steroids. The next thing is to do with the sort of regimens. The fact that many of those we spoke to had disclosed quite extended cycles. So whether that was 6 months, 7 months, 9 months, or more. Many also disclose high doses of drugs, and many also seem to suggest that certain batches of drugs that they'd taken had been a bit dodgy, and they were concerned with the quality of the drugs and what they were actually injecting. The longest I've used is over 12 months, just one course to the next, maybe even 18 months, something like that, until either you've got no money to buy a course, which generally isn't the case, or you need to stop. There's a lot of fakes going around now. I probably injected some shit trying to find one that worked well, but now I've found one that works well for me. And I'm quite happy in the way that I do it. I don't need 12 weeks off. If you look at the Olympia lads, they never come off. If I was going to cycle, it should be 10 weeks off. So 12 weeks on, 6 weeks off, That's usually what they say, but you can stay on them all your fucking life if you want. It doesn't make no difference, does it? I've been using flat out for pretty much about 7 months, which isn't very good. It's time for a break. The final category of risk that we don't have an awful lot of time to delve into is to do with pre-existing or newly emergent medical conditions, which users disclosed to us. And they continued using iPads despite these risks. So there was some to do with mental health, whether it's to do with depression, panic, anxiety attack, but potentially more risky was physical health issues, continued use despite jaundice of the liver, individuals suffering blackouts or dizzy spells, erratic heartbeats, and individuals using despite having known heart conditions. So how is it that these iPad users were getting informed? Why is it that we documented so many high-risk behaviours amongst a group of people who were actively trying to educate themselves and trying to source information in terms of best practice and use? So information was sourced from 3 key areas. First was observing or speaking with fellow gym members and their experiential knowledge, or the knowledge of staff who worked there, and suppliers, people who sold it on, but also online posts, online forums. Now, for the most part, people first got their information from fellow members, staff, suppliers, and then would follow this up by going online, going on forums. It's not that these individuals are necessarily uninformed, but if anything, there was almost a proliferation of opinion and advice, and the information that they were exposed to was at times contradictory. What someone would tell you at the gym or what the supplier would tell you might contradict something that they'd read online, vice versa. So the vastness of opinion on offer was at times actually compounded by the fact that, as many said to us, everyone's body's different. Different doses or different combinations work differently for different users. And so what this meant was very often it boiled down to a sort of trial and error approach, which is what one individual termed it. Picking and choosing some advice, trialing it, seeing what the outcomes are. So that was part of it. The person who first supplied them to me was like, here you are, this is the perfect course for you. And obviously, I don't just take his word for it. I go away and research. I'm not naive like that. I will research about it. Just Google it. And that's true of almost all the guys we spoke to. They never took anyone's advice at face value. I used my training partner's experiential knowledge first. They went into the readings and picked up bits, but it's hard. There's nothing out there proper. Like I say, it's called bro science. It's just off the lads. Compounding the problems of this proliferation of information and advice is the fact that certain individuals who we spoke to were uninterested in heeding any advice or educating themselves. And even if the right information could get to them, whether or not they took that on board is a separate issue. So this is from the gym owner on a commercial supply of steroids. I had a guy in here last night. He popped in because he was after some stuff. He was saying, oh, it's not really doing much for me at the moment. And I said to him, well, how long have you been on, mate? And he said, 42 weeks. I said, what, you've been on for 42 weeks? He said, yeah. I said, you don't have anything like HCG? No. I said to him, listen, mate, you need this, this, and this, and you need to come off cycle ASAP. But he just took everything with a pinch of salt. He's going to stay on, you know, but that's his life, innit? I didn't know nothing about what I was using first time. I never read up on what I'm taking. I don't know. I just thought if it was that bad, people wouldn't sell it to you, really. So it can't be that bad. There's no point reading up on it. Everyone here uses it, so it can't be that bad or cause death or anything, really, I suppose. Now, this last example and this last quote I think is really important because it shows to an extent in this environment where you know, use of these drugs is so widespread and normalized, that in itself is a direct and proxy indicator of practice and risks. You know, the normalization of steroids in this person's social circle is, in their view, evidence enough that the drugs are safe. So why bother educating yourself about it? Just copy people. Do what they're doing. There are probably hundreds of fucking risks I don't know about. Do you feel like you want someone to fully inform you of the risks? Or, I'm not really bothered, to be honest. I'm here for as long as I'm here, aren't I? Ultimately then, it came down to this. Most of the people we spoke to were aware of a range of risks that were there, that were present. But the rewards on offer from continuing use, from using extended cycles or using a whole range of drugs, going out and partying, outweighed the perceived risks. Now, partly it may be because many of these risks may be to some extent decoupled. You're not going to experience, you know, heart failure potentially until your 60s. But if you've enjoyed your life and felt good throughout much of it, then that's the important thing. The rewards outweigh the perceived risks. And the rewards were pretty extensive. It wasn't just about physical gains, but it was about well-being. It was about the craft of shaping your body. It was about learning new techniques. It was about implementing these techniques, getting more skillful. It was about the fraternal society that existed in this place. And for some people, there was actually, you know, it helped them deal with potential depression or anxiety or other mental health issues. The gym was therefore really prominent in these men's lives. And in light of that, the potential risks from excessive use or from use of, you know, such quite extensive polypharmacy were not deemed serious. I'd say about 50 to 60% listen to what I've got to say and what the duty manager's got to say. For a lot of people who don't come off, it's not because they don't know the risks or the advice, it's because they're scared of losing their sights. So, sorry for that whistle top talk. I have had to cut quite a lot out. So in conclusion then, this presentation looked at the extensive range of concomitant behavioural risks that were identified during my team's ethnographic work in this independent bodybuilding gym. What we found is, to an extent, again, differences between individuals, but generally speaking, a subpopulation who on the one hand made lots of efforts to educate themselves on the use of these substances and also employed a range of risk mitigation techniques, but on the other hand, were willing to sort of trade off several perceived risks in favour of greater or sustained gains. Again, these gains weren't merely aesthetic, but personal well-being was often cited as a motive for intense personal regimes and continued iPad use. And again, that sort of supportive fraternal environment that existed was important. The risks that we identified were to do with it, the ever-evolving, often high-dose, often extended use of iPads, their concurrent use of therapeutic and psychoactive drugs, poor injection practices, and sustained use despite seeming medical risks. So, in conclusion, what is the policy challenge here? How do you deal, firstly, with the proliferation of opinion or information that is out there in order to get the right information to those who are trying to seek it out? How do you promote best practice to those users? And then further to that, how do you then go about engaging those, even amongst this cohort, who are unconcerned by the risks? I'll leave it there. Thank you.
Hi, my name's Maya Underwood from the University of Queensland in Australia. Today I'd like to talk to you about enhanced bodybuilders' perceptions of steroid risk and their harm reduction practices. But first I'd like to thank Jim and the conference team for this opportunity to present my research. I'm really looking forward to hearing what conference participants think about what I have found. I'd also like to thank the enhanced bodybuilders who shared their stories. It means a lot to me that they trusted me to represent them. Now, I don't have a huge amount of time today to tell you about my research, so I'm not going to give you too much background or detail on the methods, but if there's anything else you'd like to know, please feel free to ask me during the question time or shoot me an email after the conference. So to briefly set the scene, despite the acknowledged importance of consumer engagement in drug harm reduction, there's been very little engagement with people who use steroids. Steroid risk and harm reduction has primarily been conceptualized from an outside perspective. People who use steroids have been constructed as risk takers. They're seen as recipients of care rather than as actors in harm reduction. The outside perspective is only one perspective on steroid risk. Distinct risk discourses arise at the point risk is experienced. Being the individual at risk and negotiating that risk affords a different perspective on risk. Risk assessments or decisions on appropriate risks to be taken are not made in a vacuum, but are always social processes influenced by cultural frameworks. Broader social, political, economic and cultural forces play themselves out at the local level, thus forming a context that shapes not only which dangers are faced, but also perceptions of risk. As Oakes and Hawthorne state, judgments of relative safety or appropriate risks are almost entirely social/cultural. This project explores the social and cultural dimensions of steroid risk. Specifically, it examines how enhanced bodybuilders construct steroid risk and the strategies they put in place in order to reduce the harms of steroids. This project puts the steroid user in context. That is, it examines the risk environments and enabling environments of steroid use, or the spaces in which factors interact to increase or reduce the harms of steroids. This kind of framework envisages drug harms as a product of the social situations and environments in which individuals participate, and therefore shifts the responsibility for drug harm from individuals alone to include the social and political institutions which have a role in harm production. I've spent the last 3 years conducting an online ethnography of enhanced bodybuilding communities. That is, I created online profiles in social media and forums and used these to observe and interact with consumers of steroids. In so doing, I've interacted with hundreds of consumers and observed interactions between thousands. But a core group of participants informed this research. That is, in-depth interviews were conducted with 34 enhanced recreational bodybuilders who were recruited primarily through online interactions. And some demographic details of these individuals are made available on the slide. What I found was that there is a significant difference between how enhanced bodybuilders want to use steroids and how they actually use steroids. In this presentation, I'll describe the ideal practice of steroid use and the reality of use. I'll do this by describing the risk environments that increase risk and the enabling environment that reduces the harms of steroid use. The ideal practice of steroids, which bodybuilders admit would be extremely difficult, if not impossible to ever achieve, would be to use steroids whilst in open and honest communication with a non-judgmental and well-informed health professional who's working from a solid scientific foundation, who supervises use and monitors health and assists with the prevention and treatment of harm, including the provision of regular blood work to determine the effectiveness of use and the actual or potential harms, including hormone levels, kidney and liver function, lipids, gonadotrophins, and iron. The ideal in practice includes the prevention or treatment of harm, including post-cycle therapies, aromatase inhibitors, and phlebotomy or bloodletting if necessary. While ideal practice includes these harm reduction strategies, there is much debate about when these harm reduction strategies should be performed. The legal and medical environments within which steroid use is constructed as a deviant risk practice have numerous consequences for steroid risk. It is in these environments that research into the harms and benefits of steroids and the effectiveness of harm reduction strategies is severely constrained. This lack of research has a significant impact on the ability of health providers to understand use and provide well-informed advice. As Jack said, in the end, general practitioners and even endocrinologists don't know anything. There hasn't been the medical research done into it, really. A doctor can't say to you, take this drug, it'll stop side effects, because they can't legally do it. Even if steroids were legal, if it hasn't been proven through clinical trials, they can't say it. GPs are evidence-based practitioners. Science has not sufficiently explored the doses bodybuilders use and the harm reduction practices they employ. The illegality and stigmatization of steroids prevents consumers from discussing their use with health professionals. When a user suspects something is wrong, they don't want to go to the doctor because they're afraid of repercussions. If they do go, they lie about what they're doing. How can a doctor fix you if you mislead them? Even if people who use steroids are honest with health practitioners, these practitioners may refuse to provide support. If you go the route of using these drugs, you're pretty much on your own. Furthermore, if health professionals desire to provide support, they may be constrained by policy and unable to provide services such as the specific blood testing consumers require. In response to the limits placed on harm reduction by the macro risk environment, enhanced bodybuilding communities create their own enabling environment. That is, they congregate online and discuss steroid risk and harm reduction. In contemporary online bodybuilding communities, scientific knowledge is privileged. This was not always the case in bodybuilding, and it's only recently that bodybuilding has entered what has been termed an age of enlightenment. There has been a very clear shift in the collective mindset of strength culture. It's no longer enough to know that things work. It's become far more important to know why they work. Over the course of the past 2 decades, research has gained an almost deific status in the fitness industry. Studies are considered by many to be the final word on any issue. It has become relatively common in bodybuilding discussions to link to the publicly available abstract of scientific papers in PubMed. However, bodybuilders must fill the gaps in knowledge and make theoretical leaps from the context in which the research was conducted to the bodybuilding context. To do this, they often turn to community experts who typically combine a convincing knowledge of the existing science with a current or former body that demonstrates expertise in the practices of bodybuilding. These individuals are trusted members of these communities and have significant influence on bodybuilding practice. Enhanced bodybuilders will often encourage caution. For example, in response to a post from a bodybuilder beginning use of trenbolone at 400 milligrams, one bodybuilder responded, "Way too much tren for your first time with the drug. I got tremendous results from 120 milligram of Tren E. Tren isn't a drug to just fuck around with. Unless you have a contest in the next 8 weeks, I'd drop it completely or cut dose in half." With the age of enlightenment in bodybuilding, there's come an expectation that enhanced bodybuilders regularly monitor their health. Like 8 years ago when I started, I barely saw a thing about blood work, but nowadays it's huge. A lot of people do it. If you don't have access to blood work, I don't think you should touch it because you are playing with fire at that point. The results of blood work may be posted online for discussion. Indeed, if an individual complains of side effects from steroid use, they're commonly asked by community members to provide their blood work, so members of the community can attempt to explain the experience of side effects. Thus, online bodybuilding communities promote evidence-based practice, whether that evidence comes in the form of scientific papers or individual health monitoring. But online bodybuilding communities are not just enabling environments. They're not just environments that reduce harm. They are also risk environments. Numerous factors may result in enhanced bodybuilder harm reduction practice being less than ideal. Although science is deified in online bodybuilding communities, the significant gaps in knowledge mean that steroid practice can never be completely evidence-based. The science they do is nothing compared to what guys actually use. Therefore, as described earlier, enhanced bodybuilders will often turn to community experts to extrapolate from the existing science to the bodybuilding context. These community experts do so with varying levels of competence. While some have doctorates in relevant disciplines such as biochemistry and exercise science, others have no scientific or medical training. Some members of online bodybuilding communities will be termed PubMed ninjas because they cherry pick from the scientific literature and make invalid extrapolations. In one closed community, who likened themselves to a cult, the community expert who led the group, who was not scientifically or medically trained, not only gave advice to enhanced bodybuilders about how to maximize benefits and reduce or avoid harms, but he also advised them on non-bodybuilding related health issues such as diabetes. Online bodybuilding communities fill gaps in knowledge and also attempt to address the lack of health service provision. For example, members of these communities circulate advice regarding ways to reduce harm despite the medical system. These include lying about being an injecting drug user in order to donate blood and reduce the risks of high hematocrit, or ordering blood work through private companies, some of which are crowd-funded by enhanced bodybuilders themselves. Risk may be increased by this climate of uncertainty. The fact is that there are many disagreements between enhanced bodybuilders about harm reduction. Should PCT drugs always be taken only if indicated by blood work, or taken only if trying to conceive? Should AIs always be taken or only if indicated? Does using DECA only cause or prevent harm? People who use steroids tend to feel disconnected from the medical and scientific communities who have denied the effectiveness of steroids until as late as 2000 and overstated their risks. They describe few significant harms. There's literally millions of people all over the world that are using anabolics and that have used them in the past, and they're not dropping dead left, right and centre from heart attacks. I'm in good health myself, and that's after 15 odd years of use. So where's the proof that they're dangerous? If harms are experienced, there is a tendency to attribute them to misuse or abuse of steroids. People are more willing to attribute harm to misuse rather than inherent risk. But feelings of safety may be due to factors other than the actual risks of the drug. A lot of people who start using it start underestimating the dangers because the government is lying, and suddenly they don't think there's anything true anymore because they're lying anyway. Many participants describe themselves as not abusing steroids. That is, they didn't use high doses or combine them with recreational drugs or the abuse of prescription drugs, so they felt relatively safe. Continuous use of steroids would have been considered abuse as little as 10 years ago, and individuals would have been crucified for mentioning it in an online forum. However, the blast and cruise use pattern, which involves the continuous use of steroids in that a blast phase, where high doses of steroids are used, is alternated with a cruise phase in which lower doses of steroid are used, has become quite socially acceptable in the last decade. The logic behind blasting and cruising is that it results in less loss of muscular gains than cycling off, and it prevents the side effects of very low testosterone levels experienced when coming off cycle. Online bodybuilding communities have very different perceptions of risk than do outsiders, especially healthcare professionals. As a result, immersion in these communities impacts on perceptions of risk, and certain harms can become normalised. I remember at that time I was very carefree with my drug use. Now, there are all sorts of aspects that come into that: an increase in knowledge and exposure, normalisation of usage through exposure, and other things. But definitely my perception of risk had changed. You'll know yourself now, having spoken to users, if you speak to them about being infertile or having testicular shutdown, some of them, they're very casual about it. They're very casual about it's like, well, if my balls don't work, I'll just go on TRT. But you speak to a non-fitness person or a non-user about the fact that they may now be drug dependent for the rest of their lives, and they'll be like, oh, fuck, shit, they'd be devastated. We do very much normalise problems. There's a significant discrepancy between how enhanced bodybuilders describe the ideal practice of steroids and the reality of steroid use. The ideal is evidence-based practice while being supported by knowledgeable healthcare professionals who assist them to reduce the harms of use. However, the macro-risk environment, particularly the ways that the legal and medical systems construct steroid practice as deviant, constrains both understanding and support. Thus, it is left to enhanced bodybuilders themselves to fill the gaps in understanding and design their own harm reduction strategies. However, they're not typically trained to do so. Furthermore, because of the history of academic and medical practice, they tend not to trust those who are trained in these areas. Instead, they trust their own community to fulfill these roles. The result is steroid practice in an environment of uncertainty and disagreement. This is a long way from the evidence-based practice that they desire. There exists a wide variety of steroid consumers, from individuals who use in a haphazard manner, along with psychoactive drugs and pay little attention to exercise and nutrition, through to the dedicated bodybuilder utilising a controlled regime of enhancement drugs to supplement a strictly adhered to program of exercise and nutrition. The participants in this study sit firmly in that latter category and may be best characterised as expert users. As such, they are the most risk-averse and health-conscious of steroid consumers. While these expert users are very vocal in online communities, they may be the minority of steroid consumers. However, they are extremely influential. Enabling environments tend to be discussed as places that outsiders construct for people who use drugs, for example, through interventions. But it's perhaps better to conceptualise enabling environments as not something we, as outsiders and experts, create for people, but as something people create for themselves. Therefore, our role as outsiders is to provide appropriate guidance. We cannot force others to share our views of risk. Rather, we need to understand what risk actually means to participants themselves so as to help create the conditions where risk reduction becomes possible. This paper raises many questions for future research, such as, are bodybuilders actually reducing or preventing harm when they use the strategies described in this paper? A registry of steroid consumers could be built to collect longitudinal data on their use and health. Given the turn towards scientific knowledge in recent years, I'm certain that many steroid consumers would desire to contribute to such research in order to provide an evidence base for steroid practice. This research suggests that harm reduction advice should not be told to enhanced bodybuilders, but rather discussed with them. Harm reduction may be something steroid consumers already do, so it's vital we first understand their practices and their rationales for performing them. But perhaps the most important implication of this study is the importance of trust when it comes to harm reduction. Trust has been found to play a vital role in decisions regarding risk-taking, especially in situations of uncertainty, where trust can act as the equivalent of or substitute for knowledge. Given the environment of uncertainty and the disconnect between bodybuilders and outside perceptions of the risks of the bodybuilding lifestyle, it's hardly surprising that enhanced bodybuilders turn to individuals they trust, the community experts, for guidance in their risk decisions. But given the recent turn towards health monitoring and evidence-based practice, the time is ripe to build relationships between bodybuilders and the scientific and medical communities. By building trust, we can turn the two discourses of steroid harm reduction, the inside perspective and the outside perspective, into one discourse and thus maximise steroid harm reduction.
Hello, everyone. I'd like to thank Ask, Charlotte, Mike, and Maya, I got it right, for their engaging presentations, really highlighting how important it is to take a multidisciplinary approach to kind of further our understanding in this field. The work around typologies, the contribution of ethnographic approaches and lived experiences, really, it highlights the diversity of the population that we're dealing with and reveals the very human stories behind the numbers that science kind of tends to rely on. And those human stories are absolutely crucial to not just to develop our understanding, but to develop effective responses. So I'm not going to talk anymore because I'm aware that we've kind of cut into time a little bit now. So I'm going to jump straight into the questions. So to start with, because there's a lot of questions that are kind of fed off this. So there's a question for Ask. Have you had an opportunity to discuss your categories with the users? So for instance, do YOLO types recognize themselves as risk takers?
Yeah, that's a good question. Yeah, so that's a good question. Especially if we look at the YOLO. I mean, if you approach most people that are still using, they like to see themselves as expert users, expert types. That's sort of the normal reaction. However, YOLO type users, we actually, I don't think I mean, I have talked to them afterwards, but that's after they came off their use, and they would say, well, I was definitely a YOLO type user, but I wouldn't know back then. And I think this actually points to perhaps a general problem in interacting with these populations, that we do have a general sampling bias for this group of users, the YOLO type users, because they are not interested in answering our questionnaires or being part of our interview studies. So the YOLO type users that were the empirical backbone for our study were someone who no longer were using. They reflected back on their use when they were, and from that reflection we could construct the YOLO type user, and also from various other sources. So especially for the YOLO type users, no, we didn't talk to them back then. Those we talked to were former YOLO type users, and they could certainly recognize themselves as such.
Okay, interesting. So Charlotte, do you think female users fit into the same kind of typology that Ask has outlined? If not, what kind of typology do you think would exist?
I can see some similarities in the females that I spoke to. I mean, the nature of my study was that I was speaking to competitive bodybuilders, and therefore, you know, they would fit into the athlete type at the point of me speaking to them, and at the point of uptake of steroids. So yeah, I can see some similarities there, and some may then move into expert type as they, you know, become more integrated into the community and potentially become, you know, coaches for others. And that had happened to some of the women that I'd spoken to. Not so much in the sort of using sense, but many may enter bodybuilding as a typical sort of well-being type, looking to sort of change their body in some way, and I suppose move as they move into the community and become engaged in competition. That's when they ultimately would more likely engage with steroid use. As for women, it seems more legitimized to use steroids within a sort of within the context of a competition.
Okay, that's interesting. Ask. There's a number of questions around the typologies. So, for instance, do you think that one group is particularly more prevalent than any of the others?
So that's an empirical question. And the whole idea behind the typology as it was developed originally by Max Weber is that it is an ideal typology. It's an ideal not in the sense that it's normatively ideal, but it's as a thought construct, an idea. So in that sense, it's not the idea with the typology is not to go and check whether empirical real life people fit on a one-to-one basis with the typology. So I think it's rather important to stress this part, that you can build a typology with several types around any sociological issue. So you could also make an ideal type of say brothels or nunneries, and then you would see that any specific empirical brothel or nunnery would not fit that typology on a one-to-one basis, but you could build those typologies so they describe the most consistent patterns. And the same goes with the steroid users. Now, luckily, there are other good researchers out there who have tried to see whether empirical data, to what extent empirical data could fit the typology, and that I refer to work done by René Sarnov some years ago, where they looked at more than 600 steroid users from the National IPED Info Survey. And in that, they found that the most prevalent group was the well-being type, which was around 38%, if I remember correctly. And the least prevalent one was the YOLO type with 12%, and then 25% for both athlete and expert. But that may not actually reflect, again, what the real world looks like. So I think here again we see an element of a sampling bias, that if we only have 12% YOLO type users in that survey, it may reflect that the average age, if I remember correctly, was around 30 years of age, and you don't have the younger generation, those who actually live with booze and other drugs and go fast. They are not the types that go in and reply to such a questionnaire. So that would be my reply to that.
Okay, thank you. Hopefully there's a number of questions about how services might respond to those different typologies and how they might kind of target each one. And I think that probably answers those questions quite well.
Well, I could just supplement on that or add to it that we have actually, with my colleague Anders Winter, we have tried to see how different types of harm reduction or interventions could look if they use the typology. And certainly you would have to approach these persons who you identify to belong to one type more than another. You would have to tailor your intervention more directly, and they don't. It really stresses that point that one size doesn't fit all, and you would definitely have to go with a different type of information, education, and intervention for an expert type user than for a YOLO type user.
Okay, thank you. Question for Mike now. So steroid users and hardcore gyms are quite difficult to engage with, and this is a kind of perennial issue. And I think I'd like to ask Maya to answer this question as well, possibly. What lessons have you learned from your research that you could pass on in how to engage with these groups in a kind of meaningful way?
To be honest, we were fortunate in terms of having gained. Can you hear me all right, Martin? So I'd had some technical issues. Yeah, so we were fortunate because there's a few people, just a few key individuals in the gym, and really it was dependent upon the relationship and rapport from a research standpoint that we already had with them, that they were able to vouch for us and talk about the work that I'd done previously. So it was the gym manager, but he was sort of the gatekeeper in the traditional methodological sense, and he was able to talk about what it was like to have been interviewed firsthand. But we were lucky because he was, quite a significant figure in this place. The fact he was able to sort of vouch for us. But it was also useful because we were spending a lot of time in the gym. We ended up going for food with the guys, training with them. So before really you get down to the business of asking them a whole range of questions, because we were quite novice. We came at it as criminologists, myself and principally in the three other field workers. So really on in the field work, just about spending time and building up some rapport rather than just going in firing questions straight away. But yeah, so we were privileged in the sense that we already had access to a key individual in the group.
Okay. What about you, Maya?
Yeah, look, it's a very similar story to what Mike is talking about. It was initially a really hard community to break into, especially online. I was getting, FBI hats and things photoshopped onto me. Why undercover cop? Why would we talk to you? Sort of stuff. But once you got some members on board, and especially those very influential community experts, if they could do a shout out for you, or I found creating YouTube videos explaining why I was doing my research and sort of what this kind of research is about, which is their voices and privileging their perspective rather than coming in with some preconceived ideas of what is important, sort of reassures them that you're not there to critique only, you're there to understand. So if you can show some respect for their knowledge, which is often in my community of participants, and as I said, is very biased. You don't get the YOLOs, they're too busy living once. But amongst these expert users, it's very important for you to respect their knowledge. They've got a huge amount of knowledge. And I'm a social scientist. I can't judge their nutritional understandings, their drug pharmacology understandings, and these. I can't judge the accuracy. All I can do is report what they're telling me. It's up to other people to do that. And so, I sort of have to have a respect for what they're doing, and they pick that up.
Yeah, I think that's absolutely crucial. Thank you for those. Charlotte, so coming back to you, we know very, very little about female anabolic steroid users. How would you compare, if your research showed this, how would you compare a kind of typical female steroid user's cycle with that of a male? So in terms of the products they use, the doses they use, the time on, and whether or not they discuss the issue of post-cycle therapy?
Well, yeah, I mean, my research, I suppose, wasn't heavily focused on specific sort of compound regime. So this was sort of talked about in quite general terms with the women I spoke with. I would say that for many, it was the starting point was always sort of oral, usually oxandrolone. That was for most people their starting point, and then it would depend on their goals in terms of muscularity as to whether they moved on to injectables further in their career, or if they were very focused on immediately going up to those heavier categories for competition. I think one of the key things to note is for the majority of those that I spoke with, it would be the coach figure in that process that was key in determining what they may take for any one competition phase. And so for many, they simply relied on the advice of that sort of significant figure, usually a coach or training partner or peer in the gym who was considered particularly knowledgeable in that area, who would be the point of contact and the person who would decide on that, and they trusted that advice absolutely. And for some, they did recognize in hindsight sometimes they had been given the wrong advice and they had been put on quite strong injectable compounds very early on in their career. Yet they did still go on to trust the advice of the next coach. I mean, in terms of, how long people were generally using for, again, this varied and was dependent on advice received. Usually people were using fairly short cycles. But again, someone had been told to stay on for a whole 6 months, and that's her first experience of use. There was not really much discussion in terms of PCT. The only thing that was mentioned was that often sort of herbal supplements were taken post-cycle in order to detox from use. But other than that, there was not really any evidence of that in people I spoke to, certainly.
Oh, okay. Clearly an area for more research. Unfortunately, we're out of time. We have a ton of questions, and my apologies to all the people whose questions I didn't get to. But I've just been told we're out of time. We could talk about this all day, but we have another session to go to shortly. So I'd like to thank Ask, Charlotte, Mike, and Maya for their contributions, and see you all again shortly.
Thank you.
everyone. Thanks very much for tuning into this presentation. My name's Jeff Bates. I'm a research associate at the University of Bath in the Institute for Policy Research. I'm going to talk today about interventions for people who use anabolic steroids. Firstly, quite broadly, talking about the state of the evidence base, what we know, what we don't know, perhaps where some of the gaps in that evidence base are, and then moving on to talk specifically about treatment interventions, to continue some of the themes from the first part of the talk. So I've put quite a lot of thought in the last few years around anabolic steroid interventions, and I've been recently thinking about what specifically really it is that we're interested in when we talk about interventions targeting people who are using steroids or trying to change something to do with steroid use. And this is all very, very sort of broad. This is certainly not a kind of a conclusive set of questions. But for me, these four questions are perhaps the ones that we're perhaps most commonly interested in. So how can we prevent steroid use? How can we reduce the harms associated with that steroid use if for someone who does go on to choose to use anabolic steroids? How can we bring about and maintain behaviour change? So moving somebody from that sort of that user status towards a non-use, being a non-user, and then keeping that going. And then fourthly, how can we treat the sort of the harms associated with steroid use? So we know we have an increasing body of evidence that suggests that there are a range of physiological and psychological harms, whether that's sort of short-term or longer-term associated with steroid use. So how can we sort of treat those harms and support health amongst people who do choose to use steroids? And it kind of strikes me that there's these underlying issues across all of those different areas of interventions. And that is this big, kind of really big question of what are the opportunities to deliver interventions, and as part of, similarly, kind of how can we engage with people who use anabolic steroids? So it's these kind of questions like, well, how can we increase engagement between people who use steroids and health professionals or health services? We know that often that engagement doesn't tend to be particularly high. So how can we kind of increase that? Where we do have engagement, how can we deliver effective interventions in services and in sort of healthcare settings? And the other side of that, how can we provide information and support outside of healthcare settings as well? So it's kind of question of, well, we might start to understand what we mean by interventions and what kind of interventions work, but how can we actually be in a position to deliver these? And that's, I think, relevant to treatment, as we'll come on to later, in terms of what are the opportunities for actually delivering some of these interventions that we want to. And I find it interesting to look at, think about this in terms of the size and the quality of our evidence base. And what we've got over the past 20, 25 years is a real increase in the amount of evidence that we have around anabolic steroids that together, I think, establishes this need and justification for interventions of the types I outlined before, so prevention, harm reduction, and treatment. And so we have a growing body of evidence that has we've learned a lot from, in terms of things like risk factors, characteristics of people who are using steroids, their sort of preferences, their experiences, their motivations, all these sorts of points, as well as some of the harms perhaps. And yes, so that is still an evidence base that can increase, but I think we can agree that this is a substantial evidence base in which to say, yes, this is where we might need some sort of interventions. In contrast, we have this really small evidence base, however, which is the studies of interventions themselves. And really that is almost entirely made up of studies looking at prevention efforts. And so the evidence base on interventions has not kept up with the evidence base around our kind of understanding around anabolic steroids and the harms and why we might want interventions. What do we actually want to find out about interventions? What do we need these studies for? Yes, of course, a big question is around what is effective. And that sort of traditional approach of evaluating an intervention to find out if it works or not. Does it bring about the outcomes we want? But what we need to know goes a lot beyond that as well, which I think sometimes gets a bit lost. And this kind of, I guess it's a question there. If you look at realist sort of evaluation, this is a very similar question to what you're finding in that sort of realist approach. Kind of what works for whom, where, and why. So it's really around, yes, we want to know what is effective and what isn't, but also what will affect the implementation of these interventions. And it's these sorts of questions like I've listed here around what's kind of going to be acceptable to people, what is possible to deliver. If we deliver an intervention, what are the sort of the spillover effects or the unintended consequences of these interventions are going to be. And this is sort of inspired by sort of implementation science field. Is really trying to understand not just effectiveness, but these other types of questions. And this is where we need different types of evidence. So when we talk about evidence to inform interventions, we're not specifically thinking only of these sort of nice controlled studies where we compare an intervention with another condition and see what the outcomes of that are. We're talking about sort of evaluations of services being delivered to people using steroids, kind of qualitative studies looking at the perspective of users, people delivering interventions in health staff, in services, or any other settings. And asking those questions to try and find out, well, what do people want? What is feasible? What's the sort of the barriers to delivering some of these interventions? And all of this is really missing from the evidence base at the moment. So in terms of our studies of interventions, then, what we have at the moment is evidence from really over around 30 years worth of primary prevention intervention, evaluations of primary prevention interventions, usually based within schools, in school sports settings typically, trying to reduce the chance that people will, these young people will go on to start to use steroids later in life. It's a very mixed evidence space. It is quite an incoherent set of studies really that don't really follow on from each other, or it's quite hard to know on for what reason they've been developed, whether they're sort of replicable, and the sort of implementation side of it isn't really there. And so while we can learn lessons from this evidence base, it's perhaps got sort of mixed use for us really if we want to know around, well, what should our prevention interventions be about. And there's an awful lot missing from this evidence base, and if we want to go on to develop interventions, not a lot to learn from in the evidence base in terms of sort of targeted prevention approaches around engagement, how to sort of induce behavior change amongst people who are using steroids, whether that's to adopt sort of more harm reducing behaviors or to sort of move towards cessation, or around treatments. There's very little to go on here. And interesting though, I think, we know that all of these types of interventions are going on in the community. For example, in the UK and other countries, we have an established needle and syringe program, which intends to engage with people who are using steroids. We know that in parts of the UK, people who use steroids are a really significant client base for lots of needle and syringe programs. We have very little evidence that actually tells us whether these approaches are effective or not, or how to improve or their effectiveness. Some other examples we have, we know of gym-based interventions in the community, for example, in the Nordic countries, but again, we lack the evidence on whether they work or not, and what it is about them that means whether these interventions are likely to work or not. And so we really need more studies of these existing approaches to help us understand them. And just to highlight again that, yeah, we're talking about a lack of studies of whether these interventions are effective or not, and also of their implementation. So yes, do they work, but also why do they work and why not? What are the important factors there? So let's move on to the sort of the main focus of this presentation, which is going to be around treatment interventions. And it's an area that it's interesting to me because of all the different sort of those four intervention areas, I think that treatment's probably the one that I've up until last year spent the least amount of time on. Why I find it interesting is that I think and this is all very tentative, as well as being, as an excuse to put a dinosaur into the presentation, which I always will when I can. I actually wanted to make this point that these are kind of quite tentative conclusions for me, and that I'm not completely sure about them. But for me, it seems that treatment interventions is perhaps the intervention areas where I think there's the clearest aims for what we want to do, and the clearest populations for who we want interventions to reach, to engage with, and to affect. Also, possibly the least evidence of effective approaches in the evidence base to date, anyway. So it's an interesting area, I think, to look at. Again, this isn't anything that's sort of published or has been backed up with much science, but this is how I kind of categorize treatment interventions in the work that we've been doing, which I'll go on to talk about briefly. And similar to sort of models of drugs interventions for other types of drug use, I think. Where I think that treatment interventions can be kind of fit into these different categories, which really do overlap as well. When we talk about treatment for people using steroids, we could be talking about this sort of behaviour change approaches, so motivating and supporting someone to move from that sort of user status towards stopping using their anabolic steroids. As part of that, supporting their recovery, so is helping that cessation become a long-term change, and preventing sort of reinitiation as well. And this might be referred to as sort of recovery. I'm not sure about some of the language in this, but I'm trying to make it consistent with what we might use for other types of drug use. And then again, associated with that, we have these sort of treatment interventions in terms of treating the harms associated with steroid use, whether that's these acute or longer lasting psychological or physiological harms. And obviously, again, these three areas overlap. So where we are motivating and supporting cessation, we're also thinking about supporting that in the long term. And as part of that, there's likely to be some sort of treatment in terms of treating harms as part of it. So I don't see these as three independent areas, but something we have to think about all as one package. So we undertook a study, a sort of systematic scoping review, which looked at what is the evidence on treatment interventions. And we tried to find what is known about interventions that aim to support and achieve cessation of anabolic steroids, and interventions that treat and prevent associated health consequences. So really those three overlapping areas from the previous slide. This was carried out with colleagues, at the time we were at Liverpool John Moores University, so with Marie-Claire Van Hout, Joe Tay and Jim McVeigh. And the paper, I've linked the paper here if anyone is interested. It's an open access article. So I'm not going to talk about the details of the paper at all today. And in some ways, the detail is, I don't know, of limited interest, but the messages I think in it, I think are interesting anyway. And hopefully you will do too. So these sorts of questions that we were trying to kind of really find out was around, well, what sort of treatment interventions are effective? How can they be delivered? How can we engage with people using steroids? What sort of settings should they be in? These are all the things we wanted to find out ideally through this review, in terms of how can we really, that core question of how can we support and achieve cessation of anabolic steroids. I'm not going to talk about the detail of this. It's the afternoon session, and the last thing most people are probably going to want is around detail of a systematic review methods. I could talk about it all day, but I know that not everyone is quite as infused. But I wanted to highlight a couple of points, which is that we included any study within this review that reported a treatment given to people who use anabolic steroids in response to a harm that was associated in that study as relating to their steroid use. And that's the important point, that we made no attempt to sort of understand whether that harm really was as a result of their steroid use or not. But if it was picked up in the study that this was treatment that was needed for a harm that was relating to steroid use, then we included it. And we actually found what sounds like a lot of evidence, so 109 studies to include within this review. But the real problem with this was that all of these studies were case reports. So they were all examples of individuals who had who experienced harm and required some treatment for it. There were no sort of controlled studies at all, no qualitative evidence to sort of help us understand that implementation side of things. And if you've ever looked at sort of published case studies, so these are published in all sorts of different, really sort of quite technical or medically specific journals. And what you find is that there's a great diversity in how they're reported. So in terms of the types of evidence that they actually give within these case studies, it varies so much. And typically they tell you a bit between a very little and a lot in these sorts of areas, around the detail around the harm this person's experiencing, around the characteristics of the patient, around their steroid use, the treatment they received and the outcomes of that. And all of those different factors varied so much between the different studies. So it's very difficult to make any type of comparison in terms of what's effective, what's not, and why, because that's not what the case studies are designed to do. So this isn't necessarily a criticism of the studies, it's just the nature of that type of evidence isn't really conducive to understanding the sorts of things we need to understand if we're going to be able to build up this evidence base. Just to highlight some of the findings from this review and then put them in a bit of context. So our main question was around, well, what sort of interventions are effective to support and manage cessation from steroid use? And without going into the detail, essentially we found no evidence about treatment following a diagnosis of anabolic steroid dependence, or about interventions to motivate or support cessation. And we know that we put some detail in the paper about a few studies that kind of touched upon this, but there's nothing for us to go on. In terms, if we wanted to develop a new intervention, there would be nothing here to help us to do that. What we did find was a lot of different interventions to treat a range of harms or side effects that were associated in that paper to be something to do with that person's steroid use. But what does that actually tell us? Well, the short answer is not very much. And the slightly longer answer is that these studies together tell us that people who use steroids sometimes will need treatment for a range of associated harms. And we kind of categorize these according to the categories in the table here. So you can see the types of harms that were being reported. Sometimes these harms can be very serious. I mean, there are examples of patients who unfortunately died and others who had quite long-term complications. But generally speaking, these harms were successfully treated using a variety of treatments. We didn't make any attempt to try and sort of establish whether these were appropriate treatments or not. That would be well beyond well, certainly beyond my knowledge anyway. But there are a lot of different treatments are attempted for all these different harms. And what kind of perhaps most interestingly for us, these medical treatments don't appear to be accompanied by any additional interventions. These kind of behaviour change or harm reduction or any kind of engagement interventions that we might have hoped to find. Because if we come back to those kind of key questions about interventions, for me, this underlying question is one around how can we actually, what opportunities do we have to engage with people who are using steroids? How can we increase the delivery of interventions? How can we, if we find an appropriate intervention to support harm reduction or cessation, what's the best way of reaching people to do that? And we know that for a variety of reasons, therefore, this engagement between people who use steroids and health professionals is rare, certainly in the UK and as far as I'm aware internationally as well. And there's lots of reasons for that that are sort of beyond the scope of this presentation to go into. And I'll give some examples here of some opportunities to provide interventions as part of these sort of treating harms associated with steroid use. And I recognise that this will vary a lot. And there'll be times when this is appropriate to do and not, depending on the sort of the severity of the condition, the setting, the sort of the detail of the person who's engaging with that steroid user. But there's some examples of the types of interventions that we might have hoped to see delivered alongside sort of the treatment of specific harms. But what we found then is that there was very little evidence along studies of engagement with users about their steroid use alongside any treatment they received. So we found a couple of studies that mentioned that they gave some brief advice to stop using steroids as part alongside with that, along with the specific treatment given. No understanding of whether that's going to be effective or not. And from what we know about just telling people to stop doing something, it probably is unlikely to be that effective. But no evidence of any sort of specific harm reduction interventions, no evidence of any additional investigations into the possible health harms that that person might be experiencing, apart from the one they've received that specific treatment for. The big caveat, I suppose, it's just worth flagging is that just because they didn't report this engagement, it doesn't mean it didn't actually happen. It wasn't, the focus often wasn't that person's steroid use within these studies, but it probably is correct to say that in generally this didn't happen, and if it did, then well, nothing's been written down about it. We've got no evidence to go on, so it doesn't help us at all. Just to finish off with a couple of examples of how this engagement might be missed. For example, then we had 25 cases within this review of patients given treatment for some hepatic disorders. In 12 cases, they had recently started using steroids themselves. We know this is a key time to engage with people and when they might be more susceptible to behaviour change messages or harm reduction messages. So this would have been a good time to try and initiate some engagement about that sort of about their behaviour and their choices. At the other end of this, 5 of these 25 patients are reported over 5 years of steroid use, so quite long-term users. And at that point, we might expect to see some other harms coming through. There's an opportunity to test for other disorders, as well as promoting behaviour change, promoting harm reduction. But again, no evidence of this. In cases of treatments given for harm associated with injecting complications, so people who had infections or abscesses that required treatment, you'd think this would be a good opportunity to provide interventions on injecting practices, some sort of delivering some kind of harm reduction information. But again, no evidence that this took. Just to finish off then, some what I think really are the key points of interest coming from this, which is that overall there remains little evidence to support the development of evidence-informed interventions really relating to any types of interventions, but specifically around motivating and supporting cessation or management of symptoms following cessation. So what we might think of therefore as treatment interventions. I think it's clear that alongside medical treatments for the many harms associated with steroid use, there is clear opportunity to engage with users, so leading to further interventions. As far as we know, that isn't likely to be happening at the moment, and if it is happening, we really need evidence on this, and we need studies therefore of all types to examine all types of anabolic steroid interventions that are currently being delivered, and that's thinking about whether they work or not and these issues around implementation. And if we can do that, then we'll start to build a much more meaningful evidence base that will be useful for anyone working in this area. So thanks very much to Jim and colleagues for inviting me to give this talk. Thanks to everyone for listening, and look forward to the Q&A. Thank you.
Hello everyone. I would like to thank Professor Jim McQuay and the Manchester Metropolitan University for arranging this really interesting conference and for the invitation to present our work. I would like to describe the Norwegian law and the treatment system, and why so many steroid users are skeptical to seek the treatment they have rights to. I will try to show that steroid users exist within the treatment system and other systems. That's why we use the title Mind the Gap. I work at Oslo University Hospital, Division of Mental Health and Addiction, at the National Advisory Unit on Substance Use Disorder Treatment in the eldest psychiatric hospital in Norway. This is our building. It was opened in 1855. So in the advisory unit, I work in the Norwegian Steroid Project that is funded by Ministry of Health and Care Services. And our goal is to ensure equal health service for anabolic steroid users with health problems nationwide. And to do so, we have many things that has to be done. We are working to increase the knowledge among treatment providers about steroid use, health and treatment. We are trying to reach the general public through a social media campaign. We have clinician network and supervised clinicians, and we also provide an information service for users and the next of kin. Finally, we are doing treatment-related research in the anabolic androgenic steroid research group that is led by Astrid Bjørnebekk that presented earlier today. So what is known about treatment of anabolic steroid dependence? A recent scoping review described limited evidence and mostly case reports reporting on physical health and treatment of that. It is suggested that social support and to manage symptoms during cessation is central. When you look at the literature, steroid use is registered in many studies, but research document missed opportunities for engagement and interventions. Also, this leads us to Norway, where use of anabolic steroids and other enhancement drugs have been implemented in the politics of substance use and treatment. The Norwegian Drug Act was amended in 2013, where use and possession of anabolic steroids and other enhancement drugs was criminalized. At the same time, the patient group was given rights to substance use disorder treatment services. And it was the national guidelines actually stated that the patient group was supposed to have psychosocial support during cessation and other psychosocial interventions during treatment without describing it further, and also to address mental and physical health during treatment. But few seek such treatment. Our qualitative study exploring barriers to seeking substance use disorder treatment among steroid-using men who struggle to cease their use found that organization within addiction treatment was experienced as alienating. They saw their struggle to cease steroid use to be different from being dependent on psychoactive substances. They questioned knowledge among staff and questioned also whether the treatment of psychoactive substance dependence could be transferred to treatment of steroid-related health problems. I will give you an example of experienced alienation, and you can read the quotes, and I'll give you a few seconds for that. The quotes show that a barrier was alienation due to having a healthy identity as opposed to how they viewed patients with severe substance use disorders. And that in itself was a good reason for not seeking treatment. Another barrier was that the system did not have the means to treat hypogonadism that was seen as the main challenge during cessation. You can read the quote. This quote also shows that several participants had used really high doses, and when they entered treatment, they were not ready to quit abruptly and tapered down by buying it illegally on the street, risking being caught by the police while they were trying to do something about their steroid dependence. Still, more than half of the 17 men had experience from being in outpatient treatment. There were examples of tapering by use of illicit substances, as we saw on the previous quote. Some found it really frustrating that they received antidepressants to treat their symptoms of hypogonadism after cessation. But during the course of treatment, they described supportive high-frequent sessions as essential to not restart use. That addiction treatment was useful to work on not relapsing, and that treatment of pre- and comorbid mental health problems was important, in particular in addressing motivation for use. Motivation for use is also linked to steroid dependence. It could also be seen as getting desired personality, a need for that. And this quote I would like to read. For my part, I think it had to do with me becoming myself. I felt I became myself. I felt I became how I wanted to be in a way. I was simply extrovert and much happier. So I think that was the reason to continue using it. And this participant was a victim of violence. To him, being big and strong had another meaning than having a nice appearance. By having a muscular body, he could protect himself. And this was his main motivation and also a central part of being dependent on anabolic steroids. We will now move on to a national study where 563 mainly inpatients in Norwegian substance use disorder treatment participated. We found that 36% of men and 8% of the female inpatients or patients reported lifetime use of anabolic steroids. When looking at steroid use and preferred substance, we found that more than half of the patients who had stimulants as their preferred substance had experience with steroid use, followed by opioids and cannabis. Even alcohol, that was the lowest. We found that 14% of those who preferred alcohol had used anabolic steroids in their lifetime, meaning that it's important to ask all patients, no matter what kind of substance they prefer, about current or previous anabolic steroid use. When comparing patients with and without steroid use, we found that the steroid group were younger, they had less education, more mental health problems. They initiated illicit substances earlier and got the substance use disorder diagnosis earlier. They also used more substances weekly and exercised more. As a summary, it seems like steroid use in a lifetime perspective in this sample could be a kind of marker of more serious substance use. We have shown that patients with lifetime steroid use exist in the substance use disorder treatment as it is. 2/3 had substance use problems prior to starting using steroids. And nearly half had used steroids to counteract a thin body after substance use. And 1/3 of all patients were asked about steroid use during the treatment. They also found that very few of the treatment providers had knowledge about the subject. This study shows that all patients in addiction treatment should be asked about previous and present steroid use and plans for using steroids in the future, as this is an opportunity for engagement and interventions. 8% of female substance use disorder patients had used steroids, and most had also used weight loss drugs in addition. This number is much higher than the general population, and I will give you an example on how being in substance use disorder treatment may be a risk factor in itself for starting to use steroids. This participant in a mixed method study about steroid use among 16 women described a motivation to use steroids while in treatment. I'll give you some seconds to read the quotes first. So, being underweight and gaining weight as fat was a motivation to initiate steroids. It was also a way to handle withdrawal symptoms of psychoactive substances and to get more energy and initiative. Through experiencing the bodily change by using steroids, the participant regained her confidence and self-esteem and also got irreversible side effects that she is still struggling with. Now I will briefly describe findings from a national prison study, the Norwegian Offender Mental Health and Addiction Study that is led by Anne Bukten at the University of Oslo. It is also part of a larger prison study called the PRESTUD. Check it out on prestud.no. 1,499 inmates were included, and this is 40% of the national prison population totally. We found that 30% of male and 6% of female inmates reported lifetime steroid use. And in this study, we found a similar pattern as the study in substance use disorder treatment. The steroid group was compared with inmates who had used substances but not steroids. And the steroid group had younger WHs on almost all substances. They had used more psychoactive substances in lifetime. And importantly, 6 months prior to and also during treatment. I think it's important to note that 8% of the participants, meaning all the participants, had used steroids during the 6 months prior to imprisonment, and almost all of them had ceased use. This means that they may experience withdrawal symptoms shortly after imprisonment. That is a high-risk period for mental health problems and may be in need of tailored treatment. Imprisonment should be viewed as an opportunity for engagement and interventions, particularly at imprisonment. So, what have been done to facilitate treatment seeking? And a free and an anonymous information service to steroid users was initiated 5 years ago. And it's led by the leader of the steroid project, Kristine Wisløff, who's a clinician, and she informs steroid users that contact us about possible health problems, including treatment options and what will actually happen in substance use disorder treatment. It is interesting to know that 3 out of 4 desired treatment after these sessions. And the main reason to seek treatment was mental health problems. They had both physical and mental health problems, but the reason why they wanted to quit was mainly, or most commonly, mental health problems. Still, the information service was not used as much as we hoped for, and the steroid project therefore initiated a social media public health campaign using this ad as clickbait. This and other ads as well. And when clicking on it, they entered an informational web page called the Steroid Lab, or Steroid Lab. See what happens when they get anabolic steroids. Of course, the kittens were not given anabolic steroids, but Steroid Lab in the social media campaign tries to show what may happen when humans experiment with use of anabolic steroids. And the user stories describe both the desired and undesired effects. And the viewers have used much time watching these user stories. And they have been developed in close collaboration with the users themselves. Another popular part of the campaign has been researcher facts. These clips or actually ads with the following text. Did you know that anabolic steroids can affect memory? Did you know that one can get addicted to anabolic steroids? Did you know that women can develop masculinizing effects of anabolic steroids? And the viewer clicked on the picture and got a minute-long research fact video clip. It has been viewed 400,000 times on YouTube, these clips. The Steroid Project has also produced short animation movies that are informative and scientifically based, aiming at the target groups such as the general public, steroid users, and health professionals. And they are also translated into English with English subtitles. So the thematics of the films are: what are anabolic steroids and how does it affect the body? We also describe what possible physical health problems could be, as well as mental health problems during and after use. We also have produced a film about gender-specific side effects, and finally also other performance-enhancing substances, including psychoactive substances and weight loss drugs. So, did the social media campaign change anything? The ads was viewed more than 20 million times, and the films have been viewed about 1 million times. And those seeking information and treatment also increased. Prior to the campaign started in 2018, 3 to 4 every month contacted us. And after 2018, when the campaign started, up to 20 persons per month contacted us. And it seems like after the campaign, the users are younger, have used shorter, and have less health problems as well. So this is a way to engage earlier. To sum up, it is clear that when planning and implementing new health services, the user needs and barriers should be taken into account. Steroid users may be seen as a new patient group, but I've shown that they already exist within the system, and that treatment providers therefore should take the opportunity for engagement and interventions. I've used pictures of birds to show that steroid users exist in substance use disorder treatment and in prison. We already know that they exist in somatic health services, often without telling that they use steroids. I've also added a picture of street art, a single bird from Manchester, to symbolize that I'm looking so much forward to the next opportunity to meet as many as possible researchers, practitioners, and persons with user experiences in person in Manchester one day, hopefully at a new conference. And finally, a few words about the near future. The Steroid Project and the research group are planning to test whether endocrine therapy reduces withdrawal symptoms. And we will also explore what steroid users and the treatment providers experience as helpful psychosocial interventions to cease steroid use and to treat steroid dependence. And this research will be conducted in close collaboration with Professor Jim McQuay at the Manchester Metropolitan University. And this is a picture of the research group leader, Astrid Bjørnebekk, and me last Christmas when we got funding. So it is yet to see whether we can publish a similar picture this year. Please contact me on email if you have any questions or comments, and then I would like to thank you all for your attention. Thank you.
First of all, I would like to thank Jim for giving me the opportunity to present my experiences at this exciting meeting. In the next 20 minutes, I would like to discuss shortly our patient clinic for steroid users and the results of our prospective observational cohort study, the Haarlem study. I am an endocrinologist with a particular interest in male hypergonadism. In the beginning of my career, I saw some former steroid users with symptoms of hypergonadism. I realized that I knew very little about this particular subject, and I found it hard to find advice from colleagues both nationally and internationally. Also, solid scientific evidence to base management is scarce. For me, that was the reason to start the first Dutch outpatient clinic for steroid users. The aims of the clinic are to offer care for users or past users of anabolic steroids with health problems associated with the use of steroids, to do research and, based on our experiences, to educate the public and healthcare professionals. We are very clear about what we do not do. We do not prescribe androgens for cosmetic and performance enhancement, and we do not perform routine health checks in current users. Over the past 10 years, we've seen almost 400 patients from all over the country, mostly because of symptoms such as decreased libido, erectile dysfunction, fatigue, depressed mood, gynecomastia, and fertility issues. From these patients, we obtained a pretty accurate picture of who they are, what they are using, how they are using, and what problems they may have. We summarized these findings in a recent paper, and although the Dutch user is probably very similar to the one in your country, I will give you some highlights.
Visitors of our clinic are male, mostly aged between 20 and 40, and engaged in weightlifting, bodybuilding, strongman competitions, or martial arts. A minority participates in competitions. In our clinic, only 1% of androgen abusers was female. More than 50% of users reported recent recreational drug use, such as ecstasy, amphetamines, cocaine, and cannabis. 1/3 of users have friends or relatives who are also using steroids. Almost half of steroid users consider themselves to be addicted to steroids, mainly due to the perceived positive effects on mind and body. The population seen in our outpatient clinic is selected on the basis of health problems and may not be representative for all steroid users in the Netherlands. Therefore, we started a 1-year observational cohort study in 100 androgen abusers without health problems, the Haarlem study. Men eligible for participation in the Haarlem study were at least 18 years old and intending to start a self-initiated cycle of anabolic steroids on short notice, that is, within 2 weeks after signing informed consent. The anabolic steroids had to be acquired through their usual channels. The scheduled cycle had to be at least 6 weeks long, comprised at least 2 different types of androgens, and average a weekly dose of 200 milligrams or more. An exclusion criterion was anabolic steroid use 3 months prior to informed consent. Men were also refused to participate in the study if, within 6 months prior to inclusion, a new chronic or psychiatric illness had been diagnosed, treatment for chronic illness had been started or altered significantly. Subjects visited the clinic 4 times in 1 year, and a medical investigation was performed at baseline, that is, within 2 weeks before the start of anabolic steroids, in the last week of the steroid cycle, 3 months after ending the cycle, and 12 months after inclusion. When comparing the baseline characteristics of the Haarlem study cohort with our outpatient clinic patients, we found that both populations are very similar with respect to age at first use, type of exercise, recreational drug use, type of steroid use, and the way of use. This slide summarizes the type of anabolic steroids used in both cohorts. Note that most users used more than one type of steroid simultaneously. For the Haarlem study, we made a qualitative inventory of the products obtained by our 100 study participants. Only about 1/2 of analyzed samples contained the anabolic steroid as indicated on the label, and more often than not, the samples contained steroid types not indicated on the label. In 5% of products, no active ingredient was found whatsoever. We suspected that roughly 40% originated from Eastern Europe and Asia, whereas 60% appeared to be produced locally in illegal so-called underground laboratories. Anabolic steroids are mostly used in cycles with a duration between 6 and 18 weeks. The unproven rationale behind this strategy is to gain muscle mass and strength during a cycle, allowing the body to recover between cycles. In our cohort study, the mean weekly estimated androgen dose was almost 1,000 milligrams, ranging between 250 and 3,300 milligrams. The estimate does not accurately reflect the actual androgen exposure due to the fact that it is based on the declared and not the actual concentration of the abused products. Moreover, it combines oral and injectable products and different types of androgens. However, it gives an indication that the weekly dose varies enormously between users and that the mean dose is highly supraphysiologic. For comparison, a normal substitution dose of an injectable testosterone ester to treat male hypogonadism should not exceed 100 milligrams per week. A cycle of anabolic steroids is not expensive. In our Haarlem cohort, the mean cost per week was 30 euros, adding up to 400 euros per cycle. This means that cost is rarely a barrier to start using anabolic steroids. Although anabolic steroids are by far the most abused drugs, a variety of other performance and image-enhancing drugs are commonly used. These can be categorized as muscle builders, fat burners, pre-workout agents, and agents to prevent or treat side effects. Depending on the nature and dose of these agents, additional adverse health effects can be expected. Similar to androgens, most of these products are illegally obtained and their quality should be questioned. Moreover, scientific evidence supporting the claimed effects is mostly absent. All users of anabolic steroids, assuming a significant exposure, have side effects, although the majority of these side effects is mild and transient, and some go unnoticed by the user. During androgen exposure, a large proportion of subjects reported positive effects: increased muscle mass and strength, decreased fat mass, increased libido, improved energy, and concentration. As expected, all users experienced at least one negative effect during androgen exposure, such as testicular atrophy, fluid retention, acne, agitation, snoring, palpitation, and gynecomastia. However, these were mostly considered mild, anticipated, and transient. As a result, only 13% of the subjects stopped or altered the intended anabolic steroid cycle due to side effects. 53% of subjects reported loss of libido in the 3 months after the end of the cycle, which is not unexpected, knowing that androgen abuse results in suppression of endogenous testosterone production. Surprisingly, other symptoms that are frequently associated with this steroid dip, such as erectile dysfunction, mood swings, or depressed mood, were not reported more frequently compared to baseline. The type and frequency of desired effects and side effects during and after androgen exposure were similar to those recollected by experienced users from previous cycles. The fact that 80% of our cohort had past experience with anabolic steroids suggests that for most users, the benefits of androgen abuse clearly outweigh the side effects. It also indicates that users of anabolic steroids are well aware of the possible side effects of androgen abuse. Besides moderate weight gain, a small increase in blood pressure, acne, and gynecomastia, physical examination during or after androgen exposure was mostly unremarkable. Gynecomastia is a well-known side effect of androgen abuse and was frequently self-medicated with tamoxifen to prevent or treat it. Acne and gynecomastia were mild and reversible in most cases, although 7% of participants already had grade 1 or 2 gynecomastia at baseline. And previous anabolic steroid use was strongly associated with gynecomastia at baseline and the development of gynecomastia during androgen exposure. Only one subject developed severe gynecomastia, which did not recover during follow-up. 4 subjects experienced a serious adverse event during the study period: heart failure, acute pancreatitis, exacerbation of ulcerative colitis, and suicidal ideation. Of these, only the association between androgens and congestive heart failure and suicide have been reported previously. However, our study does not allow us to draw conclusions regarding causality between these events and androgen abuse. In our study, the use of androgens had several adverse cardiovascular effects: a relatively small but significant increase in systolic and diastolic blood pressure, a 20% increase in LDL cholesterol, and a 30% decrease in HDL cholesterol. Also, a rise in hematocrit and platelet count. All effects were reversible within 3 months after stopping anabolic steroids. Longer cycles were associated with a higher hematocrit. The use of oral androgens was associated with higher platelet counts and a more adverse lipid profile. Weekly dose of androgens, although highly variable between study subjects, was not associated with any of the variables. Androgens induced an increase in cardiac left ventricular mass, a reduction of left ventricular ejection fraction by 5%, and a higher left ventricular stiffness. When androgens were discontinued, after a median recovery time of 8 months, all cardiac parameters returned to their baseline values. Irrespective of androgen dose and duration of use, anabolic steroid exposure resulted in complete suppression of the hypothalamic pituitary gonadal axis, as demonstrated by undetectable LH and FSH concentrations in nearly all subjects. Furthermore, testicular volume declined during anabolic steroid use as spermatogenesis decreased, with 2/3 of subjects having oligo or azoospermia by the end of the cycle. Androgen cycle dose and duration did not have a significant impact on the degree of suppression of spermatogenesis. After 3 months of recovery, mean testosterone concentration had returned to baseline levels for the entire cohort. When the pre-exposure gonadal function was normal, there was an 89% chance of having a normal testosterone concentration after 3 months of recovery and a 100% chance at the end of follow-up. These data suggest that full recovery of endogenous testosterone production takes place for the vast majority of androgen abusers after 1 cycle of anabolic steroids, independent of cycle cumulative dose or duration, provided pre-exposure gonadal function is normal. However, 31 individuals had signs of a normal gonadal function at baseline. To be included in the study, subjects were not allowed to use androgens up to 3 months prior to inclusion, and based on the evidence presented above, such a high rate of gonadal dysfunction was not expected. Of this group, of the gonadal dysfunction group, 94% had used androgens in the past, indicating past abuse as a determinant of gonadal insufficiency. These subjects had a significantly higher cumulative past androgen exposure, having abused androgens twice as long in their lifetime compared to the group with normal baseline gonadal function. 9 subjects still had a low total testosterone at the end of follow-up, and it is uncertain whether endogenous testosterone production will eventually normalize in these men. We were unable to determine other risk factors to predict slow recovery of gonadal dysfunction compared to other subjects that had a similar history of androgen abuse but did recover during follow-up. The recovery of spermatogenesis took longer than the recovery of testosterone production. Mean sperm count was still significantly lower compared to baseline 3 months after the end of the cycle. In our study, the mean time to recovery of spermatogenesis to baseline values was 53 weeks, or slightly more than a year. Recovery was faster in a subgroup of subjects with normal gonadal function at baseline, with a calculated recovery time of 30 weeks. In our study, PCT, or post-cycle therapy, did not show any beneficial effects on the recovery of parameters 3 months after the cycle. Although the use of PCT is widely advocated among users of anabolic steroids, there is hardly any evidence to support its use. Furthermore, the use of HCG or Pragnil had no detectable effect on testicular size or spermatogenesis, whereas this would be expected based on clinical experience in the medical literature. Liver toxicity has been described mainly in association with the use of 17-alkylated oral androgens. Of our cohort, 67% reported the use of oral steroids. However, mean levels of bilirubin, alkaline phosphatase, and gamma-glutamyl transferase decreased instead of increased, slightly but significantly during androgen exposure, returning to baseline within 3 months. In most subjects, a rise in the concentration of ALT, AST, and LDH occurred. Although this may suggest liver damage, we assume this to be the result of frequent heavy workouts, underlined by the steep rise in creatine kinase concentrations during androgen exposure in almost all subjects. Steroid abuse has been associated with manic or hypomanic behavior, irritability, aggression, and even psychosis, whereas androgen abstinence has been associated with depression and lack of energy. In our cohort, 1 subject stopped using androgens due to suicidal thoughts. In the other subjects, androgens did not induce relevant psychological disturbances based on the results of psychological questionnaires. Although a significant proportion of our subjects self-reported increased aggression and agitation during androgen exposure, the aggression questionnaire did not reveal an elevated physical aggression index. Mean scores on well-being and quality of life questionnaires did not change during androgen exposure, although a significant proportion of the participants self-reported improved concentration and energy during the androgen cycle. Most importantly, the recovery period after abuse was not associated with an increased prevalence of depressive symptoms. Moderate to severe body dysmorphic disorder, according to the BDDY box questionnaire, was present in 32% of subjects at baseline. Scores remained unchanged during androgen abuse despite the increase in muscle size and strength. Remarkably, the scores improved towards the end of follow-up, even though muscle strength and muscle mass are rapidly lost after androgen exposure. Our data show that all users experience both positive and negative effects of steroid abuse. For most users, side effects are mild and transient and may even go unnoticed. The reported weekly or cumulative dose cannot be reliably used to predict the chance, the type, or the severity of side effects. Higher androgen exposure was not necessarily associated with a higher risk of self-reported side effects or side effects such as elevated blood pressure, disruption of lipid profiles, disruption of gonadal function, or the degree of aggression or depression. On the other hand, there does not appear to be a safe dose of androgens or a safe type of androgen that is associated with a lower risk of side effects. Serious side effects do occur, but are highly unpredictable. Long-term side effects are still largely unknown, but may include cardiovascular morbidity and permanent gonadal dysfunction. We are awaiting the results of the effects of androgens on blood coagulation parameters and the results of the 2-year follow-up of our cohort. We would like to stress that using anabolic steroids is impossible without side effects. We were unable to identify a safe or a safer type, dose, or way of use. Longer exposure to lower doses of androgens is potentially more detrimental than short exposure to higher doses, since the former is associated with a prolonged adverse cardiovascular risk profile. Also, we found additional evidence that a prolonged exposure to high-dose androgens may result in prolonged and perhaps permanent gonadal dysfunction. Thank you for your attention.
Hi, I'd like to thank you for asking me to deliver this presentation at today's conference in the most unusual of circumstances. Of course, the whole point in a national conference is you get to be away for work for a few days and get drunk with colleagues you only see a couple of times a year, so that's very much missed. My name's John Campbell, and I guess I have 2 roles that's relevant. And one, I manage Glasgow's injecting equipment provision programme across 72 different outlets, and slightly more relevant, I manage and work in Glasgow's Image and Performance Enhancing Drugs Clinic, which I have done since its inception back in 2010. Although this is a relatively short presentation today, I would like to look at the current prevalence of iPad use in Glasgow. I would also like to look at the iPad prevalence before the clinic was introduced. I'll take you through an iPad clinic timeline, if you like, looking at key developments throughout the year. And I'll talk a bit about what the clinic offers each evening it's opened. And I want to introduce you to quite an exciting new development, I think, that we have going on just now. As you can see, Glasgow's largest injecting population are those people who are injecting heroin. Last recorded year, we had around 7,500 unique individuals present at one or more of our needle and syringe outlets and say that heroin was a primary drug of injection. And when I take you over and look at the column that starts with steroids, so when we look at steroids, growth hormone, tannin agents, and other IPEDs such as peptides, we can see that population equates to around 3,500. However, that population are far less likely to present at our injecting equipment providers for needles and syringes. You access them through a number of ways. You access them through people who are supplying their steroids, you access them online, or they access them through secondary distribution. So I'm fairly confident to suggest that when that's taken into consideration, the likelihood is our iPad injecting population will be significantly larger than our heroin injecting population. Back in 2006 to 2008, we've seen a significant increase in people who were using our services, that were injecting. I guess at that time it was mainly steroids, and that was being replicated across the UK. You can see Jim McVeigh, this is back in 2006, suggesting this was a growing population. We should sit up and take note. So we responded to that by, well, initially providing training sessions and briefing sessions for staff who were working in Glasgow's Drug Crisis Centre. That's a needle exchange outlet that's open 24 hours a day, every day throughout the year. And they've seen the largest increase in visits from people who were injecting steroids. This was a group of staff that were very skilled and very experienced in working with some really chaotic heroin injectors. But almost overnight they had seen a whole group of new injectors that were coming in that weren't injecting heroin. They were injecting steroids, they were injecting other iPads that they just weren't familiar with. They weren't familiar with the drugs, they weren't familiar with the terminology. In fact, they weren't really familiar with the injecting process and how those drugs were used. So we decided to form a working group that look at the best way to address this. And we all came to the conclusion that the best way to address this was to form a specialist clinic. So as you can see, we had this increase in people injecting steroids and other iPads, 2007, 2008. We formed a working group to look at the best way to address that. We had our training sessions, awareness raisings amongst our key staff groups. But I guess the main initiative we had to address this rise in this population was to introduce a specialist iPad clinic, which we did in the early part of 2010. I think it's fair to say that when the clinic opened in 2010, it was really just an enhanced needle exchange. We provided equipment in unlimited amounts and the right equipment that people would need. We had a lot of safer injecting demonstrations. At that time, we started to work with those people who were supplying steroids in the area and give them access to enough equipment to enable good secondary distribution. But I think, it became apparent to us relatively quickly that this wasn't enough. We were sitting down with clients, we were talking about the potential risks and dangers of their type of use or the particular steroids and iPads they were using. And we felt as if that wasn't really getting taken seriously. And we actually had no way of identifying harms or potential harms that were occurring. So in 2010, we put a case forward to start analysing blood, which we have done since 2012, and that is probably the most significant development in our iPad clinic over the past decade. I would now say I've no idea how we would run a specialist clinic without blood tests. To sit down with somebody and say, those oral steroids that you've been taking that we had concerns about are actually shown now to be causing pretty severe liver abnormalities. And as you can imagine, people will stop using at that point. They'll certainly take what you're saying far more seriously with blood tests. In 2010, we started to link with Wedinos. We had a very, very good relationship with Wedinos. Never abused it. Only ever if we had particular substances of concern, we would send them down. Wedinos would get them rapidly analysed for us, and we would feed the results back to clients. Some really, really powerful analysis there as well. 2015, we were very concerned about the circulation of human growth hormone and the likelihood that most human growth hormone that was circulating was fake. So we started testing for IGF-1. IGF-1 is stimulated by the liver after administration of human growth hormone. So testing IGF-1 levels are a really good indication if the person's taking human growth hormone or not. Probably no surprise to anybody working in the field. The vast majority of IGF-1 samples we had returned were within normal range. And you can see quite clearly for those people that were, for example, taking pharmaceutical human growth hormone, they would be significantly elevated. And when you're sitting down with somebody and saying, look, you've been using that for 3 months and your IGF levels are exactly where we would expect for someone your age, they stop using. But this did cause us some problems with the people who were supplying. I can imagine they've turned up at the clinic and said, you telling the guys that the stuff we are selling is fake. And of course, no, we're not. We're telling the guys that there is no increase at all in their IGF-1 levels, and they're able to make their own decision at that. We've taken part in 2 rounds of the national iPad study. It's a fascinating piece of work to be involved in. And the most recent development, which I'm going to talk to you a bit about towards the end of this presentation, is the development of... Okay, so what do we offer at the clinic? Well, we offer a basic assessment. It's the first thing we do when people come in for the first time. So there we want to identify which iPads they are using or which iPads they are planning to use. Their method of use, whether that's cycles, whether it's continued use, whether it's some form of testosterone replacement therapy. A lot of our presentations are to do with side effects or unwanted effects, and that is either on cycle, immediately after the cycle finishes, or is becoming more common now, a real period of months after the cycle finishes and the side effects are still there. I spoke a little bit about blood testing and how that has become central to how our clinic operates. We provide injecting equipment, and we provide it in amounts that clients need, so it's not uncommon for people to take away 500, 600, 700 needles, more than that if they're providing other people as well. We are very comfortable in doing that. We provide real-time injecting demonstrations. So not just how to inject, we talk about how to store the iPads properly. If the iPads for growth hormone, for example, has to be mixed with water, we talk about how to do that, and we talk about how to inject into different suitable muscle groups or subcutaneous. We have frequent discussions about dose and the dose risk, if you like, as well as discussions on individual iPads and the risks associated with them. We're relatively successful in having discussions on alternatives to iPad use for those people who haven't yet started their cycle, or they have finished their cycle, they're experiencing side effects, and they're really keen to jump back on to alleviate those side effects. So the clinic's only open one evening a week. It's a Tuesday evening between 6 o'clock and 10 o'clock. Staffed by myself as a specialist worker. I have a nurse. We have someone who provides clinic support. That's essentially doing the running, organising the waiting room for us. And the clinic's supported with the lead pharmacist and the lead clinician in addictions. So when the blood results are taken, they're sent away, the blood results will go back to the lead clinician. The lead clinician and myself will sit down, between us will analyse what those results mean, and I would feed the results back to the clients at the next clinic. So when we look at who's actually using the clinic, I think here we can actually put them into certain groups. So starting with the smallest group, I would say, are those that are suffering from some sort of body dysmorphia. I'd love to see this being researched a wee bit more. And when we talk about body dysmorphia, I know most people would think body dysmorphia is, people that look at themselves in the mirror, they have an unhealthy image of themselves, and they use steroids to change that. In my experience, that's not the majority of body dysmorphia cases we are seeing, this is something that develops. This is for people who've been training for years, sometimes decades. Huge, big guys, 17, 18, 19 stone, that are terrified at stopping because they're going to lose a couple of pounds. It's very real for them. So this is a dysmorphia that's developed through time. We see some people that are using for occupational reasons. The most obvious there is people that are involved in some form of security, possibly people working in nightclubs. But you can look at any occupation that's male orientated and centres around fitness or around a gym, and you'll find iPad use. And I feel really sorry just now for personal trainers who have some fantastic qualifications, but their ability, their success is judged on their own physique, their own muscle mass. So that's essentially what they're competing against. They're trying to be bigger than the next personal trainer. So we have a lot come into the clinic like that, and I've no doubt if that wasn't the case, then they wouldn't come to the clinic, because they would have no need to use iPads. We have people that are competing, athletic sports, and by there I mean they're members of some form of governing body. Of course, bodybuilders, powerlifters, people involved in other strength sports such as the Highland Games, semi-professional rugby players. But we have a larger group than that are just as committed. They're just as dedicated. It's athletic training, but they're not members of any governing body, and their motivations are often personal, are often to be, the strongest amongst their peer group, or the biggest in the gym, or the workplace, and of course the largest group we have is people that are using for image enhancing purposes. And when you look at those that's using for image enhancing purposes, this is often a group of people that don't have any really training experience. They certainly don't have the diet and nutrition experience or knowledge they need to make their aims successful. Often looking for a relatively quick fix. And this is the majority of this group are people that are relatively young, so under 30. A lot of the main motivations for using is to become more appealing, to attract a partner. So many of them, and we're going out and clubbing, and of course, that brings a whole other series of risks with things like unprotected sex and the potential to be using recreational drugs. And so I don't think it's a good idea in general, to kind of pigeonhole groups of drug users, but I think when you're looking at people that can come through the door to your clinic, it is useful to at least think about the motivations for use, because it's going to dictate essentially what advice you're going to give them. So some people present with harms, and I've taken this from our experience at the clinic, and it differs a wee bit from what you would see in a lot of the textbooks for the past few decades. So frequently we'll see people with a hormone imbalance. Of course, on cycle, that's where hormone, their testosterone particularly is through the roof. But more often than that, it's once the cycle finishes. So the testosterone is very low, the estrogen starts to increase, the real problems with emotions. There's no sex drive, you're suffering from erectile dysfunction, the mood is very, very low. We know things like shrunken testicles are given, but real concern as well are things like people's sleeping pattern and how that's affecting their daily life. So we'll see one or more of those side effects every single clinic we run. What's also common is injection-related complications. Now, sometimes that's down to poor injecting process. Other times that's down to the substance that they're actually injecting. We do see abscesses. We see other infections. We see granulomas. Steroid acne is very, very common, not just on cycle, but also after the cycle finishes again and their hormones are all over the place. Related to some particular steroids, we see quite severe water retention and bloating. For those people that are using high-dose testosterone, we see development of gynecomastia. Occasionally, what we see is, potential damage to the liver, potential damage to the kidneys, or high blood pressure. What we don't really see is any cardiovascular disease. Now, that's not to say that's not happening, but how could we possibly pick that up in a clinic? We would be able to pick up blood-borne viruses, particularly as we've done about 2,000 blood tests now, and we've only ever had one BBV positive back, and the chap knew exactly where he contracted. It was hepatitis C. We don't tend to see prostate issues, and in very, very few people will see the triggering of male pattern baldness. Yeah, you take things like blood-borne viruses and the triggering of male pattern baldness, that's two of the key things that you'll read in a lot of literature. Now, I can't say that's not happening in other places in the world. I can only give you the Glasgow experience and to tell you that here that's not particularly common. So the whole list here are common presentations, right from the loss of libido, erectile dysfunction, all the things I spoke about there. And you can see that people are now self-managing that, whether it's through taking Viagra or seeking out, medication for acne, or if they're engaging with a GP and only present with symptoms, and sometimes they're starting things like antidepressants. People do go to the GP for help, and it's in a number of ways. They'll present on cycle and admit to using steroids, and I think when they do that, it's really difficult for them to get any proper treatment or understanding of why the particular problem may be happening. For some, will present on cycle and they'll just deny using steroids, and again the outcome is unlikely to be successful. But the most common is for people many months after stopping use, 6 months, a year after use, they go to the GP. I'm feeling really low, I'm feeling down, I'm falling out with my partner, I used to go to the gym, I don't train anymore, I've no interest in sex at all. And of course, they'll leave with a prescription if they hadn't mentioned that they use steroids. They'll be prescribed antidepressants, or they'll be prescribed Viagra, or be prescribed both, I guess, as well. So I think it's fair to say that GP responses really vary. But how can we support people that are using iPads? Well, I think we need to adopt an approach that our clients are going to be comfortable with. Something I used to hear from staff at needle exchanges is, we treat everyone the same. Here we can't treat everyone the same. If I'm working with someone who's an 18-year-old girl injecting melanotan, then she's going to get very different advice for the competing bodybuilder that's in next, who in turn is going to get very different advice from the 25-year-old guy that's just considering using steroids for the first time. But in order for us to do that, we need to have a degree of knowledge about iPads, and that needs to be factual and real life knowledge as well. When we're developing services, then we need those services to be opened when the clients are most likely to use them. That can be an existing needle exchange, but maybe training up a worker. But I think it's really hard to see how we can do any of these things without having blood tests central to the way we operate. That's just a poster that we put around all our gyms, and our council gyms. We put it around our hardcore gyms and our private gyms, and they all said they'd put it up and advertise a clinic. This is way back in 2010. Of course, they didn't. When we introduced blood testing and things, and we put it around again and done it and put them up, I guess, for pretty obvious reasons. The most significant development we've had in the past few years anyway is the development of our new iPad module. So this is on our Neo 360 platform. It's been developed in partnership with 3 Scottish sites, so Glasgow, Edinburgh and Aberdeen. The project lead for this was a chap called Con Lafferty over in Edinburgh. He was really successful at driving this forward and getting us all together. The main purpose was to actively and accurately record blood test results, but also to double as a basic assessment, and we want that to tie in as well. So it's not a research tool, but we will be able to pull data that shows us how many people that using Trenbolone found it difficult to recover. For example, it feels as if, you know, that really isn't available in the field just now. So you can see it records a lot of demographic information. You know, things like the postcode where the person stayed is, for us, is quite important if we want to direct them to, you know, their nearest needle exchange when the clinic isn't opened. You can see the ethnicity, and we also want to know if they agree to be contacted, and that's important for us for blood results. So I've also left this chap's mobile number off this. And we ask, can we contact for research purposes as well? Interestingly, I've had no one say yes at this. Okay, and you can see this is actually information that's been recorded. So this is a real life client. Started using steroids at 22. You can see part of the list of steroids that he was using. So he was using Trenbolone, testosterone, human growth hormone, and Anavar. Now you can see it's a full year of use yet, but this chap's been accessing the clinic for a number of years now, really without any significant period of time off. At this point, he's going just about to start IVF. Him and his partner want to try for a child. Of course, you know, once he stopped using, then he was no libido at all, and it's causing him real anxiety to this point. And these were the blood results, which were incredibly predictable. And I would say that if for anyone who has any experience, you know, of taking blood, in particular for people that are using steroids, it's incredibly predictable. You know if someone's using big combinations of steroids and big doses for a long period of time, recovery is going to be difficult. We can also see for people that use post-cycle therapy, particularly post-cycle therapy at the correct dose, using the correct drugs, and they're far more likely to have a positive outcome. So you can see his chap's testosterone was barely measurable, and you can see his LH as well. It was absolutely short to pot, and a couple of other markers that are a little bit out there as well. But thankfully, all the bloodborne viruses were negative. So this is a chap we would want to monitor over the next few months. And then ask him to go to his GP to refer into endocrinology, you know, which will be no doubt will be a long drawn out process.
Okay, hello and welcome to the Q&A session for the end of this fourth session. I'd like to thank all the speakers for this session, to Jeff, to Ingrid, to Willem and John for some really interesting presentations. And again, for everybody to kind of who stayed with us today, over 120 active participants at the moment, and that's without the kind of promise of refreshments, alcohol, or the use of imaging performance enhancing drugs to keep us all awake, I'm sure. So we've got a good kind of 15 minutes for the Q&A. So I'm going to go straight into the questions. First question posed by Ask, who says, several speakers have referred to the use of AAS as a kind of growing public health problem. However, it's not clear to me when a health problem amongst a group of people becomes a public health problem. As the answer to this question clearly affects the national healthcare system's approach to this, it would be interesting to hear some reflections on this. So question to all four speakers: why is AAS use a public health problem?
I don't mind give my thoughts first. I'm sure the others have got lots to add as well. I think it's a really complicated question, and I'm not going to try and say too much because I know we don't have much time. But for me, it's a question of sort of the scale in terms of the numbers of people involved. And I'm not sure if it's a growing problem or it's just a sort of staying steady. I don't know. maybe we need better sort of prevalence data to help with that. But it's that sort of the numbers, along with the potential for harm, I suppose, and the potential for sort of how sort of severe that harm can be. And they're kind of the two factors that I suppose how I would have looked at it, along with kind of around the difficulties with reaching some of these people. Some people who use steroids could be quite hard to kind of reach with intervention and public health work. So in terms of a problem, I suppose, I think that's part of it as well.
I would like to add to that, if you look into subpopulations like prisoners and patients in substance use disorder treatment, a high percentage, as I presented earlier, have used anabolic steroids, and some used it to counteract the effects of substance use. So that's one point, and it's also maybe in some populations a marker of more serious substance use. But it should be noted that steroid users, many can use it, as Pim de Ronde showed, without, as we know, have severe health problems, and they can quit as well. But we know that maybe 1 in 3 develop a kind of addiction where they struggle to quit and are at risk at developing mental and physical health problems. And the patients that we see at Oslo University Hospital, they have mainly mental health problems. Some have described aggression and problems in their relations. So it can also affect the third party, that should be taken into account as well.
Any comments from Willem or John?
Well, when I think of a public health problem, I think mainly in numbers, that it should be a big problem or a problem affecting a lot of people. And when I consider the Netherlands, we assume that we have about 20,000 users in the Netherlands. And we're the only dedicated clinic in the Netherlands. And over the past 10 years, we've seen about 500 patients. From a number of them, it wasn't even sure that the problems they had were related to the use of anabolic steroids. So as far as numbers are concerned, I don't consider it a public health problem yet. On the other hand, if Harrison Pope is right, and the problems, most of the problems are still yet to come, then it might become a public health problem perhaps in the future.
Thank you. And John, any comments?
Maybe just say it's a public health concern, but I don't view it as a public health problem. Certainly in our experience, the vast majority of people that use iPads only do so for a short space of time. It's usually 1, 2, 3 cycles, and then they fall back out. Yeah. iPad use, steroid use isn't a quick fix. There's no steroid I've found where you can inject once a week, sit on the couch, eat Doritos, and you end up with a 6-pack and some nice pecs. It requires a lot of work. So steroid use is very much like the thousands of people that join a gym in January, and they're determined they're going to go to the gym 5 days a week, and their diet's going to be great, and they're going to be in a swimming costume by July, and it doesn't quite pan out like that. In a way, that's good, because that lets us focus our attention on the harder core of users that we need to. So public health problem, I'm not so sure.
Okay, thank you for those answers. And I move on to question 2, which was posed by Jim. It's directed at Jeff, so perhaps you go first, Jeff, but open it up to the rest of the panel as well. Where should we be looking for models of intervention? Drugs, eating disorders, or other fields?
I think the key part of that for me is it depends simply on what it is you want to achieve with your interventions. I think if we're talking about sort of primary prevention in a way of sort of the underlying issues that may contribute to some people's sort of decisions later to use steroids, and whether that's sort of body image related, eating disorder related, the sort of school-based educational studies, then I think there probably are lots to learn from other fields. And then I suppose then if you're talking more about kind of harm reduction approaches where there might be crossovers with other disciplines. So I think that's kind of it's about being specific about what it is you actually want to to achieve through an intervention? What is the problem that you're trying to solve and then or respond to? And then, we can borrow from other relevant fields. I'm sure any sort of harm reduction work, such as John was talking about in his presentation, we can learn lots from other drug-related fields in the sort of the literature around that, while always remembering that the context of steroid use or iPad use will mean that there are some differences as well.
And does any of the other speakers want to come in on this one?
I totally agree, actually. Not surprisingly, but I think it's important to explore what kind of problem is it the user want to get help for. What is it that they want to change? Is it the endocrine part of it, or is it the body image part, or is it more a kind of a dependence or a mix of everything? So I think maybe the Dutch and the Norwegian model should be we should actually group together and make sure that we have available more services. The Norwegian model is based on addiction treatment, and we actually miss the internal medical part to cooperate closer, because we have a local-based treatment all over the country. So every place we need to cooperate with a local endocrinologist, and some are not really interested, to be honest. And we don't have guidelines for treatment either. So, but most important is to ask the users, what do they need? What kind of help do they need?
Yeah, I think we're very comfortable working with drugs in this field. We're also very comfortable linking anything with bloodborne viruses as well, and that's something we've done, without a lot of evidence over the past decade or so. What we've not really touched on is almost the whole cosmetic aspect of iPad use just now. I'm pretty sure you could argue it's cosmetic procedures has increased so the amount of people that's actually been involved in this that aren't involved in bodybuilding or powerlifting or any kind of strength, competitions or anything. So we talk about image when we're really talking about cosmetics in a lot of respects as well. So maybe that requires us to take a totally different look at it and have a totally different approach, because I bet you the majority of people that's using them don't view that as drug use. And I would argue that for the majority of people that use iPads, linking them continually and saying, everybody that comes through this door is the same, these are all drug users, is actually quite detrimental, or they would see that as detrimental. We're comfortable with it because this is our field.
Okay, and finally, Willen, anything to add on this one?
Well, I'm as an internist and an endocrinologist, I see a lot of patients who are doing things that are really not good for their health. Think of smoking, too much alcohol, too much eating, little exercise, etc. So actually, we're very used to dealing with patients who somehow have to be guided into doing less the wrong things. And the biggest problem with anabolic steroid abuse is that there is very little experience among doctors about what it really does, how they're using, what they're trying to accomplish. So I really think that we have to try to educate our colleagues and try to be less, there is a big taboo, I think, among my colleagues when working with anabolic steroid abusers. And if we can get rid of the taboo and just handle them as normal patients who are doing things wrong or perhaps could do things better, then we can achieve a lot.
Okay, thank you. And moving on to the next question from April. She says there's been quite a bit of mention of mental health problems resulting from AAS use today, as well as discussion of reluctance to disclose the use to GPs and other medical professions, and low levels of support for targeted iPad or AAS services. So the question she poses is how to address this gap and what are the optimal services and outreach?
Well, maybe I can say something about that, because in Norway in 2013, possession and use of steroids were criminalized. And we have this information service where steroid users can contact us anonymously, and it's flexible and it's free, and they talk to health professionals. And they are really worried about contacting their GP, because they are so afraid of their reporting practices. They even think that since it's illegal, that the GP will call the police or inform their workplace, which is not the case. But that's one really important barrier to contact health services. But I think contacting health services without knowing what you're getting, in a way, if you're entering addiction treatment and you don't know what they're doing, I think it's important to provide information about what we can do and the knowledge we have. So I think, well, I think that could be a way to reach out to users who are worried about contacting health services. And we could be bridging contact with special clinics in the public health system.
Can I add something to that, please? Because in the Netherlands, we do not have the problem that it is illegal to use anabolic steroids, so that should not be a barrier. On the other hand, the most users will not go to their GP simply because they know, or they assume that their GP doesn't really know anything about anabolic steroids. And and I must say that it also is true for most endocrinologists. And so since we have the outpatient clinic in Haarlem, we see that the users, they really know how to find us via mouth-to-mouth communication, via internet, etc. And we have a second clinic now in the southern part of the Netherlands. And I must say that we have a name now among users that we are really interested and know about what they're using and what their problems are. And so I think that helps a lot in lowering the threshold, so to say, for them to come to the doctor.
And any other comments? I should move on to the next question.
Just a really quick one for me would just be to say that I guess picking up on the themes of what we were talking about earlier, but there obviously are loads of really good examples of engagement that lots of people have from their own experiences of running services and how to engage with people using iPads. And so just the more sort of examples of that we can get out into the, I guess, not just academic world, but the non-academic world, and reporting these sort of findings, evaluating how to do that engagement, the better. And that will really help with bridging these gaps.
I think just about 2 minutes left, so time for one last quick question, I think. And Joe's asked a question to Jeff. Is it the case that there are no studies that focus on PSI for steroid and iPad users? I think it would be pretty frequent that BI and MI as a baseline would and is being delivered in NX across the country.
Okay, well, I'm not 100% sure what PSI is. I'm guessing maybe problem-solving interventions, but I apologise, Joe, if I've got that wrong. I think you're absolutely right that these types of interventions, so brief and motivational interventions, are probably quite common, I would have thought. But yeah, he's right that there just isn't the kind of the evidence out there for how they're, in terms of whether they make a difference or not. And that's not to say they don't at all. And we've heard about examples of how these sort of approaches can be effective. And lots of people say that, yeah, that they've, in their experience, they've, people who use steroids will say we've had good experience of receiving these types of interventions. And those delivering services say that they've had good experience delivering them. But by and large, there's not like a big evidence base for us to draw upon.
Okay, and anyone would come in with a quick comment, a final minute now?
Okay, I guess when it comes to setting up services, you need to have some kind of hook. People aren't going to walk through the door for no reason. Now, before that used to be needle and syringe provision. You can get out for so many different outlets now. That's no longer the hook it was. You know, but even through the course of the day, we're almost identifying how to disengage with users in a lot of ways, how to chase users away from your service. And how you would do that is you would use terminology like addict, like drug user, like drug abuser. You would link their use to aggression, to violence, to psychosis. You would tell them they need to be tested for bloodborne viruses, even if there's no sharing going on there at all. Your service wouldn't be flexible. You would say, we're open Monday to Friday, 9 to 5. You want to see us, you fit in with our routine. Where we know the majority of people are actually working, and that's not capable. Sure, we help them make informed decisions, but we would only do that if their informed decisions met our agenda. You know, and that's the problem we have just now. We're setting up a lot of services. We've had over, I don't know, hundreds of visits to the clinic in Glasgow with people best intentions about setting up their own clinic, and it's hardly materialised across the country. And things like opening times are actually one of the barriers, or the kind of continual funding thing that comes up time and time again as well. I think we're at a stage now, if we want people through the door, we need to start thinking outside the box, and we need to do it collectively. And I'm speaking here on behalf of people that use my clinic, I guess.
Okay, I think that's a good point to end this on now. So we just ran over the 4:15 and time finished. So now we've got a 10-minute break, and then we'll reconvene at 4:25 for the fifth and final session, which is afternoon tea with Bill and Joe. So pot the kettle on, get your cake, and see you again in 10 minutes. And thanks again for a great session and Q&A session. Thank you.
Welcome, Bill. Thank you for joining us. We much appreciate it.
Oh.
Let's just crack on, shall we? We're going to have a little chat about some of the things that we've both been experiencing over the last however long, and that kind of leads us into the first area is what your perception is of how things have changed in relation to steroids over the last however long. And that in itself, however, how far do we go is an interesting question.
Yeah, sure. I mean, I would say there's been a slow, steady shift in patterns of usage, right? Going back to when I was first getting interested and involved with this, area of work and research, it was more isolated, not completely, but it was more isolated. And we're going back into, pre-2000, back to the 90s. I don't want to date myself too much, but going back to the early 90s, it was more focused on bodybuilding and athletic use. And it was starting to make its way more into the mainstream, but it still seemed like it was a long way off for that aspect of it. And, since it's been slow and steady, and now you have so many more people using these drugs that are outside of, athletic use, outside of bodybuilding use, or I should say outside of competitive bodybuilding use. And it's more of an aesthetics thing. They want to look and feel better, which I think it was a natural progression for these drugs. They're attractive for that purpose. So we've seen the usage expand. And at the same time, over that same rough time period, we've seen the supply chains shift dramatically to where, decades ago, these were mainly pharmaceutical products that were diverted. There was some counterfeiting at the time, but that's what it largely was, pharmaceuticals, counterfeit versions of pharmaceuticals. And now we have a lot less of those two categories because it doesn't make, the buying focus isn't anymore on pharmaceutical products. Most of the steroids, whether you're in the UK, I'm sure the United States, it's underground products, raw materials that are smuggled in and converted into usable products. So we've had this tremendous shift and acceptance of these underground laboratories, while at the same time pharmaceuticals are becoming less and less prominent in the marketplace, which disincentivizes counterfeiting of the pharmaceutical products. Not that I'm saying there aren't counterfeits out there, but now the business model seems to be a lot more straightforward. Get raw materials, create your own lab, put them on the black market. So those two shifts are a little bit concerning to me because I think you have less and less focus on research before people are using these compounds, more casual use of the drugs, but the supply chain has been degraded quite a lot with these underground products. Sterility is a big concern nowadays. Contamination, what you're actually using. I have a company called Colorimetrics, which makes these roid test kits to do reagent-based analysis of products. So we've been following this for since 2015 when we launched, and even in that time, we see less and less of the more expensive compounds, like say your Anavar is a key one that's counterfeited quite a lot, Primabol and stuff like that, which are much more expensive from raw materials side. They are less prominent in the marketplace now. Those are much more often to be counterfeited with low doses of testosterone and stuff. So you have again big supply issues, and often people aren't even sure what they're using nowadays. So.
And absolutely, you raised a few interesting points there. I want to just go back to the point about timescales. When do you think the tipping point was where actually more people were using for want of a better word, recreational or image type use, when it moved from bodybuilding, when it really moved into the mainstream? How far back do we need to go in America and in other places?
I'm just giving you my estimate. I don't know that there was one watershed moment, right? Like this happened like we had in like the '88 Olympics, right, where steroids suddenly became a focus in mainstream media. I don't think there was a moment like that, but sometime around 2000, give or take, I started seeing a lot more people that didn't fit that previous category of competitive bodybuilder, athlete, what have you. So sometime around there, I think we would see a shift in the demographics. But I'd be curious. Rick Collins has done some study on the demographics before, and I believe he's working on one again. So I'd be curious to see, how that's continuing to change as well.
I think that's fairly similar for here in the UK. I mean, we might have been a little bit behind, maybe 2005, 2007 type sort of area, but absolutely. The other thing I wanted to pick up on was the change from pharma to UGs to underground labs, and
sure.
And all of that's brought with it, because back in the earlier days, underground labs were a dirty word. Nobody wanted to go to an underground. They were horrific, but actually now, some of them, the quality is pretty good, but like you were saying, the untested and the difference in quality is a massive issue.
Sure. I mean, I've seen both. I've been invited to tour laboratories that have that are underground, but they're produced in licensed facilities, often in Asia, where the producers were proud to show off how their products were being made, how they were securing their raw materials, how their product was, and indeed it should be in that kind of facility, sterile, accurately produced. I've seen home brewers that took a serious focus on quality and sterility. And in one case, I had to get dressed up in a bodysuit and wear all this protective gear before I walked into what would loosely be defined as a clean room in somebody's house with positive airflow, and everything was filtered. It was quite impressive to see that, but at the same time, you don't need that to make the end product. So it's they run the gamut. You have a lot of product that's just the production itself introduces bacteria into it, and that's leading to a lot of additional issues. So you do see both, but certainly there are underground products now that are very high quality, and also the market accepts that now. For a long time, I also used to blame prohibition, whether it's criminal penalties on use like we have here, possession, or just prohibition on the supply, diversion from pharmaceutical sources. I used to blame that a lot and say that we need to reinvestigate that, and I do contend that we do need to look at that again, but you can't discount economics, how that's playing in here. I don't think, even if you roll back some of the laws, if you went back to the U.S. back in 1988, in the 80s, where it was criminal but not heavily prosecuted and the penalties were light if you diverted stuff, and that was allowing a lot of it to take place. I don't think if you even went back to that type of a regulatory environment, if it would change, because it's so much more profitable to get raw materials now. And with China, which is the main market for raw materials, being so open and competitive, it just doesn't make sense to pay $50 for a bottle of something diverted from a pharmacy when you can make it for $7 or $10 or $5 on your own. So
absolutely, yeah.
Yeah, so that's the market. That's what the black market is, and I don't see that changing anytime soon.
Ali, so during this time frame of change that we've observed with all the different drugs and all, have you seen a different way in which they are used? Is there we've often had the discussion over here, but between the difference between use and abuse, and are steroids, the more and more it's becoming apparent that there are many dependency markers for the steroid users. Do you see anything similar over there, or?
Well, what I've personally seen, and I tend to think, or maybe it's just me being an old person trying to blame the internet or the new technology, but I've seen the patterns of use get, use and abuses can be defined a lot of different ways. So I don't want to split hairs on that, but usage that's clearly much more abusive is more normalized nowadays. And I've attributed it to people being more open about what they're doing, more bragging when they're using a high dose, and oh, this guy's using 1 gram a week of test. I'm going to use 1.5 grams, and it's just become normalized, these very high doses. Whereas I have people coming to me saying, I'm looking at doing my first cycle. Can you give me your thoughts? This is what I was recommended. It's 2 grams of testosterone, 400 milligrams of trenbolone, and I'm going to take some Anadrol or some D-bol with it. And I'm like, no, I would not recommend this, and I personally would absolutely not do this, especially for somebody first trying anabolic steroids. Just take testosterone alone. At 100 milligrams of testosterone a week, for most people, that's a performance enhancing dose. It's more than your body's going to produce, and when you get to like 200 milligrams, 400 milligrams, that's a formidable amount, especially for somebody that's never used anabolic steroids before. Now, not trying to recommend a cycle for anybody, but if it were me and I had the knowledge that I have now and it were my first cycle, that's what I would be doing, 200, 400 milligrams, and see how that works for 8 weeks. But people today are so much more aggressive when getting into it, and they get recommendations so widely to do this kind of thing. Oh, you want to be big like this person? Well, this is what I think they do. And that concerns me a lot, because they're definitely pushing themselves into a range where side effects are going to be much more prominent, and safety is going to be a greater concern, certainly.
Yeah. I mean, so side effects you mentioned there, what are the main worries for the future use, for the future health implications for our steroid users, and in particular our long-term steroid users?
Yeah, for me, it's about cardiovascular, right? A lot of the side effects that they talk about with anabolic steroids are transient or cosmetic, right? Like gynecomastia, female breast tissue development. That's not really, although maybe some implications of small incidence of breast cancer in men, maybe or maybe not linked to to testosterone excess, but that's a separate issue. So you have a lot of the stuff that we talk about, cosmetics, bloating, acne, stuff like that. That's not really affecting your health in of itself. The changes to the cardiovascular system, especially if you're going to be a long-term user, are definitely concerning for me. They shift cholesterol in an unfavorable direction with your HDL, LDL. Your blood pressure can go up. Your hematocrit can increase, which thickens your blood. The endothelial lining in your vascular system can become a little stiffer, less flexible, which increases risk of cardiovascular incident. So you have a lot of things that shift in regards to all these cardiovascular markers, and then in the short term, they're very unlikely to be an issue. That's one of the things about steroids that's kind of on the one hand, the acute short-term safety is very high of these drugs, which leads people into often a false sense of security. It's the long-term impact of changing these markers that I'm concerned about. And you're starting to see it in some of the data, but it can be hard to tease this out, and we need a lot more study in this area. But you are starting to see that people with a long history of anabolic steroid abuse are more likely to die at a younger age, have cardiovascular issues. And so that's what I'm always trying to drum onto people. When when they think about gyno or water retention and stuff, these are things that they may be able to just tweak with other ancillary drugs that they're using to mitigate these side effects. But the impact on the cardiovascular system is something you really can't escape with these drugs. It happens at fairly low, performance enhancing doses, and it happens very quickly. One of the things I like to talk about in my lectures is there's a study with injectable stanozolol or Winstrol, where they took a single 50 milligram injection, one injection, and they looked at the change in cholesterol a month later. And those that had taken the drug had a substantial impact still a month later from one injection. So, this is something you really can't get away from. There's supplements you could take that can help mitigate it. There's things you could do with your diet that can help mitigate it. Cardio can help mitigate it. But pretty much, no matter what you're doing in that those aspects, it may help, but it's not going to reverse that risk factor.
So do you think we've seen any additional or different risk factors in the current climate, and how has COVID affected all of our users, and if they are still using, are they using more? Are they using less? Well, what do you see in America?
I can't speak to how much in general people are using, but my one data point is the sales that we have from Colorimetrics, which sells the test kits. When COVID first hit, we were actually worried as a company because the first month, around March, when it was really hitting in the media and everything, sales were really quiet. Like everything stopped, and we have other businesses too. It's like everything seemed to be affected. So we were concerned about all aspects of the businesses that we have. But since then, after starting April, it was a steady climb back, and I believe it depends on how things close out with the year, but I believe we may be on pace to have a record year this year with sales. So I think at first people were concerned about spending money. Maybe they weren't spending on cycles. Maybe they weren't spending on the testing. I can't tell you for sure. After, I think people, when there's times of crisis, they do say that people focus on themselves when they can. It's one thing they can control, right? So people putting in their home gyms, figuring out other arrangements to train, focusing on their bodies when other things are more chaotic. So I don't think COVID has had any dramatic reduction in the use of steroids here. If anything, I would probably wager that use may be up a little.
I mean, and I guess I can echo that for over here. We've many areas that have seen an increase in people training at home, like you say, and you've only got to go on eBay and see how much free weights were costing 3 months ago, up to £5 a kilo instead of £1.50. It's absolutely nuts.
Yeah, we've got the same here, home gym equipment. There's a couple things I wanted to get, and I'm just like, we'll wait. But thankfully, I had some equipment before that I've been dragging around from place to place over the years. So basic functioning stuff here, yeah.
So what do we think's around the corner? What's next? We've had lots of predictions historically about SARMs and things. What can we expect to see next?
I'm curious if we're going to see expansion with SARMs in the actual pharmaceutical space. I think that may be coming. The data on these compounds is promising, at least in the aspect of dealing with prostate issues. That is a concern with testosterone supplementation, which, again, abuse, that whole aspect of abuse aside, I think testosterone supplementation in older men that are noticing a decline can be a very important, healthful thing. But with some, there's this concern about excess androgenic activity. These SARMs, some of these really seem to address that. And it did seem that there were a couple on track. So I think that field, whether it's true pharmaceutical products or continuing in research and on the underground, but I think you're going to see more with SARMs. Side note on that, they still have a lot of the same side effects as steroids. They affect your cholesterol. They can increase your liver enzymes. They're not completely devoid of the same side effects. They work by the same receptors. But they're at least promising. I think you're going to see more with that. Now with peptides, I mean, it's now not a problem to synthesize, all these different proteins. We can identify a new protein. We can synthesize it within cells. So you're going to see more expansion on that. The understanding of muscle growth is expanding. It always expands every year. I do work with arachidonic acid, and a couple of the aspects of that, which really weren't talked about before, is that it can increase ribosome biogenesis in your muscle cells, that's the site that the proteins are assembled within the cells. So we find that this is another rate limiting factor in muscle growth, how many ribosome sites you have in your expanding muscle cells. And if it gets to a point where there's not enough, it becomes also inefficient. So maybe we'll see drugs that expand ribosome biogenesis. Another aspect in my work over there is leukocytosis, which is an immune system response, which helps clear damaged cells in your muscles. And also it can instill a little bit of damage to the tissues themselves. So that's an anabolic reaction that we're seeing. We may see some drugs go in there. there's so much open to the future with these drugs. It really comes down to how much more we can learn about how muscle growth is facilitated in the body and how we can tweak that. Myostatin inhibitors, we haven't seen there's been more, I think, speculation and profiteering in that area than actual true, progress, but I think that's coming. I think you're going to see stuff there. So more and more, I think the research areas, and with access to all these peptide manufacturing, we don't have to wait for a drug company to develop something to have access to it. So as the research progresses, the underground chemists, the labs, the online sellers are going to get access to them, and people will do some experimentation on themselves. So I think you're going to see more and more expansion in new drugs. Whether or not they'll ever replace anabolic steroids, that remains to be seen. I don't know.
Hello, everybody, and welcome to the final Q&A session of the day with William Llewellyn and Joe Keane, two of the heavyweights of the anabolic steroid world. We haven't got much time for questions, so I'm going to jump right into them. So questions are for both of you, really. So how much do you think the UGL marketplace has professionalized over the course of both of your careers?
You want to start, Joe? Yep.
Yeah. Well, I think, from our massively. I mean, like we mentioned, we talked a little bit about it in the interview, and I hate to use the phrase "back in the day" because it denotes that I'm getting old and can remember things from a long time ago. But underground labs, that they were a dirty word. The quality was poor. Bill touched again on in the video about the purity of it, actually knowing what you've got in it, all this kind of stuff. The raw materials were harder to get hold of. But nowadays, some of the underground labs are just unbelievably professional and sophisticated. I don't know, Bill. Do you think the same, Bill?
Yeah, definitely. I'd agree with that. I think, again, in the beginning, there was a lot of just scrambling to set up these operations. And over the years, as so much money has flowed into Asia for materials and business relationships have been established, you not only have some facilities that, some labs that have their own facilities to make these products sterile, and get the raw materials that they need from the right pharmaceutical companies. You have a good number of them now that are actually quote contract manufacturers. So you can go to one of these operations and say, I have this, this is the name of my lab. I'm looking to have some product made. Can you produce it on your line? And they operate just like the industry that I'm in here, the sports nutrition industry. It's one of them. That's how a lot of products are made. On the nutrition shelves, you work and engage with a company that does the professional production of it. So it doesn't make sense for most supplement lines, for example, to have their own facilities. It's just not financially feasible. So we go and hire professional companies to produce things, and the same thing is happening now. So again, you still have the terrible homebrew operations that that really do scare me, but you at the same time have more of this happening. So it's interesting how it's been evolving.
How big do you think the scale of production is of UGL production in the US and the UK? I'm talking here about the kind of more established, let's call them branded UGL labs rather than the kind of homebrew thing.
Sure. I think in the US, what you have as far as domestic production is it's almost 100% these small operations. And then when there is the product that's more professionally made, it's often from brands, for example, in Europe, even though maybe the product's made in Asia, the brand is the underground labs in Europe. That's where their operations are, and they send their product to the U.S. and it's often highly regarded. A handful of brands that people specifically look for. But here, given how strict the laws are, most of the production that takes place here is pretty small scale, done in the house kind of thing.
Joe?
I think if you're talking proportionately over here, I mean, I think that we probably use underground labs more than I think than our counterparts in America do. I think just like Bill was just saying there as well. Obviously, there are UG labs that are still actually getting made stuff in some of their stuff in China or abroad, and then sort of importing them in. But I think a lot of our, I wouldn't want to hazard a guess, but I would reckon it would be somewhere between 30 and 40% of everything that is purchased is probably UG these days.
Okay. Do you think the change in legislation in around 2012, particularly around importation, do you think that had an effect in this country?
I know it did. I know of some labs, and you probably did as well. I know of some labs that set up deliberately. So may have been just having an idea about, this is something that we could do. Actually, people are going to be less inclined now to order stuff from abroad now, because I've never heard of anybody actually get done for that after that law change. But actually, it prompted a bit of a rise, I think, in the UK of some new underground labs and some existing ones to expand as well.
Yeah. What do you think of again, a question for both of you. What do you think of the blast and cruise approach?
I mean, my comment on this is, I think that for many people, they view it as a type of cycling and risk reduction. And in theory, when you're blasting, right, your high doses, that's naturally of a higher risk, generally speaking. But to me, I'm traditionalist when it comes to cycling, and I believe that when you have off time, it should not be that cruise time. That dosage that you're using, whatever it is, sometimes it's a couple hundred milligrams of testosterone a week, 100 milligrams, a few, and some people consider a cruise dose 400, 600 milligrams. And that's way in excess of what you would get, even in extreme cases, for natural, for legitimate HRT. And then at the same time, even if you're going down to a legitimate HRT dose, right, you're just supplying your body a normal level of testosterone, which in theory, the risk of that is very low, and it could actually be healthful, just in terms of hormone level management. But you're in a situation where you're not allowing your body to return its normal production. So you're, in essence, on a very long cycle, maybe with changing risk factors depending on what you're doing, but you're still on this really long cycle. And if you decide to come off, many months or years for a good number of people, many years later, when you finally come off, then your body's going to be dealing with having not produced its own sufficient testosterone level for all of that time. So I'm not a fan of it. I think people should traditionally cycle, go off them for at least the amount of time that they're on, preferably even a longer period of time, because that's the time when your body's going to get back to normal. You're going to mitigate some of that risk that you put your body through.
Okay. It would appear as well that just in the UK, sorry to jump in quickly, Martin, is that people that say they're blasting and cruising or use that terminology aren't really blasting and cruising. They're just using constantly.
Yeah.
Yeah. Okay. So we're getting close to the end of the time. Could you give me a wish list of things that you would like to see, developments you'd like to see in the field over the next few years? Could be it policy, practice, research. Imagine you have complete control over it. What would you really want to see first?
I've got one really easy, quick one. Before you move over to Bill, and that is someone actually looking at the Misuse of Drugs Act and actually writing something that's worth the paper that it's written on. It's just ridiculous. It's so archaic and not relevant for today's world. But.
Yeah, the laws here are even more archaic, I think, than you guys are dealing with. I mean, people will do time often for a first possession charge of anabolic steroids. They'll actually go to prison for that. If I could wave a wand and, in my mind, solve this issue, and it's controversial. I really believe that one, you got to, in our country, you got to eliminate criminal penalties just for possessing these drugs. You're making criminals out of a whole category of people that are otherwise law-abiding citizens that are trying to just improve their body and how they feel. I would get rid of that. I would get rid of the law that makes it illegal for a physician to prescribe anabolic steroids for body enhancement purposes. I believe that if we allow cosmetic surgery, which has risks, then why can't we do this and put it under the supervision of a physician that's monitoring the individual? And I think that would eliminate a huge chunk of the people that are doing this on their own at high risk on the black market. And then there's physician oversight, and then the physician has some responsibility for making sure they're not doing ridiculously dangerous things with their patients. And I think most would want to stay in business and keep their license. So to me, that's probably the best solution for something that I think doesn't have an easy solution. But
okay,
yeah,
okay. Thank you very much, both of you. Unfortunately, we're out of time, so I'm going to hand over to Ian Boardley for closing remarks. Thank you, Bill. Thank you, Joe.
Thanks for having me. Thanks for the invite.
And Bill and Joe, another fascinating session there, finishing off. So, yeah, closing remarks on quite a remarkable day, really. Yeah, I'd like to start just by saying thanks to Jim for giving me the opportunity to provide these closing remarks on today's conference. It's been a cracking day, but I thanks to Jim also for his work in putting together this event. I'm sure it's been an enormous amount of work in pulling this together. I'd also like to take this opportunity to thank the sponsors of today's event. Probably can't thank them enough, because obviously without them it wouldn't be possible to hold the conference, certainly not to the standard that we've seen, and also without a registration fee. So special thanks to Exchange Supplies, Orion Medical Supplies and Vernicare for the support that they've offered today. But thanks also to all the speakers as well. I mean, the standard has just been consistently high throughout the day. I think most people will agree with that, or all people, and excellent answers throughout the Q&A sessions as well. So, but also the audience as well. Thanks to the audience. The attendance and engagement throughout the day has been excellent. With the website stream and the YouTube channel, I think we've seen around 300 attendees throughout the day, which is really impressive for a first conference. I'm sure there's going to be much more engagement as people sort of take advantage of the recorded sessions when they're put up on the website soon. Thanks to those who have posted questions as well. That's really helped, obviously, with the quality and the standard of the Q&A sessions. Obviously, it's not been possible to get through all of those questions and get answers to all of them, but there's an aim now for those. Obviously, we've recorded those questions and going to try and get answers to all of those questions out on the website. So look out for those. And also, it's probably worth, if you've not already signed up for the newsletter, if you sign up to the newsletter, then you'll be informed when new materials such as those are being uploaded to the website. There's also going to be a post-conference survey going out to all those that have signed up for the event today. So please try to find a few minutes to complete that so that we can look to make next year's conference even better than today's, if that's possible. But it truly has been a fascinating day, and I just wanted to pick out a few highlights of things that I've seen today, because we really have covered the whole gamut of research on anabolic steroid use today. In session one, I think we had great coverage of the range and extent of harms associated with anabolic steroid use, especially in terms of our understanding how this continues to expand and evolve. And a couple of things that will stick with me, I think, are Harrison Pope's comments about how his appreciation of incomplete recovery of the endocrine system has evolved over time, but also Astrid Bjornbeck's work on the effects of anabolic steroid use on the brain. I think they really highlight how our understanding of the effects of anabolic steroid use continue to evolve, and the importance of ongoing research. In session 2, the importance of understanding environmental influences was covered, obviously with Sue Backhouse's presentation, but also the global relevance was highlighted in that session. I think that session provided a stark reminder for me how we need a targeted research across the globe to build our understanding of how anabolic steroid use globally is an issue, and not just in the more heavily researched sort of westernized nations where we see a lot of the work to date. In session 3, I think we saw how it's imperative to consider and understand specific populations of users through the typologies, for example, and looking at subpopulations and looking to treat and understand subpopulations of steroid users, including female users as well, which was highlighted in that. And I think the importance of adopting a range of different methodological approaches, and in particular qualitative approaches, and the benefits of those were shown in that session, because it helps us, get that depth of understanding of anabolic steroid use that we wouldn't be able to with a purely quantitative approach, and also the importance of making those connections with anabolic steroid people who use anabolic steroids. In session 4, there was great coverage of what we do and don't know about effective treatments for anabolic steroid use, and also provided fascinating insight into the experiences of those who work directly to treat and support people who use anabolic steroids. And in particular, I think John Campbell's presentation demonstrated what can be achieved through services for anabolic steroid users when we get sufficient funding, but also passionate people who are running those services. And then just now, finally, in session 5, I think it was a great way to end the day with that sort of relaxing chat between William Llewellyn and Joe Keane, provided some really interesting perspective on how Bill and Joe have seen anabolic steroid use evolve through the years, and also with some concerning reflections on how they think dosages and cycle lengths seem to have increased overall, especially when people are first using anabolic steroids as well. So just in closing, I think what the day has highlighted is how much we currently don't know as well about anabolic steroid use, and also some of the ongoing research that's seeking to address some of the gaps in knowledge. And hopefully we can hear about the findings from some of this work at next year's conference, which is going to be hosted by the University of Queensland. So who knows, it might even be possible for next year's conference to be an in-person conference rather than the virtual approach today. Although I think most people would agree that today's has been, an excellent success through the virtual medium. So in closing, I'd like to thank all of you again for your attendance and engagement, and I hope to see you all again at next year's conference. Thank you.